Hello, good morning, everyone.
Good morning, sir.
How's everyone doing?
I think everyone's very excited. We're the opening session, sir, for today. So,
Good.
yeah, just waiting for, I think we'll just take 10 more minutes, sir, for everyone to join.
Sure. I just thought I'll casual chit chat before we start. Vikesh sir is there?
I don't think
I
so.
don't think so. So
Right.
okay. So this is the beginning of the conference, also, I suppose.
Yes, sir.
Very good. Chalo. All the best, everyone. See you in some time.
Yes, sir.
Good, good morning.
Good morning, sir. Very
Good
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 morning.
morning,
morning.
sir.
Very good.
Please proceed.
Yes, sir.
Sir, waiting for your opening remarks, Dr. Viswas.
Yes, sir.
They will
One.
announce it. They must have prepared some speech to begin the session. Yeah,
Yes.
eventually.
Yes, sir. A very good morning to all. We at the IAPS team are thrilled to invite you all to join us today for the Abhimanyu Prize session. So, the ethos of this session is to increase the interest among other fields such as MBBS as well as broad specialty PGs, as well as increase their awareness regarding upcoming things in pediatric surgery, as well as the relevance of pediatric surgery to their fields as well as to general fields. So we've had a very exciting response this year with around 36 to 40 papers that have been applied, all of different topics and all of very advanced level of pediatric surgery. So we can see how interest in our field is really picking up. So we have the next 4 hours to go through these papers one by one and learn as well as be taught by these PGs from other departments. So I would like to first invite Professor Biswas to give a few opening remarks. Sir is the current president of the IAPS. He's a retired professor and HOD of NRS Hospital. He is one of the finest senior pediatric surgeons who has adopted modern pediatric surgery very adeptly and timely, and his resounding knowledge and wisdom is extremely popular in all our WhatsApp and social media groups. So I'd like to invite Sir to say a few words.
Thank you, Evangelist. I'm a late riser. I just rose from my bed. I forgot it, though I chalked it in my mind, but I forgot it. So, to all the postgraduates of allied branches which have relation to pediatric surgery, thank you all for joining. So, I am eager to hear you from the nuances of pediatric surgery and different topics. I have gone through the list. It is extremely um hopeful that you are so interested in this. So I think you have joined, and I am going to see some exciting and knowledgeable papers from you. And thank you all. You can start the proceeding. Hello.
I'd like to ask Professor Migliani also to say a few words. Sir is a senior pediatric surgeon who is practicing in Amritsar for almost the past 3 decades. So, one thing about Sir is that he has an amazing sense of humor. In all the conferences, we cannot stop laughing at his jokes. So, Sir's area of interest includes, of course, all areas of pediatric surgery, but I think specifically pediatric hypospadias repair, where Sir is quite a wizard where it comes to these difficult cases. So, Sir, if you would grace us with a few words.
So thank you, Evangeline, for allowing me to say a few words to the youngsters. Well, you all know pediatric surgery is a very young branch of surgery as such.
Right.
We are just 60 years old, and we are still developing. I wonder, few years back, there was talk that pediatric surgery is not doing well, seats are going vacant. What will the country do without pediatric surgeons if the children don't get adequate, optimized treatment from qualified people? What will the country do? So we are a specialty that cannot be dispensed with at any cost. If you have to make a good country, you have to have good pediatric surgeons and in good numbers all over the country, so that any child born with any congenital problem is taken care of, and all the youngsters who are from general surgery, from other allied branches, they should update themselves. Without pediatric surgeons, from our point of view, you are nowhere. No one is nowhere actually. Adult surgeons will also struggle to do certain things which we are doing as a routine. So I wish all the youngsters who are participating today a very enthusiastic participation, and all the best to all the participants. Please start. Thank you.
I would like to call Professor Vikesh sir to give his opening address. So, sir is our secretary of the IAPS. Sir is our guiding light, especially for the youngsters, where he really pushes us to see the boundaries, like things that we had limited ourselves. Sir somehow takes us beyond that, and he's so dynamic and juggles so many things at the same time that he's an inspiration to all the youth to see how much we can achieve. So, sir, if you could say a few words.
Thank you, Evangeline, for your kind introduction. My deepest regard to my presidents and my love to all the juniors sitting here and all the members of IAPS. One word about why this word Abhimanyu. So the concept arise like last year we had discussion with Dr. Ramesh Babu and our president Dr. Biswas, that we should develop something to create interest amongst the broad specialty PGs. So Abhimanyu is the word which believes in like learning right from conception. So I'm very sure that these young PGs, they have shown an immense enthusiasm in submitting papers and working very hard. I saw a few of the PGs, they are working like it last for 4 or 5 days preparing presentations. So this is something which is very striking, and I'm very sure this program is going to be great success. At the same time, I want to mention Here we have young team of organizers here, all young pediatric surgeons under the leadership of Dr. Supraja Subramaniam from Chennai, Dr. Evangeline, she is herself third year PG in ICH Chennai, and Dr. Varsha Totadri, who is an able pediatric surgeon from Bhubaneswar, and Dr. Rohit Harchandani, who is a postgraduate in my own medical college. So I wish you all a great success today. Please proceed with the program. Thank you very much.
Sir, so shall we start with the first session, sir?
Yeah, please proceed.
So I'd like to officially start the first session in our Abhimanyu Prize paper session, which is core pediatric surgery. So we have 9 papers under this session from all over the country. We have 3 judges here who I'd like to introduce, Dr. Sujay Pal, Dr. Nabil Qadri, and Dr. Varsha Todadri. I hope all are present here.
Yep, we are
Yes,
here.
we're
Yes.
here.
So just a few words about our judges so that our youngsters here can know a little bit about them. So Dr. Pal is the secretary of the West Bengal chapter of IAPS, and he's one of the pediatric surgeons who was a crusader in support of many social issues around the country. He's currently employed as an associate professor in a reputed government college in West Bengal. Dr. Nabil is a pediatric urologist and a pediatric renal transplant surgeon. I think sir works in Rainbow Hospital here. He's a mentor and for the subspecialty fellowships after pediatric surgery, I think specifically in urology as well as minimal access in Hyderabad. And Dr. Varsha is an assistant professor in KIMS Bhubaneswar. So, ma'am is one of our leading Yuvacon leaders, one of the young flames of pediatric surgery. So, ma'am loves to travel, loves to interact with all the youngsters around her and inspire all of them to take up pediatric surgery. So, I'd like to invite our 3 judges onto the panel.
Thank you.
Thank you so much.
Thank you so much for the
Our
nice
first
one.
Just tell in
Our,
brief about rules.
Yes, okay. So our rules are we have 4 minutes for discussion and sorry, four minutes for presentation and 2 minutes for discussion. The timer, I will be keeping a stopwatch at my end as well, but I encourage you guys to do the same. I'll put up a reminder in the chat box when you have 1 minute left. Please stick appropriately to time because you will be getting negative marks in case of overshooting time. 2 minutes for discussion will be based on the relevance of your paper to pediatric surgery as well as what implications your paper can give to pediatric surgeons who are currently working in the field. So I think we can start, sir. Is that okay?
Yeah.
Just
Yes, yes.
one request, Evangeline. If you could keep the time, and at the end of the paper, if you can tell us the exact time taken by the participant.
Yes, sir. Sure, sir. Definitely.
Thank you.
Okay, so our first presentation is Dr. Aditya Raj from the Chhatrapati Shivaji Subharti Hospital. I think he's a general surgery PG, and his paper is titled A Myriad of Pediatric Surgery Cases with Challenges in Tier 2 Cities in Western Uttar Pradesh, our experience of 4 years.
Good morning, sir. Should I begin my presentation?
Yes, sir, you can start.
A warm good morning to all of you. Greetings from Shubhati Medical College, Meerut, UP. Myself, Dr. Aditya Raj. The topic of my presentation is myriad of pediatric surgery cases with challenges in Tier 2 cities of Western UP. Our experience of 4 years. Pediatric surgery has a lot of variety, new cases. Pediatric surgery has a lot of variety, rare cases, and a good workload in Western UP. Our college acts as a tertiary care center. Meerut city is a tier 2 city, and patients being referred from almost all of nearby districts. The aim of our study is to determine variety of pediatric surgery cases and challenges being faced by us. Our study is a retrospective observational study performed in the Department of General Surgery for a period of 4 years, from August 2021 to August 2025. A total of 1,730 cases were enrolled in our study. Children since birth up to 15 years of age were included in our study, and children whose data could not be collected were excluded from our study. Data was collected from OPD, IPD, and OT registers. Now, coming to results. Most of our cases are of gastrointestinal tract, hernia, and hemangioma. Urology and oncology cases are relatively less common. Causes may be less diagnosed and missed cases, or oncology cases being referred to Ayurvedic or Unani medicine. We had operated a total number of 20 cases of Hirschsprung's disease, majority modified Duhamel. One SOAV patient lost to follow-up and later came with an anastomotic stricture. One duodenal baby came at 1 month of age with only 1 kg weight. We do not have neonatal cystoscope, so we usually refer posterior urethric valve children if stable. We have a good number of neurosurgery cases thanks to our neurosurgeons who are afraid of kids. We have a number of rare cases like hydrocephalus baby with ruptured urine skull, duplication of tongue, clitoris fibrolipoma, Kaufman syndrome, complicated elsewhere done circumcision, tail gut cyst, rectal prolapse in infants, Currarino syndrome, and giant subcutaneous lymphangioma. Our journey is not without challenges. We face lots of challenges in our daily life. Majority of our patients are from rural areas and are in direct contact with local practitioners and quacks. They sometimes get lost to follow-up, just like our one SOAV patient who came with anastomotic stricture. Tail gut cyst patient never came in follow-up, even for suture removal. Our one patient of ASARP came after 2 months with complete anal stenosis, even after oral and written advice on discharge card. General practitioners, even some pediatricians and gynecologists ask for cut money to send patients to us. No matter how much you explain before surgery, if there is any complication, attendants create chaos. Emerging politicians are deeply rooted in our society, calling and threatening us for decreasing surgery amount or even asking for total waive off at times. Very few radiology centers are good. Twice we have asked radiologists to change report of appendicular perforation with appendicolith. Many times they have missed obstructed hernia. Only one center for investigations like renal scan and Meckel scan. Less amount in Ayushman packages. Lack of teamwork, lacking good and dedicated NICU and PICU teams. Very limited frozen section biopsy centers. Now take home message from us. A pediatric surgeon should be a good radiologist. Feedback of intraoperative findings should be shared with radiologists if intraoperative findings are not matching with the results. Make a good team of pediatric surgeon, radiologist, pathologist, radiology technician, NICU and PICU staff. Camps should be arranged at root level so that we can reach out to maximum number of families. Thank you.
Excellent presentation by Dr. Aditya.
Thank you, sir.
And you have seen so many cases in a entire hospital.
Right.
Have you seen all the cases
Sir,
in your
I have
study?
seen. Sir, I have seen maximum number of cases.
Okay. Have you seen any case of anorectal malformation, male anorectal malformation?
Yes, sir, I have seen a case of anorectal malformation.
How does it present?
Sir, it presents with sir either
Male anorectal malformation.
yes, sir. Either it presents with the child will have a complaint of not passing stool since birth, or will have a complaint of not passing stool since birth, or will have complaints of abdominal distension.
Okay. Initially, what you do in first 24 or 48 hours?
Sir, initially
Have you managed any case in initial stage?
Sorry, sir.
I will not. Have you managed any case in initial stage of arriving this child?
Not initially. We have not managed initially.
Okay, no problem. It's not a problem. And what you have learned from this study?
Sir, what we have learned from this study is like these days, maximum number of residents and surgeons are becoming report oriented. I have mentioned in my study that many a times our reports are also false. So we encourage the residents, PGs, and surgeons to become clinically oriented, not report oriented.
I
This
will
is the major.
differentiate. I will different. What is the difference between a pediatric patient and adult patient? In brief, what you have faced,
Sir,
like anorectal malformation.
in case of anorectal malformation, sir,
Have you seen any initial operative intervention of these patients?
initially we have not. I have not seen, sir.
Okay, no problem.
Okay, sir.
Any further?
Sorry, sir.
Our 2 minutes of discussion are up, sir. Shall we move on to the
Okay.
next presentation?
Please.
Thank you
Yes,
so much,
sir.
sir.
Yes, sir. Thank you, sir. Thank you, Dr. Aditya. You can stop sharing now. I'd like to invite Dr. Garvit Garg from the Netaji Subhash Chandra Bose Medical College in Jabalpur in Madhya Pradesh to present their paper. He's a PG in general surgery, and the paper is on applied anatomy in pediatric surgery, what the PG rotations really taught me.
Sorry, Dr. Evangeline, whether he
Dr.
took the
Garvit, are
right
you?
time? Excuse me.
Yes, sir.
Yes, sir.
I'm here, sir.
He finished exactly in 4 minutes.
Okay. Thank you.
Sir, good morning, sir. Is the screen visible? Am I audible?
Yes, you are.
Yes.
I'll just start the
Okay.
timer. I'll let you to start. You can start now.
Okay, so good morning, one and all. Picking up the learnings from my PG rotational posting of pediatric surgery, here I am, Gurvit Garg, with my incredible journey of seeing key clinical and surgical aspect of applied anatomy in pediatric surgery into action. The
Please
major
switch on your
thing to
video as well,
understand
please, Garvit. Please switch
is yes, sir. The major thing to understand is the children are not a small miniature compressed miniature. Providing them better surgical safety and efficacy is highly depend on the understanding of their age specific anatomical variations. So here I am with few system wise example to enhance our understanding of the pivotal role applied anatomy play in pediatric surgery. Looking at the pediatric airway, I was astonished when I saw that how large tongue, small layers, long floppy omega-shaped epiglottis, funnel-shaped high and anteriorly placed larynx not only makes the intubation difficult, but also makes the airway more prone to obstruction and edema. Over to this, the diaphragmatic breathing pattern, more compliant for floppy chest wall, and overall inefficient breathing mechanism makes them more vulnerable to respiratory failure. But I also got amazed when I saw that how using microcurved tubes, which are low pressure, high volume tubes, video laryngoscopy, laryngeal mask airway, and post intubation care as use of steroids and nebulization with epinephrine, overall minimal manipulation can prevent such complications. If we look at pediatric abdomen, I witnessed how disproportionately enlarged liver covering the stomach make gastrostomy difficult. Poorly developed omentum allow rapid spread of peritonitis. Thin and weak abdominal wall makes them more prone to abdominal wall hernia. And how crucial it is to remember that urinary bladder is intraperitoneal in children. I also got surprised by seeing that how retraction using hitch suture during pelvic and biliary surgery plays a great role of coinoid classification in hepatectomy, and how just a small caution of lateral laparoscopic port placement can avoid injury to inferior epigastric artery and can prevent a big hazard. I saw how patent processes vaginalis make them more prone to inguinal hernia, and how the superior and lateral placed ureter leading to VUR, which taught me the clinical significance of Pequin law. And the Wiggett-Meyer law in duplex ureter shows up how predictive anatomy can help surgical decision making and surgical actions. Here we can see how vascular anatomy, such as rich blood supply in upper esophagus, determines the possibility of mobilization compared to the lower segmental pouch. With a small stomach, having all the small stomach, but how beautifully the gastric tube can be reconstructed in gastric pull-up, and how we have to be cautious while mobilizing the colon in colonic pull-up. Another fascinating example from head and neck is of second branchial cyst, which usually lies between external carotid artery and internal carotid artery to the tonsillar fossa. Similarly, in thyroglossal cyst, in cystant operation, we excise the segment of hyoid bone for this benign disease. So with all this example, I want to conclude that my biggest takeaway mantra is anatomy is function. It's not about the size, it's about the physics and how vascular anatomy and embryology can pave the way for better surgical outcome. So knowing this tiny fragile differences that makes the all differences. Thank you.
Dr. Nabil, do you have any question for
Very well
Dr. Garg?
presented. He also has a good mentor along with him.
Yes.
So, Gavit Garg, you are final year PG now?
Yes, sir. Just completed my second year. I have entered into the final year PG.
So, have you rotated in your pediatric surgery postings?
Yes, sir. Twice. Twice. It happened twice.
Twice. That's good.
Yes,
What
sir.
is the one case which really, I would say, would make you want to take pediatric surgery? Any one case, any instant you remember from your posting?
Uh,
Not even
so
case. I mean, anything, any instance from your posting. Yeah.
Yeah, so tracheoesophageal fistulas are very commonly presenting, and doing tracheoesophageal, even the anorectal malformation, and even, sir, in our institute, urethral reconstruction are very commonly happening, sir. Even, sir, the laparotomies also in patients, intussusception, and all these cases are very fascinating to see, and seeing the outcome in the patients as well as the happiness of the parents. So this is all. This is the currency, I think.
Would you say
The
your general surgery skills have improved after pediatric surgery posting?
uh, but I must say that observations, because I got different anatomical approach. So the observations of the anatomical part and its role in clinical application. So after pediatric surgery, that was a different experience, which I implied into the general surgery part also.
Good, good. Thank you.
Very nice.
Dr. Sujay, Dr. Varsha?
Very nice presentation, Dr. Garvit. I'm going to ask you a very
Thank you, ma'am.
controversial question. Do you see yourself becoming a pediatric surgeon? You have just another year and a half to go, I'm guessing, after
Ma'am,
this experience.
I can see the possibility because I got very keenly interested in it, but I have options and I have an exam to clear. So I would prepare myself well and appear for it. And surely pediatric surgery is an option with me,
Okay.
into
Great
which I am
present.
interested.
I think
Good
that's
to
all
hear.
we have time for today. Thank you, Dr. Garvit. You can stop
Thank you.
sharing the screen now. We'll move on to the next presentation. I'd like to call Dr. Dharani. She is a radio diagnosis postgraduate from the Kovai Medical Center and Hospitals in Coimbatore. And she's here to present her paper on detecting the twist, prenatal diagnosis and management of fetal intestinal volvulus with ischemia. Dr. Dharani, we'd also like to encourage you to switch on your video so that the judges can see you. Yes, thank you. Okay. Are you ready to start?
Unmute yourself.
I think Evangeline, you have to give her permission to unmute herself.
No. Um,
Can the moderators unmute her?
Yes, yes. Am I audible now?
yes.
Good morning, all. Shall I start?
Yes, please.
I'm Dr. Dharni, radio diagnosis resident from Kobe Medical Center and Hospital, under the guidance of Dr. Kumaran, consultant pediatric surgery, and Sumati, doctor, consultant fetal radiologist. Today, I'll be presenting a case titled From Womb to OR, Detecting the Twist. Let's see this case. This is a case of a 22-year-old primigravida with no antenatal high-risk factors. She presented at 35 weeks of gestation with absent fetal movements for 24 hours. Her routine obstetric scans were unremarkable throughout pregnancy. So we were ordered an fetal ultrasound. In fetal ultrasound, it revealed there were grossly dilated fetal bowel loops with some heteroechoic contents seen within the bowel loops. Could it be hemorrhage also? And some minimal ascites was seen. Due to the advanced gestational age, differentiation between small and large bowel loops could not be made. We also would like to rule out the cause of dilatation, so we checked out for the SMA-SME axis, but it was found out to be normal in this patient. So to summarize, we have a primigravida at 35 weeks with absent fetal movements. Her routine scans were unremarkable. Ultrasound revealed grossly dilated bowel loops, heterogeneous contents within, probably hemorrhage and minimal ascites. The axis was also found to be normal. So what's next? What is the cause of the dilatation of bowel loops? Here comes the problem solver, the fetal MRI. Let's see. These are the T1 and T2 weighted images in which we can see the usually the large bowel loops will contain meconium, which will appear bright on T1 and dark on T2. Hence, the large bowel loops were normal in this case. So the dilated bowel loops were small bowel loops. Also, we can see in this image there is shading present within the loops, which indicates the supernatant fluid and the dependent echogenic contents. On further gradient sequence, we can see the dark contents within the bowel loops, which indicates hemorrhage. Hence, the blood was present within the bowel loops. In this image, we can see twisting of the bowel loops along with its mesentery, which indicates the whirlpool sign, which diagnoses the condition, which is volvulus. Hence, we made out the diagnosis, which is fetal midgut volvulus with ischemia. On an emergency cesarean section was performed based on the diagnosis, and on delivery, the unit had a distended abdomen, meconium stained liquor, and a weak cry requiring intubation. The patient was taken for emergency laparotomy, which revealed dilated gangrenous bowel loops with volvulus without any associated signs of malrotation, which we also detected antenatally. Resection of necrotic segments was performed, followed by Bishop Cook jejunostomy. About Bishop Cook jejunostomy, it is a surgical procedure used to manage intestinal obstruction by creating a continuous single lumen ostomy where the distal bowel is exteriorized to decompose the proximal bowel. This ostomy in continuity allows for distal bowel decompression and can be used to test distal bowel function before definitive closure, minimizing complications associated with bowel anastomosis. On follow-up, the post-operative recovery was uneventful. The child gained weight appropriately and at 1 year of age underwent successful jejunostomy closure with restored bowel continuity. So my take-home messages will be fetal intestinal volvulus is itself a rare condition that can lead to bowel necrosis and hemorrhage and requires urgent surgical treatment. Antenatal diagnosis of fetal volvulus is primarily ultrasound-based, though signs may be subtle. The soft tissue characterization with MRI helped us to arrive at the diagnosis of midgut volvulus with possible ischemia and necrosis. Hence, a low threshold to be kept for the application of fetal MRI when needed. MRI speaks when ultrasound whispers. Management depends on gestational age. Early recognition and referral to tertiary centers enhance prognosis through multidisciplinary care. These are my references, and thank you.
Thank you, Dharni.
Yes, ma'am.
Excellent presentation by Dr. Dharni.
Thank
You
you,
have
sir.
seen, as you know, in pediatric surgery, radiology, our help of radiology is very much important.
Yes, sir.
Many of times, the residents always do the radiology before we do the active intervention of that child. So your patient was a case of midgut volvulus
Without any malrotation, yes, sir.
without any malrotation.
Oh.
So what are the malrotation signs you see in your USC ultrasonography?
In ultrasound, usually we will look for the SMA SMV axis, sir. The SMV will be to the right of SMA. In cases of mal rotation, it will be mal rotated. So A will be to the right of SME, sir. And twisting of the mesentery will appear as a whirlpool sign, which I showed in this case.
Any question, Dr. Bharsha?
Great presentation, Dr. Dharni. Just wanted to ask, what other differential diagnosis would you have considered in this child based on your ultrasound findings, your primary
Okay.
ultrasound findings that you had mentioned?
This child had a form of bowel obstruction, but the antenatal scans were normal. But if it is abnormal, it could be due to atresia of the bowel loops, and could be due to meconium ileus with obstruction, or it could be due to the malrotation of the SME axis causing volvulus. And these are the differentials I would like to rule out, ma'am.
Oh, okay. Thank you. Dr. Nabil, sir, and Dr. Sujay, sir, any other questions
No,
from your side?
wonderful presentation, Dharani. One doubt which I had: what is the gold standard test for malrotation?
Malrotation we can detect by antenatal ultrasound, sir, but since due to the advanced gestational age, we couldn't catch up the twisting of the bowel loops, and also we couldn't differentiate between the small and large bowel loops because the abdomen was grossly distended and mild ascites was there.
Let me rephrase my question. What is the gold
No.
standard postnatally?
Postnatally, we will do only ultrasound for the baby, sir.
So that is one thing. I don't think I would agree with you there. I think the gold standard for malrotation is always an upper GI contrast.
Okay, sir.
USG Doppler study and upper GI contrast study.
Yes, these two will do. I mean, many times we have there's an routine ultrasound. We find a SME axis twisting. This relation is inverted. Then we proceed with definitely an upper GI
Upper
contrast
G, yes, yes,
to upper GI contrast is the gold standard.
Yes.
yes, sir.
Okay.
Thank you.
Yeah. Thank you so much.
We'll move on to our fourth presentation of the day. I'd like to call on Dr. Adyar Prashant, who's a pediatric postgraduate from Mehta Multi-Specialty Hospitals in Chennai. And his paper is titled An India's Foreign Body Turning into Jeopardy. Dr. Aditya? Dr. Adyar. Yes, okay. Dr. Adyar, I'd also like to encourage you to turn on your video so that the judges can interact with you directly.
In the meantime, good morning, our editor-in-chief, Professor Rashik Shah, sir. Editor-in-chief of Journal of IAPS is also present.
Yeah, thank you.
Yes, good morning, sir.
Good
Good morning, sir.
Good morning,
Continue.
Rafik.
I'm listening.
Dr. Adyar, we can't hear you either. We're not able to see your video either. No, your slides are working fine, but we're not able to hear you or see you.
I think imagine you will have to unmute him. I think the same problem with the
He's
last speaker.
unmuted, sir. He's
Okay,
unmuted,
okay.
actually.
All
But
right,
I'm not
thank you.
able to-
You just mute and then unmute.
Dr. Adyar, if you're having any issue, you can also put it in the chat box so that we can help you out. We're not able to see you or hear you.
Dr. Adyar, turn your camera on, please. It's off. Video on.
Dr. Adyar, are you able to hear us? As we're not getting a response from you.
I think you can move on to the next
Yeah,
presentation while
I
she
think,
Yes.
arrange.
yeah, let's move on to the next
Yes.
presentation. We can come back to Dr. Adia.
Okay, sir. Okay. Then, Dr. Adia, can you stop sharing, please? We'll come back to you once the technical issues are sorted out. Yeah, thank you. Okay, then we'll move on to the next presentation. That is number 5, judges to note. Dr. Deepika Rathinam, again from the Kovai Medical Center and Hospital in Coimbatore. She's a radio diagnosis postgraduate, and her paper is titled The Vanishing Blood, Baby's Blood Secret. Dr. Deepika, are you there? Yeah.
She needs to be unmuted too.
Deepika, could you unmute? You can unmute yourself.
Okay. Can you
Yeah.
now
Yes.
see
Yeah,
my screen, ma'am?
no, we can hear you, but your presentation is not up.
No?
Share the slide.
You can
You can share your screen otherwise and play the slide on that in case the slide share option is not working.
Can you now see my screen, ma'am?
We can see you.
No, we can see you. We can see you, your presentation. So there's a little green button at the bottom of your screen which says share. If you click on that, you can share your screen.
Okay. Can you see, ma'am?
Yes, yes, we can. 1 minute, I
Okay.
will just set up the timer.
Okay, ma'am.
Yes, you can start.
Good morning. This is Dr. Deepika from Kovai Medical Center and Hospital. I will be presenting on the vanishing blood, baby's blood secret. Here, a 6-week-old male baby presented with history of blood and stool for past 10 days and abdominal distension and decreased urine output. Birth history was unremarkable as vital was tachycardic, but abdomen was soft and distended. Initial laboratory investigation revealed anemia and thrombocytopenia with platelet of around only 8,000. This combination of anemia and thrombocytopenia, which is bicytopenia, has led us to a broad differentials of either a bone marrow suppression or infiltrative disorder, congenital infections, and peripheral causes of destruction. USG abdomen performed showed mild GB wall edema and mild diffuse edema of the small bowel loops. Neurosonogram performed to rule out intracranial bleed was perfectly normal. Other investigations like Coombs test, PT, INR, urine routine, immunoglobulins, and the infectious torch infectious profiles came out to be negative. Peripheral smear and bone marrow aspiration also showed there is no evidence of any atypical cells. In fact, it actually showed increased megakaryocytes and erythroid hypoplasia, which means that the baby is actually producing its own platelet and then RBC. Because of persistent anemia and thrombocytopenia, one platelet concentrate and OPRBC transfusion was done. On the day of transfusion, you can see the rise in the platelet and the hemoglobin level, but on the very next day, there is a decreasing trend of the counts. So differentials now we got will be the peripheral causes of destructions, ruling out the other causes. In this meantime, the baby had low-grade fever with one episode of vomiting. CCT abdomen showed edematous ileal loops and also mesentery appears congested and hyperenhancement. With this, we came to the differentials of lymphoproliferative disorder or either any infiltrative disorders. But because the baby had cytopenia and remained refractory to treatment in spite of multiple platelet transfusions and also baby had continuous biliary aspirates, we have to involve the pediatric surgeon for diagnostic laparoscopy for mesenteric biopsy. Laparoscopy showed dusky bubble. This dusky bubble, because of the dusky bubble, we converted laparoscopy to laparotomy. Bubble actually felt like a pipe stem or rubbery consistency, which is more in favor of the gangrenous bubble. Surprisingly, we also saw retroperitoneal mass, but this mass started shrinking as it was oozing once we mobilized the right colon, which is nothing but the retroperitoneal hemorrhage. We proceeded with the laparotomy with the resection of ileum and ileostomies. Surprisingly, after the surgery, you can see the increasing trend of the platelet platelet and the hemoglobin level on the immediate post-op and the POD 1 and 2. So on the post-op day 3, we saw a parastromal mass noted arising from the omental tissue and it also excised and sent for biopsy. Interestingly, biopsy report came out to be diffuse hemangiomatosis of the mesentery and the bubble wall with the omentum as the same hemangiomatosis. So this is nothing but the non-hereditary multifocal vascular anomaly involving multiple layers of the bubble wall and the mesentery. But because of the disorganized proliferation of the vascular channels and the adherence of the platelet to the endothelial surface and the continuous consumption of the clotting factors, we get the thrombocytopenia anemia as in this baby, which is nothing but the Kasabach-Merritt phenomenon. So this baby was diagnosed with hemangiomatosis of the bubble and mesentery complicated by Kasabach-Merritt phenomenon. Though our case was a surgical rescue, but the future of the disease is changing. The primary next generation impact has moved towards the targeted pharmacological therapy. So this baby was started on the sirolimus, which is the mTOR inhibitors, which actually inhibit the growth of the vascular tumors. So this baby was started on sirolimus for a period of 6 weeks and then converted to the propranolol. On the follow-up, the baby's count was absolutely normal. The baby was stable. So my take-home points here will be the suspect Kasabach-Merritt phenomenon and refractory cytopenia. Also, the risk of hemorrhage is extreme. Be prepared for the intraoperative hemorrhage. The targeted pharmacological therapy is the revolutionizing management. Sirolimus is a promising treatment modality and innovative treatment option for unresectable vascular anomalies and also for the treatment of conventional therapy. And this is my references. Thank you. Thank you.
Thank you. Dr. Sujay, Dr. Varsha?
Yes. Yes, it was a rare case and you have experienced it. That is very good. And I think it will, you can if in any journal as case report, it will be accepted. I hope so. But I just want to know, other than anemia, you have not seen any other clinical features like melena or bleeding?
Yes, sir.
Printer technology. Otherwise, would have given a jig and done a hemicortical section.
So sorry, sir, I can get it. Oh.
Did you get any other clinical features other than anemia?
Yes, it's a baby had blood and stools of the presentation for past 2 days when baby came for OPD.
Okay.
But the stool occult that done at that time, the sampling at that time came out to be negative. So.
Okay, Dr. Nabil, any other questions?
Yeah, good presentation. Just one thing. I think you were a little fast, Deepika, but that's okay.
Yes.
I would like to congratulate Dr. Kumaran also. He has got 2 of his allied specialty people with us. One question to you, Deepika. What are the prerequisites before you start sirolimus?
It's a hemangiomatosis. If you suspect hemangiomatosis and all the profiles are normal, so we'll start with the sirolimus.
Sorry, can you say again?
If you suspect hemangiomatosis, it is actually before we used to have a propranolol as the first line treatment, but because of the evolving, we proceeded with
No,
sirolimus.
my question is very specific. What are the prerequisite tests you have to do before starting sirolimus? No, okay. You have to have a LFT and a lipid profile before starting any kind of sirolimus. This is the baseline which you have to do.
Okay, sir. Thank you.
Varsha?
Great presentation, Deepika. Do you know any other medications that have been used or are in use in centers for Kasabach-Merritt syndrome in the past? Any other apart from sirolimus, which you've highlighted?
Methylprednisolone would be using, ma'am, for
Okay.
suppressing actions.
Okay, yeah.
Then
Some
propranolol.
propranolol more for, yeah, definitely. But apart from that, there have been few studies where vincristine has also been tried. And like you're saying, steroids, IV steroids have been given as well. So great presentation. And congrats to Dr. Kumran sir for his for the guidance to the residents.
Thank you.
Thank you.
So we'll move on with the 6th presentation. Dr. Nishu Bala from GMC Amritsar, who's a radio diagnosis postgraduate, who's here to present her case of a rare case of congenital mesenteric lymphangiomatosis in a neonate. Dr. Nishu, you can unmute yourself and also start your video.
Good morning, everyone.
Good morning.
Dr. Nishu, is your video
Please
on?
start. Make
Yes,
it in
ma'am.
a slideshow.
Yes. Okay, I'm just, you can put it on slideshow. Meanwhile, I'll start the timer. Dr. Nishu, you can put your presentation on slideshow. Dr. Nishu, are you able to hear me?
Yes, ma'am. Yes, ma'am. I can hear you.
Yeah, just you can put it up on slideshow using the icon at the bottom, right? Dr. Nishu, any issues from your side? Is your screen frozen or something?
No, ma'am. I'm not able to share the screen PPT.
No, your PPT is
Your
seen.
PPT is seen.
Just that,
Okay, it's seen.
not on
Okay.
slideshow. Yeah, it's not on
Okay.
slideshow. That's the issue.
How I can do it on slideshow?
So there'll be a bottom right.
This one?
There'll be an icon. Yeah. Or another option is on the top in your tools box, there is a box which says slideshow, right? On the top, next to animation.
Dr. Nishu, on your screen that you're showing, right? You can see the tabs on top. That is, or you can follow the advice. You can press F5. It will go into slideshow.
There
Function
is
5.
some orange box that she need to remove. Then only she can see that slideshow
Yes.
option.
Your 360 total security needs to be removed. Yes.
Yeah.
So
So now you will see that.
You'll be able to see the slideshow option there. The play
there's a little
option.
orange button, yeah, with the play icon on it.
Or you can press function 5 on your keyboard.
Not working, ma'am.
No. So can you try pressing the icon, please, at the bottom of your screen? That orange button, just above, just above. No, not that one. Above that. So you can see notes, comment, and all that, right? At the bottom.
Yes, ma'am. Yes, ma'am.
Yeah.
Yes.
So in that same thing, if you move towards the right, you can see an orange button with a play symbol.
On the whites.
Move your cursor up, Dr. Nishu. Can you see notes, comment, and then multiple small pictorial icons?
I suggest you run like this only. It doesn't matter much. You run on this only.
Okay, Dr. Nisha, are you comfortable this? Is it okay?
Just wait a minute. Just wait. No, I'm not able to share.
No, you have shared your screen. Don't worry, don't get tense. So where your cursor was now previously, just move up. Just move up. Yeah. So no. You're fine. You're fine. There
Now
is
my
a
screen is visible.
your screen is always been visible. Okay. So don't worry
Now it's
about
changing my slides also.
Yes,
your
it's seen.
Your slides are also changing. You can go back to your first slide, right?
Okay.
Yes.
Okay.
Now keep your cursor there. All right. Just go to the top where it says home.
Yes, yeah, this one.
Yeah.
No,
Home,
no.
insert,
You got
design,
it wrong.
transition, that part. You can click on slideshow. Slideshow there along the
Okay.
right. Yes.
Okay.
Yes. From the beginning. Correct. From the beginning. It says from the beginning. On top, it says from the beginning. Dr. Nishu, on your top left.
Hanji. Yeah, this one. Okay.
below the
Sorry.
file.
Yes, you've got it.
Okay.
You've got it.
Okay.
Super.
Sorry for that.
No problem. No
No,
problem.
no
So
problem.
we'll start your timer. All right.
Hmm.
Yeah, you
Okay.
can start.
Good morning, everyone. Myself, Dr. Nishu from GMC Amritsar. I am going to present a rare case of congenital mesenteric lymphangiomatosis in a neonate. Mesenteric lymphangiomatosis is an extremely uncommon disorder of a malformation of a lymphatic disorder. Although it can manifest at any age, its recurrence in the neonate is extremely rare. Incidence is only 1 to per 250,000 cases. No gender prediction or family association. Although its prescribed etiology remain unclear, the predominance of the case in the pediatric population suggests a congenital abnormality of the lymphatic system as the likely cause. Early diagnosis and management are the crucial to prevent the complication like the bowel obstruction and to ensure the better outcomes. We have a 16-day-old male neonate was brought to the hospital with progressively worsening abdominal distension since birth. The parents also reported reduced feeding and the fever. There is no history of any other systemic symptoms. The baby was delivered at full term with obstructed labor. On physical examination, the abdomen was visibly distended, soft to touch, no tenderness and no palpable mass. No hepatosplenomegaly and other abnormality are observed. On lab investigation, there is a deranged LFT, there is increase in OTPT, LAP, and the serum bilirubin decrease in the serum protein. The total ionized calcium was also decreased. Other electrolytes are normal. C-reactive proteins were raised. CBC are deranged and LFT was normal. On X-ray, we will find that there is no abnormal air fluid level, which rule out any abdominal obstruction. There is no any abnormal calcification, which rule out any abdominal mass. On ultrasound, there is a massive amount of fluid with dense internal echoes and septation in the peritoneal cavity. There is no bowel loops are dilated, which rule out the intestinal obstruction. On CECT, there is a massive amount of fluid with internal thick enhancing septations. There is formation of the cyst in the mesentery, also noted in the CECT. On the treatment, the neonate underwent exploratory laparotomy due to the progressive abdominal massive abdominal swelling and feeding intolerance. During the surgery, there is a several cystic masses are seen attached to the mesentery. These cystic masses contain the chylous fluid and they are blood stained. On the histopath examination, there is show the tissue systole in the form of the connective tissue and the smooth muscle infiltration and the lymphocytes and the blood vessels supporting the diagnosis of the mesenteric lymphangiomatosis. The neonate was relieved of the symptoms and was discharged in stable conditions 7 days after the surgery. The congenital mesenteric lymphangiomatosis is a rare developmental anomaly of a lymphatic system involving the mesentery and may present in the neonate period with no specific symptoms in the form of the tenderness and abdominal distension. The CT scan revealed the massive amount of fluid with internal thick enhancing septation, well demarcated multiloculated cystic lesion in the mesentery. A laparotomy and histopath examination were performed and diagnosed as mesenteric lymphangiomatosis. The measurement of the lymphangioma in the children is challenging due to the difficulty in achieving the complete resection and the high recurrence rate. Macroscopic excision has a fewer recurrence while the aspiration show the highest. Observation may aid in planning complete excision, though complete spontaneous regression was rare. So we concluded that congenital mesenteric lymphangiomatosis, though rare in the neonate, should be considered in the case of the unexplained abdominal distension, which pose the non-specific symptoms, and the imaging modality like ultrasound and CT scan are the vital for diagnosis and extent of the disease. The surgical resection remains the treatment of choice for symptomatic cases, with histology confirming the diagnosis. Complete resection significantly reduce the recurrence risk. Early detection, timely surgical intervention can lead to the favorable outcomes. Regular follow-up is necessary to monitor for recurrence or complications. Thank you.
Finished 30 seconds in advance, so we can carry over the time for discussion.
Thank you, Dr. Nishu.
Thank you, sir.
Excellent presentation and excellent case. I just want to know, you have diagnosed it by ultrasonography, X-ray, and CT scan.
So we just suspected by CT scan. On the ultrasound, there is just the massive amount of fluid with the internal septation, which can be the any type of the complicated complex ascites it is. And on CCT, we also see that there is a complex ascites and there is some cystic lesion, multiloculated cystic lesion adherent to the mesentery, but it's not diagnosed on the CCT itself. It is diagnosed post-operatively on histopath examination. During the surgery, surgeon also suspected that there can be the mesenteric lymphangiomatosis, but it confirmed after the histopath examination.
I just want to know what are the differential diagnoses from the clinical feature you can assess other than any radio diagnosis.
So it can be so it can be a mesenteric cyst, foregut duplication cyst.
Yes.
If it's a female patient, it can be ovarian cyst, urinoma, well, any cyst which contain the chylous fluid, or we can suspect that physically because it is adherent to the mesentery and it is no continuation with the gut, and there is a no gut signature as such, so we rule out the foregut duplication cyst.
Okay, any other thing? Especially in the child, I think it is a neonate. No?
Yes, sir.
We heard about the cystic teratoma.
Yes, sir. Cystic teratoma. Yeah.
Okay. Thank you, Dr. Nabi. Over to you and Dr. Varsha.
Thank you, sir. Thank you, sir. Thank you so much.
Good presentation. A little fast. And one more thing, just one advice I would like to give you. You don't have to read out every single line when we are talking. You can skip a few which are it's not a competition of reading the slides. So you can make that in the next one. Varsha, over to you.
Okay. Thank you, sir.
Nice presentation. Again, quite a rare thing. Like Sir pointed out, the slower you go, we can also follow it better and you'll feel more comfortable, like a conversation. Do you know anything about if there is a recurrence in such a case, what would be the preferred mode of management in that? And is there therapy is a very common thing. Do you think there is a role, or are you aware if there's a role of the same in this kind of a case in mesenteric lymphangioma?
I think she is from radio diagnosis.
Oh, I'm so sorry then. Okay, all right. But nothing else then from my side. It's a great presentation. But
I think in the management part, which I know, there is a recurrence is very common in the mesenteric lymphangiomatosis. Like we did in this case, there is we just incise, punctured and excision is done. So the recurrence is most common in the cause in this case. But the sclerotherapy, okay, 37, I think some sclerotherapy drugs are there which can help in the treatment also.
Right. Thank you so much.
Thank you,
Over
Dr.
to
Nishu.
the
Yeah. Thank you, Dr. Nishu. You can stop sharing your screen now.
Thank you.
Yeah. So we'll move on to the next presentation, which is the 7th on our list. Dr. Madhumita B. from the ESI Medical College and Super Speciality Hospital in Hyderabad. She's a radio diagnosis postgraduate, and her paper is titled From the Womb into the World, a collaborative journey of the fetal radiologist and the pediatric surgeon. Dr. Nishu, you can stop sharing your screen. Yes, thank you. Dr. Madhumita, you can start now.
Yes, ma'am. I'm not getting any share options.
There is a little green button at the bottom which says share on your Zoom screen. Yeah, you can use that and share your presentation. Yes, you can put that up on slideshow mode.
Yes, ma'am.
Yes. Are you ready to start?
Yes, ma'am.
Okay,
Good
your
morning.
time.
Yes, ma'am. Good morning. Let me take you through a collaborative journey of the fetus from the womb into the world. So, we are going to, our aim is to evaluate the antenatally detected congenital birth defects on ultrasound and correlate them with the fetal MRI, postnatal evaluation, and autopsy correlation, and also highlight the importance of a multidisciplinary team. This was a collaborative workflow followed in our institute, where we do a detailed fetal ultrasound describing the defect, looking for the prognostic factor and associated findings. We advise additional imaging findings like fetal MRI and genetic counseling whenever indicated, followed by a multidisciplinary team care involving the concerned specialties and parental counseling. This enables the parents to make an informed choice and help them to decide whether they opt for continuation of pregnancy or termination of pregnancy, which act like two sides of the coin. And we have to offer compassionate counseling and support either ways. A retrospective analytical study was done over a period of 12 months in our center, and we had about 112 cases identified with birth defects. We have excluded intracardiac echogenic foci and mild pelvic ectasia from our study, and majority of the anomalies were fitting under the genitourinary, gastrointestinal, central nervous system, and cardiovascular anomalies. We had a wide spectrum of anomalies ranging from simple pelvic cyst to hydronephrosis to dysplastic kidneys to a wide range of malformations. Let me take you through few case scenarios. This was a 32 weeks ultrasound showing the herniation of bowel loop into the left hemithorax with polyhydramnios also, but the LHR was more than 1.4 with favorable prognosis. And she delivered at 36 weeks of gestation, electively intubated at birth, and day 2 of life, minimally invasive thoracoscopic repair of the posterolateral defect was done and was discharged on day 9 of life. Similarly, we will be seeing multiple instances throughout the day where the pediatric surgeon plays an important role as a corrective interventionist. Let me take you through few scenarios where there will be a different load paid by the pediatric surgeons. This is an 18-weeker with multiple birth defects noted on ultrasound. She opted for termination of pregnancy, and fetal autopsy was done with the external examination and radiographic examination showing the imperforate anus, underdeveloped pelvic bones, maloriented limbs with club foot, club hand, omphaloceal, ectopia cordis, short umbilical cord. You can see the myelomeningocele. There was gross hydronephrosis and kyphoscoliotic deformity fitting under the pentrology of Cantrell OEIS complex. This was another case with the open neural tube defect with myelomeningocele and carry-to malformation. This was another case of non-immune fetal hydrops terminated at 24 weeks of gestation with ascites, cardiomegaly, congestive hepatomegaly, pericardial pleural effusion. This was another case terminated at 22 weeks of gestation. The fetal autopsy shows typical features like hypothyroidism, median cleft lip palate, dysplastic ear lobule, lobar holoprosencephaly, cystic dysplastic kidneys, complex cardiac anomaly fitting under the phenotypic diagnosis of trisomy 13. This was another case terminated at 20 weeks in case of anhydramnios with small dysplastic kidneys, and this was a typical Bottas facies. So to conclude, perinatal autopsy when performed by the radiologist, pediatric surgeon, and the pathologist together seems to benefit all of us and opens doors for a collaborative learning, which is similar to the multidisciplinary team review meets, which all form an important part in the fetal care. So the key take-home points are early antenatal detection with multidisciplinary care is important to optimize perinatal outcomes. Good communicative skills with compassionate counseling is essential. And perinatal autopsy and multidisciplinary team review meets provide continuous learning opportunities for us to join hands for a unified vision for the child and family. Thank you for providing me this wonderful opportunity. Thank you.
Thank you, Dr. Madhumita. It was a wonderful work, wonderful work.
Yes, sir. Thank you, sir.
In India, not much institution does the same, like
Yes, sir.
autopsy and antenatal diagnosis of severe congenital malformation for which they terminate the fetus and
Yes,
followed
sir.
by the autopsy and cause of to find out the cause.
Yes, sir.
Really a wonderful job.
Yes, sir. Thank you, sir.
Dr. Nabil, you just want to ask
Yeah,
a few questions?
excellent presentation. I think you guys are doing a wonderful job.
Thank you, sir.
Just one, it's not a question or rather curious, I mean, just a doubt which I've
Yes,
had
sir.
is, so as you're an institute, you're doing this, right? So
Yes,
you
sir.
have the pathologist and the pediatric surgeon along with you. So,
Yes, sir.
I mean, can something similar be done even in private institutes, or legally we are not allowed to? It's only to be done in government institutes.
It's being done in certain private institutes, sir, but we have to get permissions, like PCPNDT permissions for doing fetal autopsy. It has to be separately registered, and with the permissions, you can proceed, sir.
Thank you.
May I interfere, sir?
Yeah, sure. Varsha, anything?
Fantastic presentation. I'm amazed by the kind of work that is being doing. Just not a query to you, just for my own general knowledge as well.
Yes, ma'am.
Dr. Madhumita, what is, since you, I understand you're from Department of Radio Diagnosis,
Yes,
what is
ma'am.
the implications of, a lot of, do you do regularly
Training.
karyotyping through amniocentesis or anything like that in these kind of cases when they have when you're diagnosing these
Yes, ma'am.
conditions, once you identify it radiologically, what are the implications of the same?
Yes,
Just wanted for my knowledge.
Yes, ma'am. In our institute, we don't have the genetic testing available,
Okay.
ma'am. So patients are not affordable and they do not want, but
Okay.
it's being done in other private setups and other institutes where it's done with the collaboration with private labs, because
Right.
genetic testing is not available in government centers. Yes, ma'am.
Okay.
And
Right.
it is definitely useful when we suspect with mild defects, they want to continue the pregnancy. It assures us karyotyping and normal karyotyping will rule out common aneuploidy, so that it assures them that with the and if there are surgical correction of the defects possible or treatment of the defects possible, it gives them more confidence to continue the pregnancy.
Right. Okay. Thank you so much. That was a wonderful session. Thank you.
Yes, ma'am. Thank you, ma'am.
Thank you, Dr. Madhumita. You can stop sharing your screen now.
Yes, ma'am.
Yeah. I'd like to call our 8th presentation on the list, Dr. Nazma Yasin from Mehta Hospitals in Chennai. She's a pediatric medicine postgraduate, and her paper is titled When Tumor Meets Tremor, Opsoclonus Myoclonus Ataxia as the Herald of Neuroblastoma.
Good morning, all. Am I visible and audible?
Yes, you are visible. Your screen is seen, ma'am. You can just, put it on slide.
Okay.
Thank you.
Okay.
1 minute, I'll just start your timer.
Sure, ma'am.
You can start.
Yeah. Good morning, all. My topic is when the tumor meets tremor. It is the case of opsoclonus myoclonus ataxia syndrome as a herald of neuroblastoma. It is the case of 14 months old male child with a history of abrupt gait instability, head swaying, and ocular movements and oscillations for 20 days before admission. Treated at outside hospital with the supportive measures, and the child was not settled symptomatically, so referred for pediatric neurologist opinion. Child was diagnosed to have opsoclonus myoclonus ataxia syndrome in view of abnormal limb and ocular movements, and started on IV, admitted in PSU, started on IVAG and further evaluation and management. The differential diagnosis considered at this point of time was paraneoplastic tumor associated OMAS, para-infectious, autoimmune cause, and toxic cause. Other 3 causes were ruled out in view of a strong paraneoplastic suspicion. Diagnostic work preoperatively done showed hyperechoic lesion in the left paraaortic region encircling the renal vessels with a normal Doppler study. MRI brain showed MRI brain and PT, CT, PET CT suggestive of neuroblastoma. Biochemistry showed increased VMA, urine spot VMA levels suggestive of neuroblastoma origin, and other blood investigations were normal. Surgical intervention, child underwent laparotomy, and the procedure posed significant technical difficulty owing to deep-seated retroperitoneal location of the mass, and due to the major vessel structures, including the left renal artery and vein. The tumor was found encasing the renal pedicle with a dense fibrotic adhesions. Meticulous dissection was done circumferentially to remove the tumors, along with the interferent vascular clips. The retroperitoneal dissection demanded careful identification of ureter and gonadal vessels and sympathetic chain to prevent the iatrogenic injury. The tumor was excised in toto with R0 resections. Post-excision inspection showed intact renal vessels with good pulsality and preserved urine output intraoperatively. The posterior period was uneventful. Initially on NPO, then child had fever on the day 2, which was controlled on day 4 after removal of central limbs. Management of opsoclonus myoclonus included ACTH protocol as per the neurologist advice, and continuous monitoring of blood sugars and blood pressures and serum electrolytes. Post-operatively, a diagnostic workout for histopathology, immunohistochemistry, and FISH suggestive of neuroblastoma origin. So the learning point from this case was the early multidisciplinary approach from the pediatric surgery, neurology, and pediatrician, pre-op planning and imaging with the PET CT and MRI, vascular anatomy dissection for microdissection and the precise excision of the tumor, tissue handling and oncological principles for the complete end-to-end or zero resection of the tumor, imperative decision making to remove the tumor to preserve the functionality, and the post-operative management integration with the pediatric neurology team and pediatrician support, and holistic pediatric surgical perspective. future impact based on the early recognition of systemic and surgical linkages, integration of immunology along with the surgery, evolution of precise pediatric surgery, in collaboration with the multidisciplinary approach, and education and research implications. The takeaway message is early recognition of obsoclonus myoclonus lead to the prompt identification of neuroblastoma, timely surgical excision to achieve the cure and reduce the autoimmune neurological response, meticulous dissection and vascular preservation are the key in while operating, and a multidisciplinary cooperation among the surgery, neurology, and oncology team to ensure the proper outcomes. Thank you.
Thank you,
So
Dr. Najma.
she has 40 seconds left, sir, so we can add that to the discussion.
Dr. Najma,
Yes, sir.
can you hear me?
Yes, sir. I'm here, sir.
Excellent presentation. As
Thank
you
you,
are
sir.
from pediatric medicine, I just want to know how will you differentiate a case of neuroblastoma and a case of Wilms tumor
Sir, neuroblastoma mainly has the
clinically?
sir, in this case, clinically, a child had no mass, abdominal mass, sir, and a predominant child had neurological symptoms like obsoclonus and myoclonus, sir. So, like when we say obsoclonus, myoclonus, 80% of the time we think about neuroblastoma, sir.
What is obsoclonus myoclonus syndrome?
Sir, obsoclonus is like a chaotic eye movements. Like nystagmus is rhythmic movements. Obsoclonus is very chaotic eye movements, and myoclonus is a type of movement disorder, sir.
Okay. What is the pathology behind this?
Sir, it's mainly because of autoimmune pathology, sir.
How will you manage this?
Sir, we initially we suspected neuroblastoma because of the obsoclonus myoclonus, and MRI and PET-CT also showed the significant neuroblastoma, and we completely removed the tumor along with the ACTH, adrenocorticotrophic therapy. That's all, sir. And the child is now symptom-free, and they did not require any chemo or radiotherapy, sir.
Okay. Any drugs for autoimmune, this type of paraneoplastic syndromes?
Sir, for this case specifically, we used adrenocorticotrophic hormones, sir. So other than that, in this case, no other drugs we use. Sir.
Okay. Over to Dr. Nabil and Dr. Varsha, please.
Varsha, you can go ahead.
Great presentation once again. Just want to know any other syndromes or symptoms that you commonly see with neuroblastoma apart from obsoclonus myoclonus syndrome?
No, ma'am. Usually, neuroblastoma sometimes it comes as difficulty in moving limbs, like hypotonia and regression of milestones like that.
No, that is what I'm asking. Are there any other syndromes or symptoms that can be there in neuroblastoma based on the site of it? You have highlighted obsoclonus myoclonus in this particular case,
yes,
but as neuroblastoma can occur again
yes,
along the ganglion anywhere. Any
yes,
other syndromes that you are aware of or symptomatic symptoms?
Symptomatically, we had one more child neuroblastoma with a history of difficulty in moving the lower limbs, ma'am. So it presented as hypotonia.
Okay. What I was trying to get at is you can have syndromes such as VIP syndrome. Have you heard of that? Vasoactive intestinal peptide syndrome. They'll have severe watery diarrhea, etc. In cervical neuroblastomas, you can have it causing Horner syndrome. So that was what I was trying to get to, that since it can occur anywhere, it depends on the site as well as the functioning of the tumor as well.
Yes, sure.
Thank you so much. Good presentation.
Thank you all.
Thank you, Dr. Nazma. We'll move on to the next presentation. This is paper number 9 from Dr. Yogesh Soni from NSCB Medical College in Jabalpur. He's a general surgery postgraduate, and his paper is titled Tiny Patients, Big Challenges, Ergonomics in Pediatric Surgery.
Hello, good morning. Am I audible to everyone?
Yes, you are audible.
Hello.
You can share your presentation and turn on your video.
Thank you, ma'am. Is my presentation visible now?
Yeah, you can put it on slideshow, sir.
Is it visible?
Yes.
Am I audible?
Perfect.
Thank you.
Perfect.
Thank you very much, ma'am.
I'll start your timer.
Good morning to all the
You can
delegates
start.
and esteemed faculties. I'm Good morning to all the delegates and esteemed faculties. I am Yogesh Soni from General Surgery Department at Netaji Subhash Chandra Bose Medical College and Hospital, Jabalpur, here to present a paper on ergonomics in pediatric surgery, tiny patients, a big challenge. Moving on with the introduction, in simpler terms, ergonomics is the science of optimizing human performance in workspace, which aims to reduce fatigue, errors, and improve precision. In pediatric surgery, it is important for maintaining surgeon's comfort and procedural efficacy. Distinct anatomical proportions of children necessitate specific ergonomic adaptations that differ significantly from the adult surgical practices. Now, why do ergonomics matter? Because it directly impacts the surgeon's performance and patient safety. Focusing on good ergonomics enhances efficiency, patient outcomes, and long-term career sustainability, while poor ergonomics cause fatigue, musculoskeletal injuries, and reduced concentration. Up to 70% of surgeons report musculoskeletal discomfort pre and post-surgery. Now, what are the ergonomic challenges specific to pediatric surgery? Pediatric patients have a unique delicate small anatomies and high physiological sensitivity, leading to limited working space, restricted port spacing, awkward positioning, instrument crowding, high table height, reduced triangulation, precision, and assistant ergonomics are often compromised. Now, this is a beautiful illustration showing the ideal positioning during a pediatric laparoscopic surgery. Compared to adult surgery, the top level of the monitor should be at the eye level and the screen should be centered 15 to 20 degrees below the eye level of the surgeon. Then the arm position should be neutral by the sides of the person. The height of the table should be just 15 to 20 centimeters below the elbow height, and the angle between the elbows should be around 90 to 120 degrees. Now, moving on with the straight line principle. Straight line principle ensures that the instrument movement follows a direct linear path, thus reducing unnecessary angulation and torque during surgery. It helps in confined working spaces and precise movements within smaller anatomical structures as in pediatric abdomen. Now, regarding the baseball diamond concept, it was astonishing to know that this very great concept was designed by a pediatric surgeon, George W. Holocomb, to optimize the triangulation and ergonomic instrument handling. Its advantages include reduced collision between instruments, decreased awkward positioning and fatigue. It maintains critical angles necessary for effective tissue manipulation. Now, this is an illustration of the application of baseball timing concept in a small working space as a pediatric thorax during thoracoscopic surgeries. For the ease of instrument placement, we divide the thorax into anterior and posterior parts or superior and inferior zones depending on the site to be operated. Now, regarding angulations during port placement, the ideal manipulation angle between the instruments should be around 60 degrees, with the azimuth angles around 30 degrees, preferably equal on both sides. The elevation angles approximately 35 to 40 degrees. These measurements represent the ergonomic sweet spot where the surgeon's comfort is maximized while maintaining effective instrument control. Now, for the take-home message, ergonomics in pediatric surgery is not a luxury, it's a necessity. Small adjustments in setup can prevent long-term musculoskeletal strain. Comfort and precision always go hand in hand. Healthy surgeons deliver better care. Ergonomics is the invisible assistant in every operation. It supports the surgeon so that they can support the patient. Thank you very much.
He has finished 30 seconds in advance. We'll be adding this to the discussion.
First of all, excellent topic of presentation by Swami.
Thank you, Mr.
I just like to ask you one thing that have you completed your tenure or rotation in pediatric surgery?
Yes, sir. I've done it twice.
You have done it twice. So what you learned from it, what is the difference between adult and pediatric laparoscopy? One advantage and one disadvantage.
Sir, in the pediatric laparoscopies as compared to the adult laparoscopies, the major difference is that in adult laparoscopic surgery, we have more freedom of movement and more space to work. While in pediatric patients, the spaces are very small and we have so less space to manipulate the tissues. And even the angulation during these kind of surgeries thus becomes quite flexed as compared to the adult laparoscopic surgeries. So this is one of the major differences that I saw. And one more thing was that the patient, while we position the patient in adult surgery, the positioning of the adult patients is always parallel to their table, as we see in the normal practice. But in cases of infants, I had seen in my institution that the infant was placed across the table during surgery, so as to get better access to the upper abdominal structures. So these are the differences that I've seen in pediatric surgery as well as in comparison to the adult laparoscopic surgery.
Any anatomical advantages of pediatric population?
So the pediatric population, the caps like an gastric pull-up, for example, that we had seen on surgery. So in those things, the pediatric tissue has more mobility, and the outcomes of surgeries that I have seen in my institution for comparable surgeries in adult and pediatric patients, the outcome in pediatric patients was actually better as compared to the adult patients. So that was one of the advantages that I saw.
Okay, thank you. Over to Varsha and Dr. Navi. Please carry on.
Nabil sir, anything from your side, sir,
Yeah,
please?
good presentation, Yogesh. This is
Thank
I
you.
think the second paper from NCB. So congrats to Vikesh sir as well. And what I've noticed is both the PGs have said that they've gone twice for pediatric surgery posting. So good job there. So Yogesh, what is can you tell one pediatric, just tell me out of your head one laparoscopic surgery which you have assisted?
Sir, I've assisted on laparoscopic pyloromyotomy.
Okay, I am asking only
And
one. So you have told about laparoscopic pyloromyotomy. What instruments did you use for that?
so we used 3 mm instruments in that infant child.
Okay, how
The
many
adult
ports did you
infant child,
place?
so we placed 3 ports. Sorry, we placed 2 ports and 1 optical port.
Very good. So okay, good. That's good. So I think the last point which you said when you're thinking that adults compared to pediatric and adults, pediatric they respond better. That was one point which made me choose pediatric surgery. I hope you choose it. Over to you, Varsha.
Yes.
I think everything covered from my side. Great presentation. And it's very quite endearing to see youngsters be this way. It's giving me a lot of hope.
Thank you, Varsha.
Yes. Thank you, Dr. Yogesh. Time is up for his presentation.
Yeah.
We'll just go back to
Yeah,
the
we have one more.
presentation number 4, Dr. Adayar Prashant. We'll be sharing his presentation from the coordinator side. So he just needs to unmute and start his audio. Dr. Adayar, are you there?
Yes, ma'am. Are you able to hear, ma'am?
Yes, we are able to hear you.
Yeah.
We'll be sharing your screen here. One second.
Is the screen being shared?
No, ma'am, not. Yes,
Yes,
now
yes, it's shared.
you can put it on slideshow.
Yeah. Okay.
Yes. Dr. Adayar, are you comfortable?
Yes, ma'am. Thank you very
One
much.
second. I'm so sorry. One sec.
Yes. Okay. So Dr. Adayar, he is from Mehta Hospitals in Chennai. He's a pediatric medicine postgraduate, and his paper is titled "An Innocuous Foreign Body Turning into Jeopardy."
Yeah.
Just give me a minute. I'll start your timer, and then we can start.
Yeah. Shall I start, ma'am?
Just a second. Yes, you can start.
Yeah, good morning, everyone. Innocuous foreign body turning into jeopardy, a perforation peritonitis by a soft-edged foreign body is my presentation today. I'm Dr. Adaya Preshan from Mehta Hospital, Chennai. Next slide. It's a 12-year-old female child with a background history of attention deficit disorder, referred with suspicion of appendicitis. The child had bilious vomiting with right hypochondriac colicky pain. In view of subhepatic appendicitis, X-ray was done, which showed a foreign body. Ultrasound with CT screening showed a linear radiodense foreign body measuring 5.5 centimeter, noted in right hypochondrium, with one end of the structure within the bowel loop and another end in subhepatic region piercing the bowel wall. Next slide. Next slide. Yeah. Here you can see the reconstructed image showing the foreign body in the subhepatic region. Next slide. This is a video of the surgery done through laparoscopy. Here the laparoscopic ports are introduced and the foreign body is removed through laparoscopy in the subhepatic region. The foreign body actually crossed the duodenum near the C loop. It has caused pressure necrosis and it has entered peritoneum and lodged and pierced in other side near the liver. Next slide. Yeah, the discussion is the foreign body injection is a common clinical scenario in pediatrics. 80 to 90% of ingested foreign bodies are excreted without any complications. Perforations are rare. Most common site are ileocecal valve, sigmoid colon, DJ flexure. Next slide. The size and structure of the ingested foreign body plays an important role in causing this type of complication. And this extraction longer than 3 centimeter in children is younger than 1 year and longer than 5 centimeter in children older than 1 year. In adults, foreign bodies larger than 2.5 centimeter or longer than 5 to 6 centimeters must be extracted before. Next slide. Yeah. If the risk assessment has to be done in case of very high risk, if the foreign body is in upper third of esophagus or complete it is causing complete esophageal obstruction or it is sharp or button batteries, magnets, urgent endoscopic extraction should be done. If it is a moderate risk like soft foreign body, non-toxic foreign body with diameter less than 20 millimeter and length less than 50 millimeter, then endoscopic extraction has to be deferred. And in case of for a small bowel foreign body for more than 3 days, duodenal foreign body for 8 days, gastric foreign body like 3 to 4 weeks without passing, the next thing is like we have to go for a surgery or rigid esophagoscopy is the question. Next slide. Conclusion is this child had a history of attention deficit disorder with multiple foreign bodies. Other foreign bodies we have not retrieved because we consider those as non-sharp and it has reached sigmoid colon. So conservative management has done. The conclusion point is a calculated decision needs to be taken based on the size and length of the foreign body, especially in neuropsychiatric disorder underlying children. Thank you.
Thank you so much. Dr. Sujay sir and Nabil sir, any comments,
Yes.
please? And
Excellent presentation and excellent videos by Dr. Adia.
Thank you, sir.
I just want to know you have given the title that it is innocuous.
Yes,
Why
sir.
you are saying it is innocuous?
Initially, we thought it is. We initially the child presented with fever. We thought of appendicitis. We took an X-ray. We found that it is non-sharp. We thought it will like pass through it through bowel. We planned of conservative management, but the child developed a severe abdominal pain. Then we took an CT. Then we found this hairpin entering into the subhepatic region. So what is the conclusion is not always non-sharp foreign bodies can have conservative management. We need to keep in eye that they can also cause pressure necrosis and can lead into complications like this. So it can also turn into a jeopardy.
Your provisional diagnosis was appendicitis.
Appendicitis. Initially, the child
clinically.
Yeah. As a pediatric PG, we thought of appendicitis first. But after the child telling severe abdominal pain, we took an X-ray. Then we found a foreign body. Then we took help from pediatric surgeon. After they intervening, they suggested CT screening. Then the scenario turned different.
After removal, how did they manage? Have you seen that?
Yes, sir. Post-op, the child was comfortable. Actually, the child had a background history of attention deficit disorder. Child had other foreign bodies also, but we have not intervened because those foreign bodies are near the sigmoid colon. Those are past.
My question is very simple.
Yes, sir.
Have you seen what they have done after removal of the foreign body?
Yes, sir. They have. I have seen the child, sir. Follow up. The child is comfortable. They just suggested the child for a neuropsychiatric evaluation as in medical perspective. Post op, the child was kept on NPO and started on liquid diet and solid, and child is fine, sir.
So, what you have learned from this case?
We have to always keep in suspicion that even non-sharp foreign bodies also can lead on to a complication. Not always non-sharp foreign bodies can have a conservative management from pediatric PG perspective, sir.
So, what is your future plan? Are you interested in pediatric surgery?
We are studying DNB pediatrics, sir, but we have seen lot of cases related to pediatric surgery. We manage like pre-op, we'll see, and post-op management we have learned, sir, in our hospital.
Okay, thank you. Over to Dr. Nabil and Dr. Varsha.
Yeah. Varsha, you want to go ahead? Can we last paper just finish it off fast? So good presentation, Dr. Aryar.
Thank you, sir.
Just one thing I would like to ask you is clinic, because you're a pediatric PG. Clinically, what made you suspicious of appendicitis? 1 point, please.
Sir, actually, the child had a fever and abdominal pain. But the classically right iliac fossa tenderness was not there. Umbilical pain was there, but it was disproportionately more pain. So that only we took
Did
an
the child
X-ray.
have signs of peritonitis?
Yes, sir. Yes. But more than clinical, because of that X-ray only, we are able to think of foreign body after seeing the X-ray image.
Do you get an X-ray for all cases of appendicitis?
No, sir. No, sir. But
Then
because
why
of
in this case?
this child had a previous history of foreign body injection. This child is attention deficit disorder. So we thought maybe this time the child mother gave an history that child will be keeping on his her hair clip in mouth while combing. So with that history,
I
we
think what I
found it.
want to point out here is that history is again very important
Yes, sir.
part before making a diagnosis. I think this
Yes,
is Dr. Rahul. I think
yes, sir.
second paper by Dr. Rahul also. So I would like to congratulate Dr. Rahul as well for this.
Yes, sir.
Yeah,
Yes, sir.
Varsha, over to you.
That was a great presentation. Congrats. I'd like to wrap it up then quickly. Great presentation by all the presenters. Wonderful confidence. And we hope to see you grow and present more in the future. Lovely presentation on management and suspect the unsuspected always, I think. So,
yes, ma'am.
yes. All right. Thank you so much. Over to the coordinator, please.
Yes. I think we've come to the end of our first session in our IAPS Abhimanyu prize paper sessions here. So we've had 9 papers from all over the country, all showing different cases and different presentations. It was very interesting and really enjoyed listening to the questions as well as the answers given by the PGs here. I'd like to thank all 3 judges, Dr. Sujay Pal, Dr. Nabil and Dr. Varsha. For their contribution as well as for taking out time out of their busy schedule for us. So we can move on to the second session here. The coordinator for this session, again, Dr. Varsha will be taking off her cap as a judge and coming in as a coordinator. So I'll hand it over to her.
Yeah, thank you so much. Thank you so much, Evangeline. You conducted a very nice session. Thanks to the team of IAPS for letting us be the judges. Thank you, and all the best to all the presenters. Thank you.
Thank you so much, everybody.
Just Just a gentle reminder for the judges to just enter in the marks on the Excel sheet that has been forwarded to you, sir. Thank you.
So shall we proceed with the second session without any delay, if that is all right with all?
Yes, please, ma'am.
Yeah, all right. Again, welcome to everybody. The first session started off with a bang. Our opening batsmen were wonderful. So we're just going to proceed in with the second session. I hope all the presenters have joined. We have 11 papers in this session, and there are 3 judges. To my luck, none of the 3 actually need any introduction. I hope our judges and our judging panel are with us.
Yes, we are.
Yes, okay. So, starting off this
Hi,
session,
good
which
morning.
is going, good morning, sir. Welcome. So
Thank
the
you.
second session is actually comprising of pediatric GI surgery. And I'm very fortunate to have with us a wonderful panel of judges. And thank you once again for IAPS for this opportunity for all of us to meet up, as well as for all these presenters. So without any further ado, I would like to introduce our first judge, Dr. Ankur Mandelia, sir. Name is so well known, does not need any introduction. Sir is one of the performing in one of the highest series of robotic pediatric surgery at SGPGI Lucknow, and giving the youngsters a huge run for their money, because he's got a very keen interest in AI, and I'm sure he's going to be taking it very much forward. Someone to really learn from, and for the youngsters out here. Our second judge is Dr.
I'm also
Krishna.
still a youngster only, Vatsha.
Always young, sir. Young till we
Yeah.
young till we go.
Yeah, thank you. Thank you for that introduction. Thank you.
Thank you for being with us today, sir. Second judge is Dr. Krishna Rao, sir. Sir, are you with us?
Yes, Vatsha, I'm there.
Yes, sir. Hello, welcome, sir.
Thank you.
So, Krishna, sir, an true example of a pediatric surgeon who has established modern pediatric surgery in Tier 2 and 3 cities. Young pediatric surgeons and even future pediatric surgeons should look up to him for his perseverance to work in even resource-restrained environments. And that is something we as the young faculty now truly look up to. Thank you for being with us here today, sir.
Thank you. Thank you for kind introduction.
And my wonderful colleague, Dr. Supraja Subramaniam, as talented as she is as a pediatric surgeon, she is immensely artistically talented, a wonderful person to be with, and a great pediatric surgeon for the future generations coming in. So thanks for being with us today, Supraja.
Thank you, Asha.
All right. So as all our participants are here, I would like the participants, I will remind you once again of the rules. So there is 4 minutes of presentation time, and there will be a 2 minutes discussion wherein the judges will ask some questions, and you will get that time to answer the same. There will be a timer. I request you at your behest to please maintain the time so that we can give and complete the session at a good period. We have 11 papers in total. The order will go as the same, which we have shared with all of you presenters already. So starting off will be Dr. Abhipsa Singh from Kalinga Institute of Medical Sciences. She is a pediatric medicine resident. And Dr. Abhipsa, are you with us? Could you please start sharing your screen?
Yes, ma'am.
And I would also request you to please switch on your video so the judges can please see. Once you share your screen, I will introduce you once again with your topic.
Yes, ma'am.
There is an icon at the bottom.
Yes, ma'am.
It's a green color one with share.
Ma'am, is my screen visible?
Yes, your screen is visible. You just have to put it on slideshow and I will introduce you again. So we have the first presenter with us, Dr. Abhipsa Singh from Kalinga Institute of Medical Sciences. She is a pediatric medicine resident. and she will be speaking upon when interception masks an underlying malignancy, Burkitt lymphoma. Are you ready, Dr. Abhipsa? Your time
Yes, ma'am.
starts now. Please proceed.
Good morning, everyone. I'm Dr. Abhipsa, and I'll be presenting when interception masks an underlying malignancy, a case of Burkitt's lymphoma. So, interception is a common cause of small bowel obstruction in children. In young children, most of the cases are idiopathic with classical symptoms, whereas in older children, it is usually secondary to a pathological lead point, such as a lymphoma, a carcinoma, or a polyp. Coming to my case report, so I present a case of a 15-year-old male child who came to us with the complaints of fever, abdominal pain, abdominal distension, and vomiting since 10 days with no history of loose stools, weight loss, night sweats, trauma, or any other systemic manifestations. He had a significant past history of undergoing an exploratory laparotomy 2 months back at another center, which was done for an ileo-ileal interception, and the histopathology of the resected mass was suggestive of hemorrhage and necrosis with reactive hyperplasia of the lymph nodes. He was referred to our center as a post-op case of subacute intestinal obstruction. On examination, his vitals were stable, and on per abdomen examination, his abdomen was distended with an inverted umbilicus, a prominent scar mark over the midline, and there was diffuse tenderness with no guarding or rigidity. There was dull note over the flanks and shifting dullness, which indicated ascites, and other systemic examinations were normal. Coming to my diagnostic approach, interception in an adolescent boy with persistent abdominal pain and progressive ascites with the lab values suggesting bicytopenia, pre-renal AKI, dyselectrolytemia, where the uric acid levels, the phosphate levels, and were increased and the calcium levels were decreased, strongly indicating tumor lysis, which meant that there was definitely a primary pathological lead point which was missed. And the history and the lab values strongly pointing towards a malignancy. We did an ascitic tap, and the ascitic fluid flow cytometry was done, which was suggestive of kappa positivity, indicating malignant monoclonal B cells, and CD45, CD19, CD10, and CD20 positivity, indicating a non-Hodgkin's lymphoma of the mature B cells with germinal center origin, thus establishing the diagnosis of Burkitt's lymphoma. So, coming to the discussion, Burkitt's lymphoma is a highly aggressive mature B cell NHL with c-MYC translocation and one of the most common causes of NHL in children. It has three variants where the endemic or the African type is the most common. We have a Burkitt lymphoma IPI, that is International Prognostic Index, which has been developed for risk stratification, and it is a highly chemosensitive tumor where we follow the hyper CVAD plus rituximab protocol. We also followed it for the treatment of our child with Burkitt lymphoma. So the take-home message is that such cases should always have a multidisciplinary approach where the diagnostic role of surgeons is very important. Even though it was a case of surgical acute abdomen, we should always keep other possibilities in mind, and early recognition of atypical post-operative course plays a key role. And histopathology and IHC is the cornerstone for diagnosis. So meticulous examination is very important. And since it is a highly chemosensitive malignancy, early diagnosis with less invasive methods, as in our case, a simple ascitic tap, provides an excellent survival. Thank you.
Thank you, Abhipsa. The floor to the judges, please, for any questions.
Yeah, thank you, Dr. Abhipsa. It was an excellent presentation.
Thank you, sir.
It's a very important point which you're highlighting, that if an interception is there for a very long time, and if the patient is having symptoms like for a very long time, please suspect an underlying malignancy like Burkitt's lymphoma. You're a pediatric medicine resident?
Yes, sir.
Yeah. So One is Burkitt's lymphoma, which can lead to persistent interception on a CT or ultrasound. Do you know of other conditions in children which can lead to recurrent interceptions or persistent interceptions?
Sir,
I'm
Meckel's
asking more for recurrent
diverticulum.
interceptions. Yeah.
Meckel's diverticulum is one of the most common causes.
Yeah, but
And
Meckel's will usually come with an interception and will then get operated. A child who has, say, 5 episodes of interception in the last 3 years, which got resolved, and then child is coming again and again to you.
uh, so, uh, in children, Pear's patches, their hypertrophy or any polyp.
Yeah. So it is something like, say, a Peutz-Jeghers syndrome, where there
Yes,
multiple polyps in the small bowel.
polyps
So
and
those children come again and again
yes, sir.
because you can't remove all the polyps usually.
Yes, sir.
So good presentation. Thank you.
Thank you.
Very nice presentation, Abhipsa. I just want to know, as a pediatrician, when do you suspect interception? Normally, this was a very rare case where carcinoma was seen, but generally, when do you suspect interception as a pediatrician? And when would you call a pediatric surgeon?
Ma'am, we look for the common signs such as if the child is having persistent abdominal pain and if there is mass per abdomen, a common sign is the presence of red currant jelly stools. If they complain that they're noticing blood in stools of the child very frequently, and like one of the very common causes of blood in stools in children is usually intussusception, and apart from that, non-specific symptoms like vomiting. So, abdominal pain, mass, and blood in stools with vomiting, we likely think of intussusception. And also, history of vaccination, we can ask if they have taken rotavirus vaccine recently. So, that also can point towards the
We
case
generally
of
describe it as
interception.
increasing pain when we are not able to explain this colicky pain that the
Yes, ma'am.
child is having. You're right. Okay. Thank
Yes.
you. Think
Thank you.
discussion time is up. We can get to the
Yes,
next
thank
person.
you. Abhipsa, could you stop sharing your screen
Oh,
so
okay,
that we
ma'am.
may go to the next presenter? Thank you so much.
Thank you, ma'am.
Our next presenter is Dr. Pankaj Kumar from King George Medical University. He's a resident from General Surgery, and he will be presenting on When Eating Hurts, a case of adolescent SMA syndrome.
Hello, good morning,
Dr.
Abhishek. Am I
Pankaj,
visible?
I
Am
hope
I
your
visible
video is
and audible?
also. Yes, you are visible and audible.
Hello, good afternoon.
I hope the judges all are able to see.
Yes, please
Yeah,
go ahead.
can we have the timer switched on? Just a moment, Dr. Pankaj, you can start. Can start,
Let's start.
please? Yes,
Yes.
please start.
Good morning, all of you present over here. I will be presenting a unique case of superior mesenteric artery syndrome when eating herbs. Bomb greetings from my university, King George Medical University. So what is SMA syndrome? Also known as Wilkie syndrome, is a rare cause of upper GI obstruction. In what happens, there is an obstruction of the third part of duodenum, which is compressed between the aorta and the supramesenteric artery, which creates a vicious cycle. This is caused by the loss of mesenteric tract between the aorta and supramesenteric artery, due to which there is a compression of duodenum. It causes a postprandial pain, and this creates a fear in the patient's mind. If he is going to eat, he will again have a pain, and which further leads to weight loss, and due to weight loss, it will also lead to the loss of mesenteric fat pad. So coming to our clinical scenario, I am presenting a case of a 14-year-old boy which presented to us in OPD with complaint of 6 month history of worsening weight, postprandial abdominal pain, and with a profound fear of eating, which leads to a significant weight loss and documentation of 10 to 12 kgs in over 6 months. On examination, our examination finding was the patient was visibly cachexic and severely malnourished, a height of 166 centimeter, a weight of 35 kgs, and with a BMI of 12.5, which is indicator of very severe malnutrition. Our initial diagnostic workup includes the blood investigation, which were unremarkable. CBC, IFT, and inflammatory markers were within normal limits. Following which we done a barium wheel follow through, and this showed a delayed passage of contrast to the duodenum, suggesting a duodenal obstruction. As we can see here, this is the picture I have shown you here, in which there is a delayed passage of contrast to the duodenum. Following this, we have investigated a lot and we have done a contrast and a CT scan to confirm our diagnosis, which strikingly show a reduced orthomesenteric angle and also a reduced orthomesenteric distance. And also there was a dilatation of proximal duodenum, which was a significant. That was a 24 dilatation. Additional crucial findings were that duodenum was appeared to be kinked in the mesenteric vessel, compounding the obstruction. Here I have said the CT images where I have counted in the picture A, where there is arrows, we can see there is a reduced orthomesenteric angle and the reduced orthomesenteric distance also. Following which, we have planned the patient for surgery. On laparoscopic view, we have seen the lats band causing the affecting compression on the intestine. Also, there was a clear transition point with a dilated proximal duodenum, which has been shown by black dilated duodenum, and the blue was the collapsed distal bowel. Also, there was a reduced mesentery, which has been shown in the next picture also. So what we have done here, we have done a meticulous dissection along the thinking edge of the bowel. The goal was is to straighten the duodenum cilium, and the result of the point of obstruction should be relieved. And what this advantage was that apart from avoiding a new anastomosis, were going more physiologically. Outcome remarkable. Post-op day 3 tolerating liquids and post-op day 6 tolerating a full day without pain. The pre-operative situation vanished completely. Immediate resolution confirms the mechanical obstruction of the illness. Discussing a high index of suspicion is needed. Imaging is the key and tailored approach. The strong procedure was created because it addressed the specific pathology of the adhesive thinking. Significance in the Indian scenario is that in a country with a diverse nutrition challenge, severe malnutrition in adolescents can predict a direct participant in this eradication. SMA syndrome is rare. While conservative management has its plates, we can go for surgical management also. My references. Thank you.
Thank you. Judges, your comments and questions, please.
I think Krishna, you can start.
Pankaj, it's a good case. We rarely see this supramesenteric artery syndrome. You nicely presented. But 15 years, he was all right. But that is one unusual thing.
This was the one unusual thing in our case actually, because the symptoms of this patient arises from the he was totally normal in the about 13 years of age. The total time period of his symptoms is only 6 months. It started with a mild abdomen ache, which progressively increases post-pandemically, and due to which he had reduced their rating, and and also there is a progressive increase in the pain also. So there's maybe a different point of this presentation actually. We didn't also suspect SMA syndrome in the first actually when patient presented. It was only clarified by our barium shallow supported by the CT finding.
Pankaj, can I ask a question? You said there were lads bands, and basically all have done a straightening of the C loop. So there was some form of malrotation also, is it?
And there was a point intraoperatively I was there also. There was a high of cecum also. And there was a lateral one from the posterior abdominal wall going to the cecum. There's a high one. So what we have done is a visualization of that band also. And there was also a band near the C loop where the supramesenteric artery was running. There was a band also which was pinking the duodenum, and which was what causes the proximal obstruction, dilatation, and distal collapse. And what we have done is meticulous dissection of that band also. And we also have straightened the C loop of the duodenum, and also prophylaxis we have done the appendectomy also.
Okay, so you all basically did a lads procedure, almost.
Yes,
So it was which type of malrotation? Like where was the DJ? DJ had crossed the spine.
Yeah, DJ was
Or not at normal, but little lower, I think, right? It
little
was
lower,
like,
sir.
yeah, little lower. Okay, so
Yes.
very interesting. Nice case.
Thank you, ma'am.
Thank you so much, Dr. Pankaj. If you could stop sharing your screen.
Yes, ma'am, definitely.
So we have the next speaker, who will be Dr. Harish Hebali. Dr. Harish, are you available with us, please? Dr. Harish? Okay, you are there. Could you please share your screen? And if you could also switch on your audio and video for the judges to see.
Recording in progress.
Your video as well, please, Dr. Harish.
Yes, ma'am.
Your video also, please. Could you please switch
Video.
on your video, sir? Video on?
Yes, ma'am, it's on, ma'am.
Okay, okay. So we have Dr. Harish Hebali with us from Sakra World Hospital. He's from the Department of Pediatric Medicine, and he will be speaking on preterm survivor of segmental hepatectomy for massive abdominal mass of uncertain origin. Can we have the timer starting, please? Dr. Harish, the floor is yours.
Good morning, everyone. I'm Dr. Harish Abhimanyu from Sakra World Hospital, Department of Pediatrics and Neonatology. I'm presenting a rare and challenging case of a preterm survivor of a segmental hepatectomy for a massive abdominal mass of uncertain origin, managed successfully through a multidisciplinary approach at Sakra World Hospital under a guidance of Dr. Anil Kumar and Dr. Shiv Kumar. A preterm baby born at 33 weeks, 5 days of gestation at 2.18 kg male child with antenatally detected by ultrasound a large abdominal mass occupying 50% of abdomen presented with the increasing respiratory distress and feeding difficulty soon after birth. On postnatal evaluation, an abdominal ultrasound showed a uh, large heterogeneous intra-abdominal mass extending from the epigastrium to the pelvis, causing mass effect on nearby structures like stomach, intestine, spleen, and kidney. Baby also had a thrombocytopenia, elevated infection marker, elevated LDH, and D-dimers. MRI suggested a large multilobulated lesion with a central necrosis in a left hypochondrium with a no vascular invasion. Despite of full ventilatory support, distress kept worsening. The team decided on an emergency surgery in view of increasing respiratory distress. An emergency laparotomy done noticed that a large mass originating from the left lobe of liver. A non-anatomical resection of a left lobe of liver done, including segments 2, 3, 4A, and 4B. A baby required a massive blood transfusion, nearly equal to its total blood volume, about 100 ml in the OT. Then baby shifted to NICU. NICU care and challenges are: it's a preterm baby, low birth weight, feeding difficulties, low platelet counts, respiratory distress, low blood volume, and tolerance of a major procedure like anesthesia risk and liver resection tolerance. Post-operatively, baby had a cardiac arrest requiring a CPR, adrenaline, and mechanical ventilation in the NICU. Baby extubated on day 2 of life, achieved room air on day 17 of life. Baby battled with the sepsis and thrombocytopenia. Sepsis is treated with the aggressive broad spectrum antibiotic treatment like meropenem, metrogyl, and fluconazole prophylaxisally given. And blood cultures were showed no growth. And thrombocytopenia is treated with the STP transfusion. Nutrition wise, due to a large liver mass, due to a mass effect, pre-operatively and post-operatively, baby had a feed intolerance and GER symptoms. So nutrition wise, initially baby kept nil per oral and started with the total parental nutrition to ensure the adequate calories and proteins and electrolytes. And post-op day 2, continuous feeds are initiated by infusion feeds. On day 5, bolus feeds are started and day 15 of life, Palada feeds were initiated. Baby had repeated episodes of vomiting due to a small abdominal cavity, last stomach cavity. So it is managed with the anti-GR measures, and direct breastfeed was initiated on day 19 of life. Feeds are fortified whenever required. Dyselectrolemia is managed with the IV correction, and intermittent hypoglycemia episodes are managed. Daily weight monitoring and growth, gradually weight gain was there. Histopathology report shows the mesenchymal hematoma. At present, baby is this is a pre-operative picture, and it's an intraoperative, and it's a post-operative picture. Why this case involves the preterm neonate, and it's the smallest baby surviving the major hepatic surgery. In conclusion, sir, preterm neonates can also tolerate the major surgeries. Early intervention, multidisciplinary approach ensures the success of this case. Thank you.
Thank you. On to the judges, please.
Yeah, thank you, Dr. Harish, for a very well-managed case and a difficult case. Are you a neonatology resident, DM resident?
Yes, sir. Medicine, pediatric medicine department, sir.
MD
Pediatrics.
medicine resident.
First year
Okay.
resident.
Yeah. So one question is that the picture you showed in the second last slide, it was written left lateral segmentectomy. You said segment 2, 3, 4A, 4B parts of that were removed. Yeah. So that's a more of a surgical question. So left lateral segmentectomy
Non,
means you remove segment
non-anatomical
2, 3.
resection, sir, actually.
Yeah, but non-anatomical resection and left lateral segmentectomy are two different things. So just clarify it with your surgeon, pediatric surgeon.
Non-anatomical resection.
Yeah. So this picture is labeled wrongly, maybe, right? So in a my question is in a newborn with a huge mass causing respiratory distress. So what is your first DD?
First, the most common abdominal mass is a neuroblastoma and teratomas, and CDH is the most common thing,
No,
sir.
I'm asking. You're right. I'm asking about a liver mass. You had a liver mass on CT and MRI. So a liver mass, huge liver mass causing
And
respiratory distress.
most common benign is a hemangioma, sir.
Yeah.
Carcinomas are the hepatoblastoma is the most common.
Yeah, you're right. So if it was a hemangioma, what would you see on the imaging and what will you do? Will you do surgery or
Vascularity will be
something
there.
else? Sorry?
Increased vascularity will be there, sir, in this thing.
Any specific imaging features you know of a liver hemangioma?
No specific.
It's all right. You can read about it. And what would you
Treatment
do
wise,
if your radiologist tells you it's a liver hemangioma? What would you have done differently in this case? Suppose this was a liver
treatment
hemangioma. Your CT reporting showed a liver hemangioma of left lobe of liver. What would you do?
treat with the propranolol and steroid we can give.
Yeah, excellent. Surgery is the last resort for that. Very good.
Yes, sir.
Thank you. Thank you.
Thank you, sir.
So I think time is up. We can
Then,
go to the next
yeah,
one.
we'll go to the next one then. Dr. Harish, if you could stop sharing your screen and I'll invite our next speaker on.
Yes, please.
Thank you so much, Dr. Harish. We have our next speaker. I hope you're with us, Dr. Rajakartika. Yes. Dr. Rajakartika, please unmute yourself and also please switch on your video so our judges can see. Dr. Rajakartika is from Tanjavur Medical College from the Department of Pediatric Medicine, and she will be presenting on mercury pellets unmasking Hirschsprung disease in a newborn, an unusual case report. Could we have the timer on, please?
Good morning to one and all present here. My topic for the presentation is mercury pellets unmasking an underlying surgical bowel obstruction in a newborn, which is usually an unusual case report. So Hirschsprung disease is characterized by absence of myenteric ganglion cells in the distal alimentary canal. The frequency of the disease is 1 in 5,000 live births. The male is to female preponderance is in the ratio of 4:1. So the male has more predominance. The intentional administration of metallic mercury is rare in newborns, but in certain parts of Tamil Nadu, especially in the delta districts of Tamil Nadu, it is given to newborns in the belief that it has some therapeutic or protective power to clean the stomach or improve vitality or protect the baby. It has also been believed to have some cosmetic and aesthetic beliefs to improve complexion, skin tone brightening, and enhancing features. It is being marketed in the name of Rasapodi, and the most common symptoms of mercury ingestion are abdominal distension, vomiting, failure to pass stools, irritability, lethargy, and poor feeding, giving a sepsis-like picture. We present an unusual case where this harmful practice unmasked an underlying surgical condition. A term newborn was admitted with abdominal distension and failure to pass stools starting from day 2 of life. The parents revealed a history of giving mercury pellets orally for cultural reasons. Chest and abdominal radiograph showed multiple radiopaque pellets in the abdominal lumen, as shown in the below picture. Initially, it was thought to represent a benign transit because whenever this cultural practice was being followed, the mercury pellets given in newborn usually get transmitted through the newborn's bowel within 2 to 4 days. So this condition was managed conservatively for presuming it to be septic ileus with reassurance and that the mercury would pass spontaneously. However, serial X-ray showed static mercury pellets. We suspected impaired transit and proceeded with the contrast enema. This was justified both diagnostically and prognostically, and it helped to identify the transition zone and guide timely surgical intervention before actually the enterocolitis developed. The infant subsequently underwent colostomy, during which multiple mercury pellets were noted impacted at the aganglionic segment. Postoperatively, the child improved and passed stools normally through the stoma. On follow-up, some mercury pellets were visualized adherent to the intestinal wall, which gradually disappeared over 6 months without any intervention. So what were the diagnostic challenges we were facing in this case is that this rare case of mercury ingestion coinciding with Hirschsprung disease illustrates how a traditional neonatal practice can complicate a clinical diagnosis and even momentarily mask underlying surgical condition. While metallic mercury is being inert, its radio opacity created diagnostic confusion initially, yet paradoxically it had acted as a contrast agent, revealing the transition zone and aiding in the diagnosis. This case emphasizes the need for heightened clinical suspicion in any term neonate with delayed passage of meconium and careful interpretation of imaging findings and culturally sensitive communication with families to prevent such unsafe practices. Ultimately, this experience reminds us that medicine and culture intersect at the bedside, and awareness of both is essential for timely diagnosis, compassionate care, and improved neonatal outcome. Thank you.
Thank you so much. We have some extra time left over, so on to the judges so that it can be added to the discussion.
Yeah, please go
Good
ahead.
presentation.
Krishna, go ahead, please.
Good presentation. First time I'm seeing this type of cultural practice of feeding mercury. Mercury is a poison, no? We all know, and which has masked the common Hirschsprung disease also. Did you get the histopathology done, and what was the biopsy report while doing stoma?
Histopathology was having like absence of aganglionic cells and nerve bundles were um, nerve bundles were being enlarged, sir.
Okay. And stoma is looks like a double barrel or divided stoma has been done. We usually do a end colostomy or Hartmann's procedure like that. Why it was done? Any like just for just to have a suspicion was there, not confirmed. Is it so?
No, sir, it was actually confirmed because it was very quite common to have
Yeah,
such
X-ray was very quite. It was classical,
field.
but was
Yes.
divided stoma was not. Just why I was just confused whether the surgeon had any doubt of still doing a end colostomy or they had to preserve some bowel. That's what my question.
No, sir. Initially, rectal few 2 to 3 rectal washes was given, and then we went through compression, decompressive colostomy, sir. It was not like specific or something like that.
Hi, Raj Kartika. We also had a similar case actually that was referred from Tanjore with a foreign body that we didn't recognize actually that was mercury till someone else remembered that, it's given there. So
Yes.
these are inert, these pellets that are given are inert, is it? Like they don't cause, there are no cases where it caused poisoning as such,
No, ma'am.
generally?
Generally, the amount matters, I guess, ma'am, because
Yeah.
when they give around 4 to 8 droplets of mercury, and some neonates actually doesn't make up with any symptoms, but some actually present with vomiting, like irritability or poor feeding, giving a sepsis-like picture itself. So we
Okay.
actually confuse it with the
NEC.
yeah, yes,
Yeah.
yes,
Okay.
ma'am. That's what happens.
Okay. Generally, as a pediatrician, when would you suspect Hirschsprung's disease? Or not with any foreign body or such. When do you suspect Hirschsprung's disease? When would you look for it and call a surgeon? What are your points? Yeah.
Delayed passage of meconium from day one, presenting with abdominal distension, or vomiting, same picture like thing, and the main picture is abdominal distension is and delayed passage of meconium from day one.
Thank you, Raj Kartika.
Thank
Very
you.
nice
Thank you.
presentation.
Thank you so much, Dr. Rajakartika. If you could stop sharing your screen. Could we have the next speaker, Dr. Sagar Rathod, please? Dr. Sagar, are you with us? Could you please share your screen and unmute yourself?
Yes, ma'am. Hi.
Yeah.
Good morning, everyone. Good
Yeah,
morning.
I'll just introduce you.
Yeah.
Could you share your screen, please, Dr. Sagar? It's not visible yet.
1 second, ma'am.
Sure.
Is it visible, ma'am?
Not yet. There is an icon at the bottom, a green color icon with an arrow pointing up. Share.
No. No. Just a second. Okay.
Right. Let me try to help you out.
1 second.
Any help needed? Shall I share it for you otherwise? Would
Yeah,
that
please, ma'am, please.
Yeah, okay. Let me just, I've got your presentation with me. Is this your presentation? Is it visible to you?
Yeah, ma'am. It's visible.
Can I proceed to play it? So we have Dr. Sagar Rathod with us from the Department of General Surgery, All India Institute of Medical Sciences, New Delhi. And he will be presenting on ram's horn patent vitellointestinal duct. Could we please have the timer? You can start, Dr. Sagar.
Okay, ma'am. Good morning, everyone. I'm Dr. Sagar, Junior Resident in Department of Surgical Discipline, AIIMS Delhi. So I will be presenting a case report on Ramson, which is a patent vitellointestinal duct. So to start with, vitellointestinal duct is a embryological connection between the midgut and yolk sac, and it's a really rare condition. It presents in 2% of the individuals and 2% of the neonates, and normally obliterates by 7 to 9 weeks of gestation. And persistence of the vitellointestinal duct can lead to anomalies like Meckel's diverticulum, which is most common. And Ramson, it's due to prolapse of PVID, and it's a really rare condition. And it can lead to strangulation and ischemia later on if not identified and managed properly. It mimics umbilical hernia and interception. Ma'am, next slide. So our patient, he's a 3 months old male infant present with protruding dusky bowel loop from the umbilicus, and it was noticed while the baby was crying, and yeah, infant also had one episode of the non-bilious vomiting. There was no history of fever or abdominal distension, no history of poor feeding or lethargy, no other complaints. And on examination, an irreducible dusky prolapse bowel loop was identified through umbilical 0.5 centimeter umbilical defect. So vitally patient was stable, and on systemic examination, no other findings were noted other than the abdominal examination findings. And provisionally we made a provisional diagnosis of prolapse PVID, prolapse VID, and proceeded with the EL. And on exploratory laparotomy, we noticed proximal and distal ileal mucosa was prolapsing through the 0.5 centimeter of the umbilical defect, and initially we reduced that defect. We reduced that mucosal prolapse, and on examination, the bowel loop was sinus approximately 20 centimeter from the ileocecal junction. Initially, we tried with 100% oxygen and warm saline. There was no improvement. So we proceeded with the resection of the ischemic segment along with the PVID, and we did end-to-end ileoileal anastomosis. Later on, we did umbiliculoplasty. Next slide, ma'am. So these are the images, intra images showing the prolapse ileal mucosa, proximal and distal mucosa was prolapsing through the 0.5 centimeter of the umbilical defect and it presented as an interception. And the last image was showing the defect size. So at the end, we did umbiliculoplasty. Next image. So post-op course was uneventful. We started the infant on oral feed on post-op day 2, and patient was passing stool and urine. There was no other complaints, and this was the image, post-op image of the baby. So, and patient is being discharged on post of day 6 in a hemodynamically stable state with a healthy wound. In conclusion, Ramsan is a prolapse cervical intestinal duct is a rare condition. VAD itself is a rare condition. That too, in that Ramsan is really rare condition, but it can be life threatening. So early recognition and prompt surgery prevents bowel ischemia. And infants who presents with umbilical masses, we must suspect. Hello.
Proceed. Please continue, doctor.
Suspect for Ramson, we should suspect, and we should differentiate it from other umbilical conditions. Thank you.
Thank you. I will stop sharing the screen. Yeah, on to the judges. Would you like me to continue sharing the screen, judges, or is it okay if I've stopped sharing?
No, it's all right. It's all right.
All right. Thank you so much.
Good presentation, Dr. Sagar. Very well managed. So this is a rare presentation of Meckles,
Yes,
right?
sir. Yes, sir.
So can you just tell what are the common presentations of Meckles, which you might have seen or theoretically you must be knowing it?
Common presentation. I mean, I have never seen, sir. This was my first case, actually. So.
No, I'm saying you're a general surgery resident, right?
Sir.
Yeah. So this is a rare presentation. What you have presented, prolapsing through the patent VID. Do you know of how the Meckles commonly presents? Otherwise, how does a Meckel present in a patient? It can be an adult also. Yeah, even in general surgery, you may see it. Do you have any idea?
Not much idea, sir.
Bleeding, obstruction, pain, etc. Okay.
Yeah, bleeding. Most common like symptoms will be like obstruction and bleeding. Those
bleeding,
are.
Yeah, that's what I was
presentation.
asking.
Okay, I thought.
Yeah.
Okay, sir.
Okay, thank you. Yeah, other judges, please. Yeah.
Hi, good, nice presentation.
Thank you, sir.
Where was the delivery happened? Because still 2 months it has not come to contact with any pediatrician or pediatric surgeon.
Actually,
because the red mass from the umbilicus, we have to suspect patent intestinal duct. So where was the delivery and why it was delayed till 2 months?
Delivery happened outside, sir, in a private hospital. Baby presented later on to AIMS. So on presentation, we evaluated the baby and proceeded with it.
Any other questions from the judges, please? Dr. Supraja?
I think we can move on.
Right. Okay.
Thank you, ma'am.
So
Thank you.
you can mute yourself now. Thank you so much, doctor. Could we please have the next presenter, Dr. Sandeep John? Are you with us, Dr. Sandeep?
Ma'am.
Could you please share your screen?
Yes, ma'am.
We have Dr. Sandeep John with us from Sakra World Hospital from the Department of Pediatric Medicine. He will be presenting on multidisciplinary breakthrough preterm jejunal atresia with NEC and short bowel syndrome. Can we please have the timer? Yeah, you can start, please.
Good morning, everyone. This is a challenging neonatal surgical case that progressed to short bowel syndrome following 2 major abdominal surgeries. So, antenatal scans of the baby showed dilated bowel loops. Baby was born preterm at 33 weeks with a birth weight of 1.7 kg. Delivery followed rupture of membrane and baby developed respiratory distress with persistent bilious aspirates. On day 2, abdominal X-ray done showed dilated proximal loops. A laparotomy done which revealed a type 3B jejunal atresia with malrotation, the classic Christmas tree deformity. A LATS procedure with a resection and anastomosis was performed and a feeding tube was placed. Baby was recovering. By day 19, there was abdominal distension with the bilious aspirates, raising a suspicion of necrotizing enterocolitis. A repeat laparotomy which done and which showed a necrosis of the bowel. Resection with Hengi Mikulis bowel lengthening was done, leaving a residual bowel length of almost 20 centimeter with the ileocecal junction preserved. Postoperatively, the baby was started off the IV fluids and TPN, and multi-drug resistant E. coli was managed accordingly. Even small volumes of enteral feeding triggered large watery stools with perianal excoriation. Maximum levels of feeds which we are able to reach was 50% of the requirement of the baby. So what happens is after massive jejunal resection, the remaining bowel loses its normal absorptive and osmotic handling capacity. High osmolality feeds pull water into the intestinal lumen, producing osmotic diarrhea. Evidence shows that osmolality less than 300 milliosmol markedly reduces the stool water losses. So standard preterm formulas which you get is usually often exceed 380 to 450 milliosmols, whereas human milk averages around 260 to 300 milliosmols, providing a physiological advantage. We used donor human milk, which because it combines optimal osmolality with the bowel protection, bioactive protection. Multiple RCTs demonstrate a 40% reduction in recurrence of NEC also with human milk. Beyond nutrients, donor human milk provides lactoferrin, epidermal growth factor, and transforming growth factor beta, which enhance the villus growth and tight junction repair. So this was the cornerstone of our feeding practice. After jejunal resection, the unabsorbed bile salts can cause secretory diarrhea. To control this, cholesterol was added 15 to 20 milligram per kg per day in 2 divided doses. So by binding the luminal bile salts, it reduced their irritant effect on colonic mucosa, thereby improving stool consistency and perineal comfort. The Resicadople and encapsulase inhibitor was also added. So unlike loperamide, this preserves the normal peristalsis while reducing the chloride-driven hypersecretion diarrhea. So these agents gave us a pharmacological bridge until the enteral adaptation became self-sustaining. So in surgical neonates, Indian study in 2023 showed that the combination of Lactobacillus GG and Bifidobacterium reduces the stool output and shortened the TPN duration by almost 25%. Lactobacillus accelerates the intestinal adaptation by upregulating the GLP-2 and the epidermal growth factor receptors, hence improved villus height, enhanced the brush-borne enzyme activity, and a better sodium glucose co-transport. Once we started, this stool volume decreased within 1 week of starting the probiotic, confirming its clinical utility. Fortifies MCT oil, calcium, iron, zinc, and fat-soluble vitamins A, D, E, and K and was added to offset the ongoing malabsorption. Other systems were managed accordingly. By corrected gestational age of 45 weeks, the baby tolerated oral feeds weighing almost around 2 kgs and was clinically stable. So, from these integrated steps such as scientifically balanced osmolality, human milk-based feeding, evidence-backed probiotic use, pharmacological bile acid control, and vigilant systematic care, the infant short bowel improved slowly and it gradually adapted, paving the way towards a complete enteral autonomy. So, in short bowel syndrome, surgery saves the life, but the nutrition and meticulous conservative management saves the child. The take-home message is this case highlights that even in complex GA surgeries, judicious nutrition and conservative management are important as surgery itself. Thank you.
Thank you so much, Doctor. On to the judges, please.
Hi, Sandeep. Very nicely managed. So nice to hear such a good correlation between the neonatologist and the surgeon. But do you know what, as surgeons, we call a short bowel syndrome? Like, or what would entail a short bowel syndrome? This child had 20 centimeters of bowel with IC left. So what do we generally say as short bowel syndrome?
See, even time neonates, if the bowel length is less than 40 to 50 centimeter, which is we call it as a short bowel syndrome. Or if we can tell like that, it's 25% of reduction in length of the short bowel also, miss bowel also, we can term it as a short bowel syndrome. And all the growth parameters, everything we have to consider accordingly in that.
Yes, yes, thank you.
Yeah, Sandeep, very good presentation and excellently managed case. I just want to ask, like, how long after the second surgery it took to discharge the patient?
It's 90 days for the babies to get discharged from the hospital, total from the first day onwards. So the second, by starting the second feed, after the second surgery, the baby has so much of loose stools and there was a profuse watery diarrhea. So to get the intestinal adaptation took almost 3 to 4 weeks once we started all the supplements and all.
Yeah, because that is excellent because you said 20 centimeter with ICJ. And if the adaptation happened in 3 to 4 weeks with the supplements you said, that's a way forward to manage many of these kids. So very well managed and congratulations. Thank you.
Much. Any other questions from the judges, or should we proceed?
I think we can proceed, ma'am.
Right. Okay. Thank you so much, Dr. Sandeep. If you could stop sharing your screen, I'd like to invite the next speaker. Could we have the next speaker, Dr. Aditi Sharma, please? Dr. Aditi,
Yes,
are you with
ma'am.
us?
Yes,
Yeah,
ma'am.
could you?
Just a
Yeah,
minute.
yeah, sure. Please take your time. You can also share your video for our judges to see.
Good morning, everyone. Am I visible?
Yes. Could you share your screen, Dr. Aditi?
Yes, ma'am. Just a minute. Um, Ma'am, there is some issue in sharing. Can you do it if it's possible for
Yeah,
you?
I will do it for you. Just a second, please. Just give me a moment, judges. I'm just opening her presentation. Is this the right one, Dr. Aditi? If you could please take a look at it.
Yes, ma'am.
Is it visible?
Yes, ma'am.
Right. Okay. So I'd like to introduce our speaker, Dr. Aditi. Just a
Good morning.
second. Just a second, Dr. Aditi. 1 second. My screen is just hanging. Could you please give me a moment, judges? Yeah, sorry for the delay. I'd like to introduce our speaker, Dr. Aditi Sharma. She's from Srimati B.K. Shah Medical College, Sumandip Vidyapeeth University, from the Department of General Surgery, and she will be speaking on jejunal-ileal atresia in a neonate with situs inversus, polysplenia, and tetralogy of Fallot, a case report. Dr. Aditi, the floor is yours.
Good
Could we
morning,
have the
everyone.
timer?
Good morning, everyone. I'll be presenting a case of
बोल देना यही बात ठीक है क्या कैसे होता है
Hello.
Just a moment, Dr. Aditi. I think there's some disturbance in the other section. You can proceed, Dr. Aditi. Please proceed.
Good morning, everyone. I'll be presenting a case of jejunal ileal atresia in a neonate with situs inversus, polysplenia, and tetralogy of Fallot physiology, a case report. So, introduction, neonatal intestinal obstruction due to jejunal ilealized atresia occurs approximately in 1 in 5,000 live births and typically presents within the first few days of life with bilious vomiting and abdominal distension. Abdominal hallmarks can be a triple bubble sign when it's jejunal atresia or a double bubble sign when it's a duodenal atresia. Situs inversus with polysplenia is a part of heterotaxy spectrum. So there are two types of heterotaxy spectrum. It could be a left or a right isomerism. In our case, it was a left isomerism per se, because we had polysplenia along with the situs inversus and jejunal atresia. There was associated TOF in the baby, which generally is seen in the right isomerism. But what makes our case unique is that it was present, the TOF was present along with left isomerism. Ma'am, please next slide.
Yes.
We got the baby came to us when it was 8 day old with non-passage of meconium, bilious nasogastric aspirate from day 2 of life, and examination revealed abdominal distension, upper abdominal fullness, but there was no cyanotic or dysmoric features. So when we did an echocardiography, it was performed because on auscultation we could hear a murmur. So when we did a echocardiography, there was a TOF physiology with a left to right shunt. Generally, we do have a right to left shunt, but this again makes it a very unique case because there was a left to right shunt. In the plain abdominal radiograph, we had a triple bubble sign, which was suggestive of proximal jejunal obstruction. In addition, there was no distal bowel gas present. We also did a gastrograph and meal follow through and contrast enema, which was suggestive of small bowel obstruction with partial situs inversus. Then echocardiography, TOF physiology was seen. The child was acyanotic and with stable saturation. Intraoperative findings, we saw situs inversus with polysplenia. The liver was placed centrally, and beneath the liver, we could see multiple spleens. We came across 5 to 6 spleens per se. It is shown here in the first picture, where my cautery is pointing. That is where we had multiple spleens, and the splenomegaly per se, they were very small. And beneath my retractor is the liver. Then we had genoileal atresia. In the next image, we can see there are multiple small atretic bands. So we have 4 types of atresias, but this one was the 4th type per se. Then there was a dilated proximal duodenum. Ma'am, please next slide.
Yes.
So in surgical management, we actually did resect the treatic segment. We did duodenal tapering in order to prevent the dysmotility that would happen. We did the duodenal tapering and we anastomosed it with the ileum. Post-operatively, the baby was stable. It took him some time to regain and adapt feeds. Initially, he was accepting 3 ml of feeds every 2 hourly. We switched to 4 ml and it was purely mother's milk via nasogastric tube. The follow-up is, however, awaited. Ma'am, please next slide. Here are the differential diagnosis of neonatal triple bubble sign. Earlier mentioned bubble means it's duodenal atresia, triple bubble, jejunal atresia, annular pancreas, and even with malrotation and volvulus. Distal bowel gas absent is the mostly proximal obstruction, but if it is present, there could be a sign of partial or obstruction or stenosis. What makes our case unique is it had left isomerism along with TOF, along with polysplenia and there was jejunal atresia. Along with that, it was very challenging to get the anatomic orientation during the operative procedure. It was very difficult for an anesthetist as well. It was quite challenging, I'll say. Then, per se, we did not feel like had encountered any problem in the cardiac system of the patient per se because he was maintaining saturation very well. Had it been different, we would have preferred a shunting case first. Thank you.
Thank you so much. I'll stop sharing the screen. On to the judges, please.
Good presentation, but I think there is no time left. Is there time left for discussion?
Yes, there's about a minute left, sir.
Okay, so Aditi, a good presentation, rare case. Just 2 suggestions. One is, I think you were projecting your case report directly. So try to make the slides of the most important points. And also don't exceed time in such presentations because you're getting -5 for that, right? Rest it was a good, well-managed case. Thank you.
Thank you.
Any other comments or should we proceed? Other judges, please. Dr. Krishna, sir, Dr. Sutra.
I think we can proceed. We've already crossed time.
Right. Yeah. Okay.
Thank you. Thank you.
All right. Thank you so much, Dr. Aditi. If you could stop. If you could. The next speaker, Dr. Anubhav Singh from Maharani Lakshmibai Medical College, Jhansi. Are you with us? Dr. Anubhav Singh?
Actually, that candidate is having some exam or something. I've just contacted his friend. I think we can go back to him if he's able to join at the end.
Sure. Okay. All right. Okay. So we'll proceed to the next speaker, Dr. Sudarshini Sudhakar. Dr. Sudarshini, are you with us? Could you please unmute yourself and switch on your video?
Yes, ma'am. Good morning.
Yeah, good morning. Could you please share your screen and your slides?
Is my slide visible?
Yes, your slide is visible. You just need to put it on slideshow mode, please. Just give me a moment. So our next speaker is Dr. Sudarshini Sudhakar from Yenapoya Medical College. She's a general surgery resident and she'll be presenting on intramural hematoma of the terminal ileum causing intestinal obstruction in a child, a case report. Dr. Sudarshini, the floor is yours. Could we please have the timer? You may start.
Yeah. Good morning, everyone. I'll be presenting on a spontaneous intramural ileal hematoma following pediatric inguinal herniectomy. It was a post-operative obstruction. So basically, intramural hematoma is rare. Is it not?
No, there's other slides moving for the other for the judges as well because
No, ma'am.
No. Right. Dr. Sudarshini, can you please switch on your slideshow?
Hola, good morning.
Yeah, it's switched on.
I don't think so. It's still showing on your primary page.
Can you exit and restart? We'll
Yeah.
re-put your time.
Yeah.
Yeah.
We'll re-put your time. Just exit and reshare your screen, please.
Aase सारे बहुत आई सकता आसे तुमकन भाभी से तुमकन गई भाभी से
Is it visible now?
आई बाबा बाजी खाली है
Yeah, could you go to switch on your slideshow?
साइबर से आगो रही हो वीडियो पर जे
Varsha, can you mute everyone?
Yes, sir.
हम
Have you switched on your slideshow?
Yes, ma'am. I have switched on slideshow.
It's not showing actually, doctor.
I think
Dr. Sudarshini, you can go to the bottom
Yeah.
right.
yeah.
Ma'am, is it okay? You
Try clicking on that.
Yeah, from beginning. Yeah.
Done. Yeah.
No, she's
No.
It's
I'll
gone.
share it. I'll just open up just a second.
okay?
Just give me a moment, Dr. Sudarshini. I have to resist him. Could you just give me a moment? I'm just opening up her presentation.
Okay.
Are you able to see your presentation on my screen, Dr. Sudarshini?
Yes, ma'am.
Yeah. Can we please have the timer restarted for her?
Just a second, ma'am.
Yeah.
Yeah, start.
Yeah. Okay, you can start.
Yes, ma'am. So, intramural, I'll be presenting on intramural hematoma following pediatric inguinal herniatomy. So, basically, intramural hematoma is very rare in children. It was first described in 1838 following a postmortem examination in an adult body. So, small intestine is the most commonly affected size, where the duodenum is very most common. It is seen mostly after blunt abdominal traumas. So non-traumatic intramural hematoma are still rare, and post-operatively, the presentation of intramural hematoma is very rare. So we had a child, a 3-year-old male child, came with complaints of irreducible hernia. The child was first went to an outside periphery center where he had an emergency right side inguinal herniatomy done. So during the surgery, the surgeon found a dusky but viable ileal loop. The loop was nothing was done to the loop. The loop was reduced inside, and no resection was done for the loop. So the child was then later examined for the post-op days, and by post-op day, the child started developing bilious vomiting, abdominal distension, all features of bowel obstructions were there. So the child, they took one CECT, and CECT showed 15 centimeter ileal segment mural thickening and narrowing. I'm slide 4.
Okay.
And
Sorry.
then the child was later referred to our tertiary care center. On arrival, the child had distension. There was bilious vomiting present, and the X-ray showed multiple air fluid levels. We tried conservative management. We tried keeping the child in the pediatric ICU and monitored it for 2 days, but the conservative management failed. So we took the child for explorative laparotomy, and during the exploratory laparotomy, we saw tense bluish ileum present. About 15 centimeter resection was done, and later during the recovery period, the child the recovery was very uneventful, and the child later got discharged on day 7th. Could you please day 7th? Ma'am, can you press once more? So this video shows that we drained about 100 ml of hematoma. I think the video is not. About 100 ml of hematoma was drained, and the whatever non-viable part of the ileum was resected out, and the viable parts, the distal and proximal loops were end-to-end anastomosis were done. The resected segment was sent for histopathology, and histopathology showed submucosa and muscularis had hematoma within them, and there was no vasculitis or no malignancy features. So they gave a diagnosis of intramural hematoma. The child was then later followed up after 3 months, and the child was healthy and active. So basically, intramural hematoma, when we think about it, is mostly caused due to trauma, where or the other causes like iatrogenic injury, bleeding disorders, anticoagulation therapy, or vasculitis. But post-operatively, it is very rare. Discussing our case, post hernia obstruction. Usually, hernia is a very common surgery which all kids undergo, and post operative obstruction in an hernia case is very rare. But we should keep an eye on it. So there was no coagulopathy or trauma identified in this child. So likely cause would have been ischemia or any trauma to the mural wall during the manipulation. While reducing the hernia, there might have been any damage to the mural wall. So the child had a rapid progression within 48 hours post-op. So CT, a timely diagnostic approach, which led us to the diagnosis of like we were suspecting any obstruction. So there was mural hyperdensity, narrowing was present, and the early exploration was done. And the remaining bowel loops could be salvaged. So what I mainly learned was, even with a simple herniatomy case, you might have some surprises. So it is better to have all aspects to keep in our mind. That's all. These are my references.
Good case, very unusual finding. I think that's where the role of pediatric surgeons come. We, the pediatricians, are very gentle in handling the tissues. May not be in this case. It was obstructed case, though. One thing we can still suspect is that there may be little handling problem may be there during the first surgery by a general surgeon. 3-year boy may be very small still. So good case.
So, Darshini, can I ask you, what would you think if there was no history of surgery? Like, do you know any causes of a spontaneous intraluminal or a intramural hematoma? What would you suspect, or what would you investigate first? As a general surgeon, what would you think? If there was no
So
history of
mainly,
trauma or no history of surgery?
I would have gone about like whether the child had any coagulopathies within coagulopathies like financial purpura or any other vasculitis features. But in our case, the child didn't have any other features like any joint weren't involved, no renal dysfunction was there. So we ruled it out, and there was also a significant history of surgery in the past. So we went ahead with that. Otherwise, we would have found this coagulopathy, and the baseline investigations were also normal.
Normal, yes. Like, if we do a CBC, we'll see platelets, we'll see INR. That's what it is. Thank you.
Thank you.
Anything else from our judges, or should we proceed?
Yeah, I think we can
Sure.
go ahead.
Yeah, all right. Okay. Thank you so much, Dr. Sudarshini.
Thank you, ma'am.
Yeah, all right. So we'll go on to our next presentation without any delay. Dr. Uday, do we have you with us? Dr. Uday? Yeah, all right. Dr. Uday is from Mehta Hospital in Chennai, from the Department of Pediatric Medicine. He will be presenting on multidisciplinary rescue of abdominal tuberculosis with ileocecal perforations and limb ischemia in an adolescent. Dr. Uday, could you please start your slideshow as well as unmute yourself and switch on your video for our judges? Dr. Uday?
Yes, ma'am.
Yeah.
Is
Could
it
you switch
visible,
on?
ma'am?
You are not visible. You are audible, not visible, but yeah. Could we have the timer, please? Yeah, switch on your slideshow. Yeah.
Yes, ma'am.
You may switch on your slideshow. Yeah, can we have the timer, please? Yeah, please start.
Good morning, everyone. This is Dr. Uday, pediatric resident at Mehta Hospital. With the guidance of Dr. Rahul, consultant pediatric surgeon, I'm going to present a case of an abdominal tuberculosis with ileocecal perforation in an adolescent, which was managed with multidisciplinary rescue. So he was a 16-year-old male child who presented with 2 years of intermittent fever, reduced appetite, and generalized weakness. With a significant weight loss from the last 3 months, presented with an acute onset of bilious vomiting, abdominal pain, and distension for the past 2 weeks. With a significant history of father receiving treatment 2 years back for pulmonary tuberculosis. On examination, the child on arrival to the ER was very sick with dehydration and diffuse abdominal tenderness and guarding, where we stabilized him managed medically, followed by undergoing a CECT abdomen which was showing peritonitis perforation with pneumoperitoneum and plenty of free fluid. In view of acute abdomen, we took up for surgery, emergency laparotomy under general anesthesia, where we could find a cocoon abdomen with multiple small bowel perforations with an extensive fecal peritonitis. The video depicting the aspiration of the fecal matter, and the child underwent an adhesion release with small bowel resection was done and a peritoneal lavage was given. Ileostomy and colostomy was done with one intra-abdominal drain in situ. So video is depicting the multiple tubercles which can be seen over the small bowel, and very bad small bowel with multiple perforations are also visible. So this is the colostomy and ileostomy opening with an intra-abdominal drain. So when we sent for the histopathological examination of the intestinal biopsy, which was showing multiple necrotizing granulomatous inflammation, which was consistent with intestinal tuberculosis. So for this, post-operatively, we had multiple challenges for the management of sepsis and septic shock, and an establishment of the diagnosis, the close differential of IBD versus the TB, and an IV ATT followed by the oral therapy. So this was a medical management at our PICU for the stabilization of the child with sepsis and septic shock with multiple inotropes and high flow oxygen support with antimicrobial therapy and antifungal. The child was stabilized within day 6 of post-operative day 6, and he was started on IV ATT initially as a child was on NPO, and with IV ATT the other case reports are being followed up. With a close differential of Crohn's disease versus the GI tuberculosis, with a clinical presentation of short course of fever, ascites, and pulmonary TB, and imaging showing necrotic lymph nodes, and colonoscopy can show transverse ulcer and petalous IC valve. With histopathology, caseating, and confluent granulomas, everything points towards GI TB. Whereas in the Crohn's disease, we'll have a chronic course with diarrhea, perianal, and extraintestinal signs. The imaging might show a long segment thickening and comb sign, colonoscopy showing the cobblestone. So this was one of the close differential. Histopathology will be showing in Crohn's disease will be the non-caseating focal microgranulomas. And the child was switched over to the IV ATT after 14 days to the oral therapy. And currently the child is doing well, gaining good, adequate weight gain is there, and is taking orally well. And the child is currently ongoing the continuation phase. He has finished the intensive 2 months of intensive oral therapy. Now the child is being planned up for the colostomy and ileostomy closure in the follow-up in the next week. The take-home message of my study is that tuberculous abdomen is and perforation is a rare entity, and managing and stabilizing pre-operatively was a very challenging, and intra with extensive fecal peritonitis and perforation. The child was post-operatively managed with ICU care and ATT therapy. Thank you.
Thank you so much, Dr. Uday. The floor is to our judges.
Thank you, Uday, for a very well managed case, good presentation. Your intro picture showed clear tubercles on the serosal surface of the intestine. So
Yes.
why did you consider Crohn's disease in this child? This is a clear picture of intestinal tuberculosis.
Yes, sir. It's a clear picture just for the since the TB abdomen was a close differential for IBD. We didn't suspect of IBD, sir. Just for the academic purpose.
This case is clearly tuberculosis.
Yes.
So I didn't get your message very clearly. What is the message from this case? Like, this is a case of tubercular small bowel perforation, came with sepsis, peritonitis. You managed with stoma and medical management, and child recovered with ATT. So what is novel in this case report?
Sir, tuberculous abdomen perforation as such is a rare entity in which you can find in tuberculosis because of the usually tuberculosis white has less perforation is because it forms a fibrinous secondary fibrinous and adhesions, because of which perforation is a rare entity. But
So
in
what
this
what is more common? I agree with you what you're saying. What is more common in
obstruction can be a
strictures and obstruction. Yeah. Okay, thank you.
And his extremely, it was an unhealthy small bowel which was resected, and the fecal exudate was too much. He was in a
well
septic
managed.
shock, sir.
Well managed. Congratulations. Thank you.
Thank you.
Thank you so much,
Nice
Dr.
case.
Uday.
Thank you, ma'am.
No,
Nice
please
case.
continue,
Okay.
judges.
Okay. Okay, nice case. I didn't understand where was the ileostomy done and colostomy. And are you going to connect these two things at the next class, or do you have placed anything blindly, any bowel you have closed blindly inside?
Sir, we did the barrier dressing and stoma bag we have kept it, sir. And
No,
next
that I
week we
understood.
are
Where is
closing
the
the
ileostomy location
ileostomy and colostomy.
and colostomy? Where is the location? I wanted to know, like what bowel segment it is. I think he didn't understand the question. It's okay.
I could not get it, sir.
Yeah. No, I'm asking in the next surgery, are you going to join these two stomas, or have you placed anything blindly closed? Anything, any loop is there and blindly inside?
No, sir. We are closing it together, sir. Like
Okay.
joining it together, ileum and colon.
Okay, fine.
Thank you so much, Dr. Uday. Any other questions from our judges, or
No,
shall
right.
we proceed to
I
the
think we
last
can
one?
proceed to
Okay.
the next one.
Right. Okay. So we'll have our last speaker for the session. That is Dr. Swapnil Singh. Dr. Swapnil,
ma'am.
are you with us?
Yes, ma'am.
All right. Dr. Swapnil, please share your screen as well as switch on your video. Dr. Swapnil is from King George Medical University from the Department of General Surgery and will be presenting on autoimmune pancreatitis presenting as a pancreatic mass in a child, a case report.
Ma'am, is my screen visible?
Yes, your screen is visible. You can start, please.
Okay. Good morning, everyone. I'm Dr. Swapnil Singh from KJMU, Lucknow, and today I'll be presenting a rather unusual case, autoimmune pancreatitis presenting as a pancreatic mass in a child. Let's begin with a brief background. I'm not able to change.
It's changing. You can.
Let's begin with a brief background. Now, pancreatic masses in children are extremely uncommon, and when they do appear, our first thought is usually a neoplasm. However, autoimmune pancreatitis, though uncommon, can closely mimic malignancy, both clinically and radiologically. So this case highlights how that diagnostic confusion can occur and what we can learn from it. So our patient was a 5-year-old girl who presented to pediatric surgery OPD 5 months ago with persistent upper abdominal pain for 5 months and progressive jaundice. On examination, she was ecteric and a vague lump was palpable in the right hypochondrium. So naturally, our initial suspicion was of an obstructive pathology, possibly malignant. Let's see what the labs showed. Her liver function tests were markedly deranged. Total bilirubin over 100 micromole per liter and alkaline phosphatase in the thousands. Clearly, these values were consistent with obstructive jaundice. So now the big question was, what's causing the obstruction? So we moved on to imaging. On ultrasonography and CCT, it showed a hyperechoic, hyperenhancing lesion near the head of the pancreas with compression of the CBD. And on MRI, there was a T2 hyperintense lesion in head of pancreas / distal CBD. These are the images of CT and MRI showing similar lesions as I have described above. So the patient was planned for ARCP. The attempt to cannulate the ampulla of Vater by ARCP failed due to angulation and compression of the CBD by mass. So based on all these findings, the picture strongly suggested a neoplastic lesion, most likely a pancreatic head tumor. So we planned the patient for surgery in order to relieve her from the symptoms as the initial conservative management, that is ARCP, failed in our case. So on exploration, there was a non-cystic firm mass which was densely adhered to duodenum, and on aspiration, it yielded no fluid. So given these findings and the preoperative suspicion of malignancy, we proceeded with the Whipple's procedure. All these are the intraoperative picture. The first image is showing the mass lesion at the second part of Whipple's procedure was carried out. This is the final resected specimen. Patient tolerated the surgery well and had an uneventful recovery. She was discharged on postoperative day 11. But the real surprise came when we received the histopathology report. Histology revealed fibrotic nodules with lymphoid aggregates and preserved pancreatic lobular architecture. These findings were consistent with chronic autoimmune pancreatitis. Interestingly, her IgG4 levels were within normal limits. A reminder that not all autoimmune pancreatitis cases have elevated IgG4, especially in children. So, what exactly is autoimmune pancreatitis? Let's review that briefly. Autoimmune pancreatitis is a benign, steroid responsive fibroinflammatory pathology of the pancreas. Clinically and radiologically, it can mimic pancreatic malignancy, hence, a true diagnostic dilemma. Although autoimmune pancreatitis has been well described in adults, there are very limited reports in pediatric population, so there is difficulty in diagnosis. In adults, we often see the IgG4 positive, that is multi-organ form, type 1, and in children, type 2, which is IgG negative and pancreas specific, is more common. So our case fits the type 2 profile. Coming to conclusion, when a child presents with a pancreatic head mass with obstructive jaundice, malignancy should not be our only thought. Autoimmune pancreatitis, though rare, should be considered. If clinical suspicion is high, a short steroidal trial could help confirm the diagnosis and potentially avoid a major surgery. Thank you. Thank you.
Thank you,
Thank you so
Dr.
much.
Swapnil. You presented very well. You said when the child, 5-year-old child, came with a lump, abdomen, and jaundice, your first suspicion was malignancy. So
Yes, sir.
that is not quite right. Before you do the imaging, if a 5-year-old child comes with a right upper quadrant mass and jaundice, what is the first DD?
So we also thought of infected duplication cyst, but
Yeah, so it should not be malignancy in a 5-year-old child. It is okay for an adult, but not in a 5-year-old child. Maybe say a choledochal cyst or something obstructed the biliary tree. Secondly, when you did the Whipple, what was your DD? What was your working diagnosis?
so pancreatic head carcinoma and pancreatoblastoma, these were the differential diagnosis.
Yeah, I will keep pancreatoblastoma even
As
above
the first.
pancreatic head carcinoma. Pancreatic head carcinoma in the first decade of life is extremely, extremely rare. And I will also like to know if you did alpha fetoprotein for this child preoperatively. You didn't
Yes,
tell,
sir.
tell us that.
So we did that.
How much was that?
So it was not in the higher
Yeah.
range. It was.
Yeah, so that is raised in pancreatoblastoma. That is how you differentiate it from a pancreatic cancer. But very well managed case. Congratulations. Thank you.
Thanks.
Any other questions? We have some more time for questions from the judges, please.
Very interesting case, Swapnil. You mostly answered everything that sir has asked. I'd just like to know, like, have you seen other cases of pancreatic tumors in your center, or was this one of the rare times that you all had
So
seen
this
one?
is, ma'am, this was the one of the rare. We haven't seen
Rare.
any. We haven't encountered.
Encountered. Very well managed case. Nice.
Right. Any other questions? I think our time is up for the questions, but any more? Shall we wrap it up then?
Yes, I think we can.
Yeah. All right. So actually, one of the candidates is not there. That is Dr. Anubhav Singh. We are not able to hear back from
Hello.
him. So
Yes, ma'am.
since we're not able to hear back from Dr. Anubhav Singh, in the event that he comes, we will permit him to try and present his paper as he has gone for an exam. So with that, this session comes to an end. I thank our wonderful judges, Dr. Ankur Mandelia sir, Dr. Krishna sir, and Dr. Supraja ma'am. Thank you so much. And any closing remarks from the judges, please?
Yeah, thank you so much, and great initiative by IAPS, especially Vikesh sir, for giving this opportunity to allied specialty postgraduates to present in Pediatric Surgery Forum, and it was a very uh, a lot of learning points in most of the presentations, and very well organized and very well managed the session, Dr. Varsha and Dr. Supraja. Congrats to all of you. Thank you so much.
Thank you,
so
sir.
much, sir. Krishna sir, any closing statements, sir? And we'll proceed to the next session.
Thank you. All presenters did very well presentations, and all the thanks to all the mentors who gave these very rare cases and good papers for the general surgery and pediatric medicine PGs. And thanks to IAPS for organizing this wonderful format for the postgraduate students to get exposed to complex pediatric surgery and rare pediatric surgical cases, so that in future they will be getting more experience about the pediatric surgery, and also they will be showing interest to the pediatric surgery, and they may join our field also in future. Thanks to everyone.
Thank you, sir.
Thank you so much. All right. Suprajam, ma'am, any closing statements, as you will be taking on the cap for the next session in
I
your
think
I'll
I'll make
double
it
role?
I'll make it an opening statement, I think. Thanks so much, Vasha.
Yeah.
We really enjoyed judging the previous session, and now we'll be starting with the next one. The third session is the pediatric urology session, and we have three very dynamic young pediatric surgeons who as judges. Our first judge would be Dr. Prabhu, who is a very driven pediatric urologist and surgeon who we thoroughly engaged with recently at SpookOn and had a great time with him. We have Dr. Abhirami, our very passionate pediatric surgeon from Chennai, who is a very well-known social media enthusiast and activist who's always spreading awareness about pediatric surgery with more than 36.3K, I'm not able to convert it, followers. And Dr. Arun Prasad, the OG pediatric urologist with high octane pediatric surgery experience and the authentic cool dude, as we call him in Chennai. We welcome all of our judges and we will go on with our presentation. We have 7 topics in pediatric, 7 presenters in pediatric urology. The rules are the same. We have 4 minutes for each presentation with 2 minutes for discussion. We'd like if 2 judges would question each participant so that we can save up on time since we are already moving a little late. Shall we start with our first presentation? Our first presentation is by Dr. Prerna Agarwal from Sri Ramachandra. She is from the Department of Radio Diagnosis. Are you here, Prerna?
Yes, ma'am.
Okay, can you share your presentation and put on your video?
Yes, ma'am.
Prerna will be presenting a paper titled Virtual Reality Reconstruction in Understanding Pelvic Floor Anatomy and Vasculature in Bladder Extrophy. Any issues, Prerna? Let us know.
Ma'am, the whole screen went away.
Okay, we can see you now. Can you try sharing your screen?
Yes, ma'am.
Yeah.
Is my
Yes.
screen visible, ma'am?
Yes, it is visible. You can start presenting. Imagine, can we have the time?
Yeah, bladder extrophy presents one of the complex challenges in pediatric urology. Traditional imaging shows us slices but not relationships. What if we could step inside the pelvis, visualize the vessels, muscles, urethra, and plan a surgery in 3 dimensions? Good morning, everybody. I am Prerna, here to present my paper on virtual reality reconstruction in understanding pelvic floor anatomy and vasculature in bladder extrophy. What is virtual reality reconstruction? It is a technology that utilizes advanced 3D models and creates immersive and patient-specific anatomic structures, which helps in surgical planning, education, by enhancing visualization of complex anatomical relationships. Background on bladder extrophy and anatomy. It's very important that we understand the pelvic floor anatomy, the bony and soft tissue anatomy, as well as the anatomy of the underreported vascular pedicle, the pudendal vessels, which are often overlooked because these can lead to potential challenges during surgical reconstruction. The aims of our study were to utilize virtual reality reconstruction to provide comprehensive visualization of pelvic floor anatomy and vasculature. We had cases of bladder extrophy, pseudo extrophy, and a normal patient as a control. We used the patient-specific 3D models and contrast-enhanced CT scans to get the virtual reality reconstruction. Now coming to the virtual reality reconstruction, here we can see that the rectus abdominis muscle has been split because the pubic symphysis is split. We have removed it and we are using VR to remove it and see how the pudendal vessels are entering the Alcock's canal. From the undersurface of the pubic bone, we can see the obturator internus muscle and we can see how the pudendal vessels are running. The process that we are doing here is called segmentation, where we are marking the intersymphysial bands. They are marked step by step in each section. And once this process is complete section by section, we can give it a color. So in this patient, we gave the intersymphysial band a blue color, which we can see over here. We can see how the intersymphysial band is holding the rectus muscles together, and we can see the penis also hanging from it. So overall, we get a very good understanding of the complex vasculature and anatomy. This results in improved surgical planning and accuracy, reduced operation time, enhanced understanding of the pelvic anatomy, which increases confidence among the young surgeons and lowers the complication rates. Here, by doing this, we are able to preserve the vascular pedicle, minimizing the risk of damage to blood vessels, which can lead to post-surgical complications. Complications such as the loss of glands or corpora can occur if the vascular supply is compromised during surgery. Understanding anatomy through virtual reality can help us avoid these adverse outcomes. So the advantages are the enhanced spatial understanding and the improved preoperative planning and reducing surgical risks. And the limitations are the high implementation cost and the technical limitations. The next generation can benefit by transforming surgical planning, revolutionizing surgical education, and using this for AI integration. I would like to summarize by saying that in bladder extrophy and potentially any complex congenital anomaly, virtual reality reconstruction can transform how we see anatomy, and it can be a roadmap for safer, smarter, and more precise surgery. Thank you.
She has 8 seconds left, sir. The judges may take over.
So very nice presentation, Dr. Prerna. So very amusing to watch your presentation actually. So what is the CT machine used for this VRR technique?
Ma'am, we have a Siemens CT machine, ma'am. We have a 128 slice CT machine which we use for this, ma'am.
Okay.
Hello, Dr. Prerna.
Good afternoon, sir.
Yeah, what other anomalies have you done with the virtual reality in your city?
Sir, we've used it for Wilms tumor, for anorectal malformations, for cloacal abnormalities, to see posterior urethral valves, and yeah, these are the ones which we are mainly using it for, sir.
Posterior urethral valves, how did it help?
Sir, when we reconstruct the CT, we are able to visualize it, and we can even go inside through the bladder, and we can travel inside and visualize the anatomy, sir.
Travel inside the bladder?
Yes, sir. We can travel inside the bladder. We can even travel inside vessels, and in tumors like Wilms tumor, we can go inside the tumor and we can see whether there is any vasculature inside the tumor and what is happening inside.
Okay, fine. What about, you also mentioned about the vascularity also regarding the this index case which you have taken.
Yes, sir.
What about the vascularity?
Like we can see how the pudendal vessel is entering and exiting through the sciatic foramen and then re-entering. So it helps us plan better and avoid injury to the vessel when we are for the surgeons, when they are operating. It reduces the complications.
You have any idea about the relation of that normal relation of the vascularity along with the penis and the abnormal anatomy, anatomical presentation, the vascularity? That's okay. That's all.
Not much.
Thank you.
Okay.
That's all.
2 minutes for discussion are up, sir. Shall we move on to the next speaker?
Yes.
Okay. Thank you, Daphne. Thank you, Prerna. Can you stop sharing your screen? Our next presenter is Dr. Daphne from Netaji Subhash Chandra Bose College, Jabalpur. She is a general surgeon and she will be presenting a paper titled Unraveling Urethral Duplication, a Case Series Experience. Daphne, if you are here, can you share your screen and your video?
Yes, good
Yes, we
afternoon.
can see you.
Is it visible?
Just a second. Yes, it's visible.
Okay. Good afternoon, one and all. I'm Daphne John, and I'll be talking about unraveling urethral duplication, a case series experience. So this is one of the most rarest anomalies with an incidence of just 1:1 lakh live births, with a 68% of predominance. In embryology, we know that the urogenital sinus rise to the urethral plate and the lateral fold, misalignment between the plate and the membrane, or an excessive growth of the mesodermal tissue gives rise to urethral duplication. Fman further classified it into three major types. So in type channels, these patients are usually asymptomatic and do not require any surgical management unless it is with UTI. Type 2 is the most common type with complete duplication. You can see that there are separate units rising the renal stenosis. Hence, we need a three-staged approach. So first is identifying the patent tract with a normal caliber and an intact internal sphincter, which is bidictum, the ventral urethra, whereas the dorsal atrial by
I think Daphne has dropped out. Can you just give us a second?
And I think something wrong with her
Yeah.
net.
Hi, Daphne.
hello.
Yeah,
Yes,
actually,
sorry.
there's a lot of lag while you're presenting, da. I think your net is not all right. Uh, would you be
Shall
able
I
to connect? Because we weren't able
shall
to
I
see your
join
slides also
again?
properly. Yes, yes. Can you do that? We'll give you 2 minutes.
Ma'am, shall I start again? Or
Yeah, start again, da. 1 second. Just give us, we are not able to see it.
Ma'am, is it visible?
Yes. Judges, we'll start again.
Shall I start now?
Yes,
Yes,
you can.
Daphne, you can start.
I'm starting the time.
Okay. Yeah. Good afternoon, one and all. I am Daphne John, and I'll be talking about unraveling urethral duplication series. So this is one of the most rarest congenital anomaly with an incidence of 1:1 lakh live birth and 60 age of male predominance. In embryology, we know that it and the lateral folds, which form the genital tubercle. Patterson and Berry has proposed that if there is a misalignment with tuber membrane,
Daphne, I'm sorry, we are still unable to hear you.
1 second.
And even your slides didn't move. Would you be able to connect to another internet connection, or you can put off your video and try?
can we move on to the next presenter meanwhile while she sorts this out?
Sure, Daphne, can we get back to you? Is that fine?
Yes, ma'am. I'll go
Yeah.
somewhere where
Sure.
connect.
Let's give her some time. Yeah.
Yeah. Okay, our next presentation is Dr. Aishwarya Roy. Are you here?
Yes, ma'am.
Yeah, Aishwarya Roy is from RGK Medical College and Hospital. She's a general surgeon and she will be talking to us about orchidopexy and the after teachings, the testicular journey. You can share your presentation and start.
Is it visible, ma'am? Hello?
Yes.
Is it visible, ma'am?
Yes. Uh, you have not shared your PPT again. We're just seeing your screen.
Yeah, now?
Yes.
Okay, I'm starting, ma'am. Okay, so good afternoon. We talk about rise in life, but here the story is of fall. So undescended testis constitutes a very common pediatric urological problem. 30% of the premature males and 3% of the term infants are usually affected. It has a lot of complications, and usually hormonal and surgical treatments are used nowadays for its treatment. So, with an aim to evaluate the clinical and functional outcome of orchidopexy in patients with undescended testes through combined analysis of prospective and retrospective cases, we did a study with the following objectives, as mentioned in the slides. So, we took 15 patients prospectively, uh, and we followed them up, did subdartos pouch orchidopexy and Fowler Stephens operation wherever it was required, followed them up for 6 months. And also we took 15 patients who had surgery in last 10 years, and we collected their data. So after that, the results came out to be that more majority of them had a delayed presentation around 3 to 5 years of age and 6 to 10 years of age. Right sided undescended testis was more common compared to left or bilateral. Majority of them 90% of them had no complaints at the time of presentation. Familial history of was associated with only one patient who had a similar complaint in the cousin. Rest of them had no familial history. 90% of the patients were full term, and hernia was present only in 2 of the patient, even though patent processus vaginalis was present in all of them. So for this slide shows the prospective 15 cases, that is 6 plus 19, 15 cases. 6 of them were clinically palpable, had clinically palpable testes, whereas 9 had clinically impalpable testes. And we during the surgery noted the position of the testes, and we followed up after the surgery, after 6 months of the surgery, what is the position of the testis, and we could find that the position was inside the scrotum, and there is no ascent of the testis, which was a good sign. Even though in one of the clinically impalpable testis, we could find one abdominal mass, as we can see in this picture. We had to excise this mass, and it came out to be non-seminomatous GCT, so it was a malignant case. And in one, we could not found the testis during surgery also. So in those 9 clinically impalpable cases, 6 we did USG. 6 USG could find 6 of the in cases. But USG was not useful in 3 of the cases. Elongated epididymis with long lobe vas was present in morely with intra-abdominal testis. Post-operatively, the size of the testis increased to be identical to the non-operative side, and other wound infection and cosmesis was well acceptable. This is for the retrospective cases, which had a minimal follow-up duration of 48 months and maximum of 120 months. We again did the intraoperative, noted the intraoperative position of the testis and postoperative position of the testis, and here also we don't see any ascent of the testis in those cases. The in the follow-up in the prospective cases, herniotomy, cremasteric division, and retroperitoneal mobilization was adequate for gaining adequate length from deep ring to upper pole of the testis, except for 2 cases where the initial length was 1.2 and 1.3 centimeters. So we have to go for Fowler Stephens lengthening surgery. Secondary sexual characteristics were normal in majority of the patients, whereas we noted azoospermia in one patient who had to undergo surgery at 28 years of age. So these are some of the intraoperative clinical pictures. So to conclude, we can say that operation can be done safely from our study around 2 years of age, and good clinical results can be achieved below 15 years of age. These are the impact of the study and future directives. Thank you so much.
So do we have time for discussion? I think the
Yes,
time is
ma'am.
up.
Yes, ma'am. We have 2 minutes for discussion.
Okay, Dr. Aishwarya, what are the three scenarios which you like to explain the patient before taking up a case of non-palpable undescended testis?
Ma'am, regarding, I would like to talk regarding the complications that can happen. So, if the patient is having undescended testis, then there is a high chance that the patient may have infertility in future. There is an increased chance, somewhere it's written around 13 times increased risk of cancer, and also
No,
there
no,
is.
no. I think you misunderstood the question. The question is in a case of a non-palpable undescended testis,
Yes, ma'am.
ultrasound is not giving you a clear picture. You like to explain something else to the parents, the attenders, before going in for surgery?
Yes, ma'am. I'll have to first consider the age of the patient, because 6 to 9 months is usually the normal age till which the testicular descent happens. So, if the patient is within 9 months, then I'll ask the parents to wait, and also I'll ask the parents to see the child while sleeping, because it can be a case of a retractile testis as well. And also, I'll look for whether the testis is an ectopic testis or not. So, I'll have to palpate and whether it is like present at some other position or maybe on the opposite scrotum or not. So I'll have to look for that also.
Okay. So, Dr. Aishwarya, so you will generally explain about the scenario of absent testis. So, in case of undescended, non-palpable undescended testis also, sometimes you will not be able to find the testis inside when you go by a laparoscopic approach.
Yes, ma'am.
And,
Yes, ma'am.
okay, that's one thing.
Yes, ma'am.
Okay, fine. We'll, any other questions?
One last question. What was the age of the child whom you had that non-seminomatous malignancy? The one which you had put a picture of the mass abdomen. What was the age of the
Yes, sir.
child when
Yes,
you
sir.
did the surgery?
That child was 3 years old, sir.
3 years old and returned malignancy.
Yes, sir.
Thank you.
So do we have time for question, doctor?
Sure, sir. You can go ahead.
Dr. Aishwarya, see, you've done
Yes, sir.
archaeopexy. Nice presentation, very well compiled series.
Thank you, sir.
You've done an archaeopexy and you're seeing the testis size is going down on the side which you've done an archaeopexy, or if it is testis size is increasing. In these two scenarios, what would you do? What would be your appropriate step?
So can you please repeat? The testis is
If the
going down.
testis size, if the testis is decreasing in its size and increasing in its size, in these two scenarios, what will you do? Can you hear me?
Yes, sir, I can hear you, sir. If the testis, as I already mentioned, that the testis after surgery was increasing in size, so it can be physiological as well, that it is trying to attain the normal size. And if it's decreasing in size, then probably it's a case of atrophy. So we have to see that whether any vascular injury is there or not, maybe during surgery. And also, if it's increasing size, so we have to also look for any malignancy if that is occurring, even that maybe rarely, but that can also occur after surgery also, sir. And maybe also there can be, sir, herniation or hydrocele formation in many of the cases where the process is vaginalis is patent. So whether it is increasing in size, maybe the scrotal size is increasing, may not be a case of testicular size increasing. It can be a case of hernia or maybe hydrocele also, sir.
Good. Thank you.
Thank you,
Thank you,
Aishwarya.
sir. Thank you, ma'am.
Can you stop sharing your screen?
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Our next speaker, just a second, I'm so sorry, is Dr. James Gio. He's a general surgeon from KS Hegde. James, are you here?
Yes, ma'am.
Can you share your screen and your presentation there? James will be presenting a topic titled A Melange of Urogenital Anomalies in a Young Male. Rohit, can we have the time?
I'll start now.
You can start.
Good afternoon. So I'll be presenting about a young male who has multiple urogenital anomalies. So this was a 17-year-old male, known case of intellectual disability, came with recurrent episodes of dysuria for the past 2 months with bilateral non-palpable testes since birth. So on examination, bilateral scrotum was empty and there was a cord-like structure palpable on the right inguinal region. There was proximal penile hypospadiasis and TANS stage 5 pubic hair distribution. So we got all the routine investigations and everything was normal and karyotyping was 46XY, normal male phenotype and testosterone was within normal limits. So we went ahead and got an MRI abdomen pelvis which showed bilateral kidneys and a cystic structure of size around 30 centimeter located between the urinary bladder and the rectum, and they've identified a left testis also which we were not able to palpate on examination. So the differential diagnosis was 46XY disorder of sexual development with hypospadiasis with bilateral undescended testis, could be a persistent Mullerian duct syndrome or a prosthetic utricular cyst. So the plan was to do a cystoscopy followed by a laparoscopic excision of the cystic structure. So cystoscopy, we noticed a very trabeculated bladder with the opening at the veru, which we were able to negotiate with the scope, and it opened into a spherical cavity which was filled with urine. There was one more opening that was below the current opening, which we were not able to negotiate, and there was no posterior urethral valve present. There was a circumferential anterior urethral valve which was corresponding to the membranous urethra. So intraoperatively, this is the laparoscopic image that we got. This was the cystic structure, which was posterior to the bladder, and the tubular structure, which we thought would be the ureter or a fallopian tube, and the right gonad and the left gonad. This procedure was converted into an open procedure owing to the difficulty in dissection, and on opening the patient, the feel and consistency was more of muscular, and this was the final outcome, the specimen that we retrieved, which we sent for histopathology. So on histopathology, the cystic structure showed duplicated bladder lined by transitional epithelium with hypertrophied muscle bundle, and the cord-like structure showed ureter lined by transitional epithelium with squamous metaplasia, and the section from the left testis showed Leydig cell hyperplasia and seminiferous tubules containing only Sertoli cells. So this is the specimen after this is the initial picture that I had shown. Now with the histopathology report, we were able to identify the cystic structure as a duplicated bladder. The cord-like structure was the ureter, and the end was the left testis, and the other, which we thought was the right gonad, is the urachal remnant. This is the marked picture, again the intraoperative picture, which shows the urachal remnant, duplicated bladder, ureter, and the left testis. On the right side is a diagrammatic representation of the patient complaint that we had seen. So normally for bladder duplication, we normally have the complete sagittal or complete coronal section classification according to Huffman. But in this particular patient, we saw a completely duplicated bladder along with the ureter with an absent kidney. And there was an left testis, which we were not able to palpate. So the conclusion from this was urogenital anomalies can be complex and can occur in various permutation and combination because of the complex sequence of events in the embryological developmental process. This is the first documented report in literature that we found having a duplicated bladder opening into the prostatic utricle, a duplicated bladder which is completely independent of the bladder, and duplicated ureter ending blindly with an aborted kidney. So a clear understanding of the genetic and pathological process in the development of these structures can explain most of these causes that we have encountered. Thank you.
Thank you, Gio. Well within time. Over to the judges.
Very interesting case, doctor. You said that patient was 17 years. So previously, any investigations done? Has he gone for any diagnosis and all?
So the patient came to us with an outside USG report showing a cystic structure. The patient party was telling us they have not gotten anything evaluated. He had recurrent urinary tract infection, but they were getting antibiotics from an outside hospital. But for 17 years, they did not get him evaluated for this particular complaint in specific.
Okay.
Good presentation, doctor. I would just like to you to go back to that diagrammatic representation which you have done. Yes, yes. Which was the absent kidney, dysplastic kidney, which you were mentioning? That part I'm not able to understand.
So the patient had bilateral kidneys on MRI, bilateral kidney was there. So we were
Okay.
mentioning that the patient had a duplicated bladder along with the ureter, but there was no kidney, no renal tissue was there. Instead of the renal tissue, there was a left testis.
So
This ureter was a blind ending on histopathology. This ureter was a blind ending and extension was a left testis. There was no renal tissue.
what was the HPE of that bladder specimen?
Sorry,
HPE report? Biopsy report.
Biopsy report showed it as a duplicated bladder and a ureter, sir. No renal tissue is put in biopsy, sir.
Can you repeat that, doctor? I'm sorry.
There was a duplicated bladder, sir, and a ureter. There was no renal tissue on histopathology. The pathologists were not able to identify any renal tissue.
Was there any muscular remnants present in the duplicated bladder?
Duplicated bladder had, sir. They gave us a transitional epithelium with hypertrophied muscle bundle, sir. This was the duplicated bladder's histopathology.
I'm just wondering whether it's just a prostatic utricular cyst, which where
Our initial doubts were a prostatic utricular cyst, sir, but then pathologists were very confident about that. Even the feel and texture of the cystic structure was more muscular, sir.
I just thought it was just a left testis with that vast difference draining into the prostatic epithelium. Thank you. It was a good presentation. Thank you so much. It was an interesting case.
Thanks.
Doctor, do you have time?
Yes, sir. Please do ask a question, sir.
Yeah. Doctor, very well presented. Very nice case, interesting one. So, you are a general surgery resident, so I would ask you, can you give us 2 or 3 more differentials for the cystic structures in between the spine and the bladder in a male child?
So it can be a Mullen duct syndrome or a prostatic utricular cyst. Other DDs that we can take in this.
Anything related to spine? Anything related to tumor? Okay. That's all, doctor. Just for completion of academics. Thank you.
Thanks.
Thank you, James. A nice presentation. Shall we move on to the next presenter? Can you stop sharing your screen?
Yes.
Our next presenter is Ramya Ranga. She is from Maharaja Institute of Medical Sciences, Neelamai. She's a general surgeon and she'll be presenting a case titled Rapid Onset of Yolk Sac Tumor in a Toddler with Undescended Testes. It's a case report. Ramya, can you share your screen and put on your video?
Is it visible now? Hello. Hello, am I audible?
You're heard very softly, Ramya, not really audible.
Okay. Is my screen visible?
Yeah, your screen is visible, you're audible and visible now. Okay.
Yes.
Can you go to slide presentation?
Yeah. Is it visible now?
Still not in presentation mode. It's disappeared.
Is it visible now?
Yeah, we are still in the PPT mode. You've not gone to slideshow yet.
Is it changing?
No, you're not in slideshow yet. We are just seeing your presentation. Could you go to slideshow and put current slide? Maybe that would work. Yeah. Not yet.
For me, it's changing.
It's not for us yet. Give it a try one last time. Otherwise, I'll share your slides. One second. Yeah.
Is it changing now?
Noda, can I try sharing?
Yeah, sure.
Just one second. Just give us a second. Is it seen for everyone?
Yes, yes.
Yeah, okay. You can start. Can you start timer, please?
Yeah, thank you.
Yeah, start.
Good afternoon, everyone. Myself, Dr. Amya Tumla. My guide is Dr. M. Srinivas from Department of Pediatric Surgery. Today, I'm going to present a case report on rapid onset of yolk sac tumor in a toddler with undescended testes. Slide. It is yolk sac tumor, also known as endodermal sinus tumor, is a malignant germ cell tumor, mostly occurring in age 3 years of age and in males. Clinicians must recognize its rapid onset and hallmarks features to avoid delayed diagnosis. This report highlight a case of rapidly developing testicular yolk sac tumor of undescended testes in a toddler and discusses the clinical approach and the prognosis. Our case, a 2-year-old male child presented to us with an left impalpable testis, and surgery was deferred due to upper respiratory tract infection. After 6 months, the patient presented with an asymptomatic lower abdominal lump that gradually progressed over 6 months without pain, any other symptoms. Next. On examination, a firm non-tender mobile mass was palpable in left lower abdomen, and the right testis was descended and normal. So we investigated the patient with serum, with keeping malignancy in mind. We investigated the patient with serum alpha fetoprotein and beta human chorionic gonadotropin levels, which came out to be normal. And we proceeded with an abdominal CT, which revealed a 9 into 5 centimeter well-defined lobulated heterogeneous mass extending from the left iliac fossa to the suprapubic region. So we proceeded with the surgery, and we approached the patient. We approached the tumor with exploratory laparotomy, and we continued with the total tumor excision along with adjacent lymph node dissection. And with the post-operatively, the tumor confirmed to be an prepubertal type yolk sac tumor, and immunohistochemistry stains positive for CD117 and glypican 3 and negative for CD30 and OCT3 and 4. In post-operative course, 1 month post-operatively, we repeated the serum alpha fetoprotein and beta HCG. Alpha fetoprotein level came out to be 10,000 international units per ml, and beta HCG remained normal. So we have sent for the patient for metastatic workup with PET CT, which revealed an 25 into 18 para-aortic lymph node with no other metabolically active lesions. So he underwent 4 cycles of chemotherapy with cisplatin, etoposide, and bleomycin regimen, and without any significant side effects. And post-operative, post-chemotherapy 4 years, the patient remained disease-free and with normal serum tumor markers and PET CT. Discussion. The incidence of pediatric testicular tumors is 0.5 to 2 per 1 lakh children, accounting for 1 to 2% of all pediatric tumors with bimodal peak occurrence. Initial peak was in first 3 years of life. And Alani et al. Found that yolk sac tumor is the commonest pediatric testicular tumor of about 43%. And the yolk sac tumors in children usually presents as in painless testicular swelling with elevated AFP levels. However, rapid growth in the intra-abdominal testis with normal AFP is seen in this case, but it is a rare condition. It has been reported only one case priorly. A similar presentation with preoperative normal levels of AFP is established in presumed to be due to torsion and necrosis of tumor. Yolk sac tumors in undescended testes, especially intra-abdominal, could be multifactorial. Impaired germ cell maturation leaves undifferentiated cells to prone to malignancy. Chronic heat exposure disrupts the DNA repair and increases the oxidative stress. And abdominal growth factor further promote tumor growth. Potential explanations may be small tumor burden, intra-abdominal tumor location limiting the systemic marker diffusion, altered tumor marker expression, torsion-induced ischemia suppressing the AFP secretion. So it has been hypothesized that torsion may impair secretion and postoperative rise in the AFP, reflecting the detorsion and delayed marker release into the circulation. So whether earlier orthopexy might have prevented or delayed tumorigenesis is speculative. Early orthopexy, ideally 6 months of age, is recommended if spontaneous descent does not occur. And delayed orthopexy has a risk of 5 to 6 times increase of malignancy. It should be explained in preoperative counseling. Conclusion. In summary, this case illustrates the rare but aggressive presentation of yolk sac tumor in an intra-abdominal testis with potential atypical AFP patterns and critical importance of timely orthopexy and vigilant follow-up in the managing cryptorchidism. These are my references, and thank you.
Thank you, Ramya. Can we, the judges can take over. Abhirami ma'am, Arun sir, Prabhu sir.
Yeah, it was a very good presentation, and the importance was the unique thing was in this case was like AFP values, isn't it?
Yes, sir.
How did you come to a conclusion that it was because the AFP didn't go because of the torsion?
Intraoperatively, we have found a torsion of the tumor, sir.
Okay, because of that, but even then, AFP markers can still be raised. Is it a possibility?
Yes, sir. But immediate post-operatively, the tumor markers were in normal range. When we repeated after 1 month, it was rose to around 10,000.
Right. All right. Since we're short of time, I think. Yeah. Yes, sir.
I had a question. Doctor, if you're okay, if you have time.
Yes, sir, we have 1 minute left.
Yeah. Doctor, very well presented regarding this case, particularly when AFP is not shooted up. It's really tricky. Yeah, and good collection of literature as well. So, Dr. Ramya, I have two questions for you. You said, so this child, you are initiated with pebreginil, right? If I get it right. So,
Yes, sir.
with or without bleomycin, you're supposed to go with 2 other chemotherapies, inevitably in these cases, right? So,
Yes, sir.
what exactly the preoperative workup you would do before initiating this, initiating the chemotherapy? What is the pre-chemotherapy workup you do, and why you do it?
Priorly, like because these have an side effects of nephrotoxicity and ototoxicity, so we have to get ENT checkup done and renal parameters.
Okay. What is DND? ENT checkup. What exactly is what that's what
Like hearing test, we have to
not
rule out.
2-year-old child. Okay. Then another question. You said this is the yolk sac tumor. What's the most common tumor that is associated with your undescended testis? Ignoring the age, what is the most common tumor? Now you presented a tumor.
Seminomas is the most common, sir, in adults, but
fine, absolutely.
Yes.
Yeah.
In children, yolk sac tumor, some literature showed yolk sac tumor, and some literature it was teratoma, sir.
Okay. But you should be very specific to the age. Anyways, absolutely fine. Yeah. Another question I have is, you said 5 to 6 times the risk of running tumors in children with undescended testis. So what does exactly that 5 to 6 times means? Was that a relative risk? Was that odds ratio? What exactly that you wanted to tell us?
Relative
What
risk.
exactly that statement means 5 to 6 times? Is it
Relative
something
risk
to
of
normal public, or because it's very specific question? Yeah. Or is it something to do with comparison to children with undescended testis, or is it the normal children? What is that you wanted to? I'm
it
going
is
to the
when compared to the descended testis, sir.
as a so you meant to say with normal children,
With
the risk
normal
is
children.
5 to 6 times.
Yes, sir.
Okay, you just have to read up that area, right? Thank you. Very good, very well answered. Thank you.
Thank you, sir.
Thank you, Ramya. Thank you, judges. Shall we move on to the next speaker? Our next speaker is Dr. Abhirami. She's from Sri Ramachandra Institute of Higher Education and Research in Chennai. She's a general surgeon. Can you share your screen and put on your video?
Yes,
Abhirami.
Is it visible, ma'am?
Yes. Abhirami is going to be presenting a paper titled Transcutaneous Electrical Nerve Stimulation versus Oxybutyrin in Children with Overactive Bladder, a prospective randomized study. Once Rohit starts the time, we can... Yeah, you can start.
Thank you for the introduction, ma'am. I'm Dr. Abhirami, and like she said, I'm going to be presenting on transcutaneous electrical nerve stimulation versus oxybutynin in children for overactive bladder. I'm doing this under the guidance of Professor Ramesh Babu sir from the Department of Pediatric Urology in Chennai, Sri Ramachandra Hospital. So overactive bladder in children causes urgency, frequency, incontinence, and daytime wetting, which leads to low self-esteem and depression in the school-going children. Usually treated with anticholinergic drugs like oxybutynin, it's commonly used, but it causes multiple side effects, usually leading to poor compliance and drug discontinuation. Neuromodulation with TENS doesn't have side effects. However, there is an exact protocol and relapse rate, and TENS is not studied. This picture shows the parasacral TENS. So a meta-analysis was done in our hospital on the role of TENS in overactive bladder, and it showed that the response was better in the TENS group when compared to other treatments, and patients completed the treatment. It was effective as a standalone and as an adjunct therapy. So in our study, we aim to compare the efficacy of parasacral TENS versus medical management in treatment of overactive bladder. We tried to assess the patients with overactive bladder and studied the pre and post TENS to analyze whether this therapy had subjective and objective improvement in symptoms. We also studied the efficacy in side effects and compliance of TENS with other medications, and to compare the relapse rate of TENS with other medications. So it was a prospective randomized control study done in our hospital for a period of 2 years. We had 30 patients in the pre and post TENS in each limb, and 30 patients in TENS versus medical management. We used 10 hertz frequency at 200 microseconds pulse width for 20 minutes duration. It was given every day for 4 weeks. We included children in 5 to 18 years age with symptoms of overactive bladder after evaluating and treating bowel symptoms. We excluded patients with neurological abnormality, obstructive uropathy, UTI, and uncontrolled bowel bladder dysfunction, which we ruled out with these investigations. This is the TENS being done. So the outcomes were studied both on subjective and objective methods. The subjective was frequency wetting episodes, and objective was the OAB index and DVSS score. So out of the 60 patients, we followed them up for about 6 to 12 months and excluded the dropouts, and none of them crossed over to the other treatment, and additional therapies were not given. So the bar graph shows us that the frequency and wetting episodes, that is the subjective ones, decreased significantly in both the TENS and the oxybutynin therapy groups. And the OABI and the DVSS, the scores improved following TENS and oxybutynin, but the improvement was better among the TENS group. The Euroflow graph also confirms our findings, which we saw in the bar graphs. In detail, there was a complete response in 24 patients in the TENS group when compared to only 18 in the oxybutynin group. And there was a side effect present in 16 patients in the oxybutynin group when compared to only 1 in the TENS. Relapse rate was also more, that is 7 in the oxybutynin when compared to 2 in the TENS. So while TENS is effective as a medical treatment, the side effects and relapse rate are significantly less. The limitations of my study is that we had a small sample size. A long-term follow-up past a year was not included, and TENS as an adjunct therapy was not studied. There is also the limitation of hospital visits. Parents will have to take time off to bring their children every day, and children are more likely to miss classes. This can be overcome by home visits, by taking home TENS to home. And the study has also not performed cost analysis because we offer the treatment free of cost during the study. So we need to do further studies to perform a cost-effective analysis. So I'd like to conclude by saying that TENS therapy is as effective as oxybutynin in controlling overactive bladder, and it has a both subjective and objective good response. However, the side effects of TENS and the relapse rate is significantly less, hence allowing a better patient compliance in the TENS group. So these are my references, and thank you.
Such a wonderful paper, Abhirami. Over to the judges. She's well within time.
So, doctor, it's a very nice presentation. So, I just wanted to ask you, what will be the time duration of each TENS?
So, it was for a duration of 20 minutes, ma'am, each session. 20 minutes continuously it was given.
And the children were compliant with that. Was there any complaints during the procedure?
No, most of the children, they were comfortable lying down. It was just made to lie down. We could also put on some music. They can watch cartoons also during the time. So they were mostly compliant with this.
Okay, and there's a question in the group. 20 minutes for how long? And can you answer the question?
I'll put this in my methodology. It's 20 minutes for a duration of 4 weeks. It was given every day. We had a 10 hertz frequency and a 200 microsecond pulse width setting.
Okay, and did you give this for bowel bladder syndrome also, like when the child has constipation? And have you tried this in that also?
No, ma'am. Actually, in our study, we took that as part of the exclusion criteria and we
Exclusion.
gave it only for the overactive bladder patients.
Okay.
We have another minute. The judges can continue discussion.
Dr. Well presented, Avirami.
Thank you.
I have a question for you. Like, how exactly, what is the difference between TENS and PENS? There is some entity called PENS as well, right?
Pens and tens. Okay. In tens, I know there's a type of parasacral and
What,
posterior, but
what is it?
in a
Okay, the
posterior,
second question is, you are going with a parasacral
yes.
electrical stimulation. Is there any other way to do your TENS?
We can also do it in the posterior tibial nerve stimulation, sir. It's called
Do
posterior.
you do it? Do you do it?
No, in our study, we did. We gave only the parasacral to the S3, sir.
Okay, nice. And another question I have is, even there is a recent. I mean, by the looks of your presentation, you are a little above our basic presentation. So I would like to go with one more question. See, even recent systemic analysis says that tends along with anticholinergics are better. So what is your take on that?
Yes, sir. I have read in a couple of studies that the adjunct use of TENS along with the anticholinergics is better. In our study, we did not do that, and that is a limitation. Following studies, we'd like to do that and see, sir.
Do you observe any improvement in the, like the other judges have asked you, in the improvement of the constipation in your study while you are doing this tense?
Well, one thing we compared with the anticholinergics is that while anticholinergic itself has
Constipate. Yeah.
side effect of the constipation, TENS did not actively have a side effect causing constipation, but we did not check whether it improved whether a child had constipation. We did not.
Well answered. Thank you, doctor.
Thank you, sir.
Thank you so much, Abhirami. Can you stop sharing your screen? Our next speaker is Dr. Saurabh Maurya from Netaji Subhash Chandra Bose Medical College and Hospital. He will be presenting a paper titled Two Flip Matthew, Innovating Glans Augmentation in Small Glands. Saurabh, can
Good
you
afternoon, ma'am.
share your screen?
Yes, ma'am. Is it visible, ma'am?
Yes. Can we have the time? Yeah, you can start, Saurabh.
Good afternoon, everyone. My topic is two-flip Matthew technique in distal hypospadias with small glands, a technical innovation for glans augmentation. To start with the basic, gland size is an important predictor for distal hypospadias repair. Less than 14 mm gland size is defined as small. Complication rate is usually 25%. If the gland size is small, that is gland dehiscence, meatal stenosis, functional urethral obstruction, and urethroperitoneous fistula. Gland size can be increased by using preoperative hormonal stimulation. Distal hypospadias with urethral plate less than 8 mm and gland size less than 14 mm is challenging. In this study, distal hypospadias patients who have adequate gland size and urethral plate have undergone TIP urethroplasty and is excluded from the study. Patient with urethral plate less than 8 mm and adequate gland size have gone for conventional Matthew repair, and patient who have inadequate gland size and urethral plate had a need for gland augmentation. In two flip Matthew technique, the flap is of 1.25 times longer than the uh, urethral plate. This excess TMF flap is then flipped backward on itself to bridge the narrow glands and trim to the shape of it to augment the distal part of the glands. In this slide, interop image 2C shows the Matthew flap, which is long enough for the second flip. Objective of this study is to compare the outcome of two-flip Matthew vis-a-vis conventional Matthew in distal hypospadias with small glands who are unsuitable for TIP. It is a historical type of study taken place in NSCB Jabalpur and Shriyar Chennai from duration 2021 to 2023. In preoperative evaluation, metal position, glance width, urethral plate and premetal skin quality and absence of body is evaluated. Inclusion criteria is distal hypospadias with urethral plate less than 8 mm. Gland size more than 14 mm is taken in group A for conventional Matthew repair, and gland size less than 14 mm was taken for two-flip Matthew. Exclusion criteria is body after degloving, patient who need redo surgery, and patient who are more than 12 years of age. Comparing the result of group 1 and group 2. In group 2 have glands width comparatively smaller than the group 1. In complication, group 1 had more incidence of glands dehiscence and needed more repeat procedure. Other complication are comparable in group 1 and group 2. Comparing cosmetic outcome in reported by parents, parents have reported better glance aesthetics and overall cosmetic satisfaction in group 2 patient. In post-operative image here show 3B and 3C show better slit-like meatus, and 3D show slide fish mouth of the meatus. In conclusion, gland size and urethral plate caliber are critical determinant for the success of hypospadias repair. For inadequate urethral plate, Matthew is a time-tested alternative. It avoid any complication associated with TIP. Two-flip Matthew is better alternative than conventional Matthew if the gland size is inadequate. Two-flip Matthew has less glans dehiscence repeat procedure and has improved glans cosmesis. A limitation of this study is that it is only limited to distal hypospadias. Uh, it has fish mouthing, which can be reduced by fastening of V flap. Skin used for augmentation has altered appearance and texture, which over the time merges with the glands. Enhancing the tissue for glands reconstruction is reinforcement rather than the augmentation, which is a misnomer. And patients with urethral hypoplasia and poor quality of perimetal skin are unsuitable for this procedure. These are my references. Thank you.
Thank you, Saurabh. He is well within time. Can the judges can take over?
So, okay, if I can ask you, Dr. Saurabh, well presented, very nice series. If I can ask you a question, what is the basic principle of a flap? What should be the breadth versus the base versus the length of the flap when you're taking any flap?
Sir,
To ensure
usually
that
ratio
flap
should
survival.
usually 1:1 ratio is taken for the flap, but in Matthew we have taken 1.25 of size of the
That's a
urethral plate,
basic
sir.
plastic surgery principle. That's the question I have. But your answer is not exactly to the point, but you have to little, read up and refine that. It's not 1.25. Another question I have is there an objective way of, see, for example, you're taking a flap and you're trying to again do a flip flap onto the ventral aspect, which is double flip. That's what you're trying to say.
Yes,
In
yes,
that,
sir. Yes, sir.
yes. How do you ensure the vascularity is intact at the end of the procedure? Is there an objective way in assessing the vascularity?
Mhm.
I'm sorry, I think it's a little loaded question, but yes. Okay, you can, any other, it's okay, just have to read up. It's a completion of academics. Do not be too worried about it. Yeah. Any
Yes,
other questions from other judges? Thank you.
thanks, sir.
Any other judges have any more questions, or shall we move on to the last presentation?
Yeah, we
we'll
can
go.
move on.
Okay. We'll be getting back to Daphne.
Thank you, sir. Thank you.
Thank you. Saurabh, can you stop sharing your screen? Daphne from Jabalpur, she's a general surgeon and she'll be trying to present her case titled Unraveling Urethral Duplication, a Case Series Experience. Daphne, are you here?
Hello?
Yeah,
Yes, am I
Daphne.
audible? Am I
Yes, you're
audible?
audible. Yes, Daphne. Do you want me to share the presentation or will you try?
I'll try
Okay.
sharing. Is it visible?
You have to put present, yeah.
Is it
Yes.
visible?
Yes. Can you turn your screen so it will become bigger for us?
Yeah. Okay.
Done.
Is this fine?
Yes, it is. Can we start the timer?
Yeah.
Daphne, you can start.
Good afternoon, one and all. I'm Daphne John, and I'll be talking about unraveling urethral duplication, a case series experience. So this is one of the rarest congenital anomaly with an incidence of just 1:1 lakh live birth with a 68% of male predominance. So we know that from embryology, the urogenital sinus gives rise to the urethral plate and the lateral folds, which forms the genital tubercles. So Patterson and Berry has proposed that if there's an abnormal relationship or a misalignment between the tubercle and the membrane, or an excessive growth of the mesodermal tissue, it will give rise to urethral duplications. F-Men has further classified it into three major types. So in type 1, you have incomplete or blind ending pouches. These patients are usually asymptomatic and do not require a surgical treatment unless they have UTIs. In type 2, you have complete duplication, in which there are two separate urethras arising from the bladder. So they present with double stream of urine with constipation and obstructive features. And we have a three-stage repair for these patients. So first, we identify the urethra with a normal caliber and an intact sphincter, which by dictum is the ventral urethra. Then we dissect the dorsal atriatic urethra. A perineal ureterostomy is done and a neo-urethral reconstruction can be followed. Type 3 being the rarest of all, we even have duplication of the bladder and it needs a multidisciplinary approach. So we were fortunate to have around 22 different cases in our institute. So in this case, we can see that in the glans of the penis, you have two urethral meatus. Dye study concluded that the ventral one was patent, whereas the dorsal one was atriatic and blind ending, and it's a type 1A. In the second, we can see that there's a type 2A to Y type of duplication with the posterior urethral valve in the ventral urethra, making it even more rare. So we proceeded with a urinary diversion vesicostomy was done, and then valve ablation for the posterior urethral valve to cystourethroskopy. The ventral urethra was identified and relocated, whereas the dorsal atriatic one was excised. Then using penoscrotal flap, we made a common pathway, and after patency was achieved, the vesicostomy was closed. So these are the post-operative images where you can see a single patent tract in dye study. So this is an exception to the rule of Y duplication. In this case, the dorsal tract appeared to be patent, whereas the ventral was atriatic. So we just proceeded by excising the ventral tract. In this case of Y series, the patient also presented with constipation and had anal stenosis. So first we did a loop sigmoid colostomy. Then we tried to translocate the ventral tract, which was ending in the perineal region, and Padua was tried for the dorsal tract, which is where we introduced feeding tubes of increasing caliber to increase the patency. But since it failed, we used a penoscrotal flap. And after that, a vesicostomy and colostomy was closed. So what is one important thing we have to remember is that circumcision should be avoided because the foreskin can be used as a future flap for the new urethra. So in a nutshell, urethral duplication is a very rare anomaly. We need hands of experienced pediatric surgeons and urologists to tackle this with thorough knowledge of anatomy. It is also essential to classify these so that we can have a tailored surgical management. And here we have a case of diaphalia with anorectal malformation, which needs a multidisciplinary approach with a multi-stage procedure. So thank you.
Thank you, Daphne. She was well within the time limit. The judges can take over.
So, Dr. Daphne, very interesting case series. So, I just wanted to ask you about F-Man's class 2A,
Yes, ma'am.
where you will have two draining urethra. How will you decide which one to be preserved and which one to be closed?
Ma'am, we can look at the flow and the caliber. So if we do an RGU and if the prostatic urethra of either the dorsal or the ventral appears to be narrow, we can close that tract. Or if both appears to be patent, then we can do a common channelization procedure also.
Will that be easy for you to common channelize? Because that will be coming all the way from the bladder neck to the exterior, right?
It won't be an easier method to common channelize, ma'am, but we will. I don't have that much knowledge about it, but
That's
I
okay.
just.
Okay, being a general surgery resident, talking so much about pediatric urology is amazing. Did you see this type of case in your case series?
Yes, ma'am.
Okay, so what was the management in that?
In that, one of it was had an atreatic segment at the prostatic urethral. It was narrower, so we had excised that one, and we had only kept the ventral one patent, ma'am.
So any of your cases needed vesicoscopy?
The one with the posterior urethral valve, we had to do a cysto. We had to do a vesicoscopy,
Not
ma'am.
cystoscopy. Vesicoscopy is something different, which you'll go from the dome of the bladder to visualize the urethral orifices.
No, ma'am, we had not done that procedure for any of the
Or any,
cases.
okay, fine. Okay, yeah. Well presented.
Thank you.
Do you have any more questions from the judges?
Arun Prasad, do you have any question?
No, we can proceed.
Thank you,
Yeah.
Daphne.
Okay, Dr. Daphne, I have one. Do you have time for one question, doctor?
Yes.
Sure, sir.
Yeah, Dr. Daphne, well presented. I'm very much impressed with the way you told one should avoid circumcision in these kind of children. Very happy about that. And the question I have is, see, the type 2A, which you're describing, you being a perennial urethrostomy and managing is a very complex entity. So in this, the most common complication is the fistulas that can reoccur to the rectum as well. So my question to you is, can you name a muscle that is described in the literature that is useful for bridging in between the rectum and as the in between the rectum and urethra, which is commonly used to avoid this fistulas? If you read through the literature, sorry, it's a too much of a question, but yes.
I have heard that we can use buccal, mucosa, and Q flaps.
But not muscle. Please read up. It's a very interesting topic, but I was very impressed with your. Thank you. Thank you.
Thank you. Thank you, sir.
Thank you, Daphne.
There is no need for circumcision. There is no circumcision should not be performed. Very nice.
Yes. Thank you.
Thank you, Daphne. Thank you, judges. This is the end of the urology session. We've completed the third session right now. Can we have some closing statements by our judges? Dr. Prabhu?
Yeah, yeah, it's very wonderful. In fact, these residents from general surgery speaking about pediatric urology, I'm amazed to listen to, and particularly emphasizing statements like, somebody should not do a circumcision and what should be followed up in a test post orthopexy. So people are exactly knowing this is what a general surgeon should know. I'm very happy that in IAPS is getting into such a kind of niche areas to train the general surgeons. Thankful to IAPS for both this opportunity and as well as chairing the session. One tip I would suggest for all the residents out there is keep to the time. And second thing is, if you're presenting slides in this kind of forum, follow the principle of 5 and 10, which is like, you should not exceed 10 slides at any point, never exceed 5 lines in any slides. So this is a simple thing so that you can be at ease. Yeah, thank you. Thank you, guys.
Thank you so much, sir. Dr. Abhirami?
Yeah, congratulations to all the presenters and thank you organizers for this opportunity. These sessions are always reminders that we never stop learning. So these presentations, I learned new insights and innovations, and these were not there when we were training, like the virtual reality and all. It's always a learning points for us. Even though we are sitting as a judges, we learn very new points from the junior colleagues. Thank you.
Thank you, ma'am. Arun, sir? Any closing statements? Dr. Arun?
Hello, can you hear me?
Yes, sir.
Yeah. So it's been a great presentation by all of them, and I would really like to congratulate all the presenters, especially with all the very deep and complicated topics, including all the range of all construction anomalies. And their knowledge and their preparation was spot on, and they're quite impressed with all their efforts and the way they presented. And few of them, the slides also was like really amazing to watch. And congrats to all. All the best.
Thank you so much, sir. Thank you to all the participants and the judges. I think we'll quickly move on to session number 4. Our coordinator for the same will be Rohit. Rohit, you can take over.
Thank you so much, Supraja ma'am, and a very good afternoon and warm welcome to everyone joining us online. Thanks to all the senior coordinators, respected judges, and all the PGs for such amazing sessions. Now we would proceed with session number 4. I would like to start the session by introducing our judges. It gives me immense pleasure to introduce our esteemed judge, Dr. Prabodh Goyal sir, Professor of Pediatric Surgery at AIIMS New Delhi. Sir is a leading name in pediatric urology and neonatal surgery, widely recognized for his research and innovative surgical techniques managing complex congenital anomalies. Sir has numerous national, international, and publications to his credit and is deeply involved in teaching, training, and advancing pediatric surgical care in India. We are truly honored to have him today with us to share his insights and experience. Next, we have Dr. Gurmeet Singh, sir. From King George Medical University, Lucknow. Sir is an accomplished pediatric surgeon with expertise in neonatal surgery, pediatric urology, and hypospadias repair. He has several research publications to his credit and is actively involved in clinical work, teaching, and academic training of young surgeons. We are delighted to have him today to share his guidance. Now, also, we have with us Dr. Tanmay Motiwala, sir, as our judge. Sir is a distinguished pediatric surgeon and urologist trained from AIIMS Jodhpur and currently practicing in Raipur, Chhattisgarh. Sir is known globally for his expertise in minimal invasive pediatric and neonatal surgery, but also as a Yuva icon, social media influencer, and a finance expert and a trainer, inspiring thousands of young professionals. He actively promotes balanced growth, excelling in medicine while encouraging financial literacy and personal development amongst doctors. Thank you, sir, for being with us to share your knowledge, experience, and energy. To begin with the session, first, I would like to begin with the session. First, I would like to remind everyone with the rules. We have 4 minutes for presentation and 2 minutes for discussion. We'll be keeping the timer on the screen, but it is advisable for the candidate to keep a timer with them as well. This session has 7 presenters. The first presenter is Dr. Devam Baderia, General Surgery PG from Netaji Subhash Chandra Bose Medical College and Hospital. Dr. Devam?
Yes, good afternoon, sir.
Good afternoon. Can you please share your screen?
Yes, sir.
Dr. Devam will be speaking on making statistics effortless through AI, my learning as a MSPG. Devam, can we start?
Yes, sir. Just a second, sir. I want to do. Just.
Can we start?
Sir, is my screen visible?
Yeah, it is visible.
Yes, sir. Good afternoon, everyone. Today, I would be speaking about making statistics effortless through AI, my learning as an MSPG. Statistics is the backbone of research, but often difficult for us postgraduate. Many of us find this confusing, time-consuming, and error-prone. We all know the advantages of AI. We can use this for thesis, for clinical research, for publications. I would be talking about my journey using AI to understand statistics and how it can help others. We have many available tools for performing AI assistant for available for statistics, but I have used Julius AI in my presentation and in my clinical work. How should data be for statistics with AI? The data has many qualities, but most importantly, data should be in numerical form. It should be complete. Cells should not be empty. Data should be clean, and it should be accurate. Now I will come to the examples. We have first I will be talking about parametric and non-parametric tests. We commonly use parametric and non-parametric tests in our day-to-day statistics. We have like I will be talking about t-test and chi-square test. In this, we have to upload a Excel sheet. Then we have to write the appropriate prompt that what we desire. Like in this, I had uploaded my table and I have described about in what variables I need my Casper test and t-test. It will evaluate the data table and it will give us the result of the table, and it will interpret the result and will show us what is the actual result of the table. Then I would be talking about regression. It is a statistical method used to study relationship between a dependent variable and one or more independent variable. Here, with the same team, I have uploaded my data table and have given the prompt to the AI that I need R-square value, odds ratio, ROC curve, and Gaussian whisker plot. It has evaluated the table by Python, and it has given me the graphs and the tables with the interpretation of the charts. Next, I will be talking about ROC curve, receivable operating characteristic curve. It shows how well a test distinguishes between two groups. On y-axis, we have true positive rate, that is sensitivity. On x-axis, we have false positive rate, that is 1 minus specificity. To interpret the curve, and we have curve closer to the left has a better accuracy, and higher area under curve shows better test results. With the same similar table and the prompt, I have received the ROC curve. The ROC curve gives a graphical way to evaluate a test across all possible thresholds. In this, like an example, we can say that in a head trauma patient with a what would be a poor GCS score? If that we know that the poor GCS score is 8, we evaluate the patient and we provide the table to the data. It will show us that how accurate our GCS score is. Then I come to the meta-analysis. It combines results from various studies to get a precise overall estimate. In this similar way, I have uploaded my table and I have given the prompt to the AI to interpret to make the meta-analysis in the form of forest plot, funnel plot, pool heterogeneity stats, and risk of bias. It has made the charts and tables, and it has given me the results and the interpretation of each of the charts and the table. It helps us to get the results in this form. Then I would be talking about inter-rater reliability. It measures the consistency agreement between two or more raters assessing the same subjects. Common measures are Cohen's kappa between two raters, Flee's kappa more than two raters, inter-class correlation, and percentage agreement. I would like to end my presentation with Indian mathology learning from Abhimanyu. The Chakravarti from Abhimanyu. Taking lesson from this story, we should learn to use AI judicially, ethically, and not getting trapped into Chakravarti of AI. Thank you.
You were well within the time limit. I would like to proceed to the judges for any discussion.
Okay. Thank you, Devam, for a nice presentation. Am I audible? Can somebody confirm?
Yes,
please?
sir. Yes.
Yes, sir. Yes, you are audible, sir.
Okay. So, Devam, it was a nice presentation. In fact, AI is the need of today, and
yes, sir. Thank you.
It's nice that you thought about it. But when you were presenting about AI, I'll ask you one question and help it to illustrate what you missed out. So, like when we were discussing about inter-rater reliability, you talked of Fleece kappa, and what was the other kappa?
So, Cohen's kappa, inter-rater correlation. Yes,
so,
sir.
when do you use either of these tests? So, what are those situations when you would use either of these?
So, we use Cohen's kappa when we have two. We use Cohen's kappa when we have two raters. We use Fleece kappa when we have more than two raters.
So exactly. So now you come to my point. So the first point is, which we somehow missed out, is that a basic knowledge of biostatistics is essential. Because use of AI is not a substitute to a basic knowledge of biostatistics. And see, I understand you're a resident and I am a teacher. So as a teacher, I always tell my resident, the first thing is that it's not a substitute. So when you're using it you can use it to enhance your presentation, but it should not go back on your learn. So this is just a suggestion. Now, my second thing which we missed out mentioning was that when we are giving the prompts, do we tell the AI tool which test to use, or you would prefer the AI tool to suggest you? If you are preferring that the AI tool should go by suggestion, how do we ensure that this is taking the right test and it is not hallucinating? So hallucination is a third limitation. Having said this, you come to the fourth limitation of AI tools is you talked about AI in general. However, as far as I understand, each AI tool has its own strong and weak points. So there's an AI tool which is good for generating review of literature. There's another AI tool which can be customized for biostatistics. The third one is for generating photographs.
Yes.
And my final comment
Yes.
here is that you presented a single instance of analysis. I think we could have better given this a format that we tried running maybe a sample size of 10 different analyses, and we realized that in these 10 analyses, maybe 7 times the AI was just perfect. It was hallucinating 2 times and it was giving inappropriate tests 1 time. So that could have given it the form of a research. But having said that, it's a new thing. It's innovative. I appreciate your idea. At least somebody ventured into that. I'll allow the other judges also to take their questions. Tanmay and Gurpreet, please. Gurmeet, sorry.
Very nice presentation.
Thank you, sir.
Am I audible?
Yes,
Yes, Gurmeet.
Yeah, very nice presentation, Dr.
Thank you,
Devam.
sir.
As sir said, I would like to add on this that the AI is addition to our knowledge to biostatistics, not a replacement for the knowledge. And
Yes,
one
sir, yes,
more
sir.
thing.
So it will help us supplement what we know. It will help us to we are not substituting the AI with the knowledge. We are just helping us to get the interpretation. So as a residents, we are in the check with the our consultants for the AI.
Okay, one question is that do you have incorporated AI in your curriculum, in MS curriculum?
No, sir. We are just with the help of AI, we are just not substituting it with the studies.
No,
We are
no.
just
Have the AI been added in your curriculum? Because at some institutions they have
No, sir.
added the use of AI in the curriculum.
No, sir. No, sir. No, sir.
Okay, thank you.
Thank you.
Thank you, Devam, for a great presentation. Just
Thank
one
you.
quick question from my side is how do you ensure the reproducibility of the results that you are doing using your AI tools? And second is, what do you think, should there be a disclosure on your front if you are using it for publication so that there is a transparency on the prompts used to get such sort of result?
So we do the analysis by different platforms or not, and with the same platform also we do it twice or thrice to see that it is precise or not. By this basis, we are seeing that the AI what results we are getting is precise and accurate by different platforms and by repeating the results.
Okay, thank you.
Thank you, sir.
Thank you, sir. Thank you, Devam, for such a good
Thank you,
presentation. Can you stop sharing your screen now?
Yes, sir. Thank you, sir.
Dr. Preeti? Dr. Preeti, can you hear me? Dr. Preeti Rea Pinto?
Am I audible, sir? Good afternoon.
Yes, you're audible. Can you please share your screen?
Yes, sir.
Dr. Preeti, your slides are not visible now.
Is it visible, sir?
No, not yet. Yes, the slides are visible now. Can you switch to the slideshow mode?
Yes, sir. So are the slides visible?
They are visible, but not in the slideshow mode. Can you start the slideshow mode?
For me, it's slideshow.
Okay, it's
For
not
me, it is in
visible.
slideshow mode, sir.
No, for us, it's not visible in the slideshow mode. Can you just go to the slideshow button and start from beginning?
Or Dr. Preeti, you can also exit and try to start it again.
Is it visible now?
No.
There's a button here. I am not sure if my pointer is visible, otherwise I'm hovering my pointer over the button. At the bottom right side where you have the slider for Zoom, just before that.
No, actually, I think that button has been pressed, but it's still not showing. Dr. Rohit, do you have her presentation with you? Yes, we got it now.
Wonderful.
There. So the next presenter is Dr. Preeti Ria Pinto, General Surgery postgraduate from Yenepoya Medical College. She would be presenting on retrospective analysis of clinical profile and management of pediatric chronic pancreatitis in a tertiary care center. It has again gone to the normal window.
Is this okay?
No, previously it was visible in the slideshow mode, but now it's not
Rohit,
visible.
if you have her
Yes,
presentation now,
it's there.
maybe
It's there now, ma'am. We can start.
Yes,
Yeah,
sir.
we must start.
Yes,
Good
Dr.
afternoon, everyone. I'm Dr. Preeti. Today, let's look beyond the stars to the life of pancreatitis. When we think of chronic pancreatitis, we often focus on the enzyme. But in children, this does not just affect the pancreas, it shapes the entire world. Pain, which is not just for days or weeks, but for years. Pain that keeps them away from school. Pain that it would trigger an attack. Some are unable to play in class or even spine for days. It can also cause financial constraint on the parents and ultimately can progress to diabetes and lifelong enzyme dependence. So we conducted a study to analyze the clinical spectrum of pediatric chronic pancreatitis and to look for the treatment strategies in the three different categories, and the celiac. A retrospective observational study was conducted. Medical records of children less than 18 years were collected based on presenting symptoms, episodes, nutritional status, school attendance, and the radiological findings. Follow-up at least 12 months was done, followed by descriptive analysis was done. So the results that I found was 50% were
I think,
48%
Preeti, sorry, I'm interrupting you. I think your slides are not changing, number one, and your voice is cracking. So is there something that you can do to improve your internet connection?
Preeti, if you want, we can share your presentation
Yeah.
and you can just go on talking. Is that okay?
Dr. Rohit,
yes,
you
sir.
can share her presentation from your system and she can just give the voiceover as you change the slides. Have you shared your presentation with him, Dr. Preeti?
Yes, I'm shared with you.
Okay. Okay. Can we restart her time?
Are the slides visible now?
No, actually, it's not yet visible in your voice is also, I think there's an issue with the network, possibly, Dr. Preeti, if you could check on that.
Ma'am, can I get back for the next presentation? I'll check on my internet connectivity, ma'am.
So I think that's a good idea. Meanwhile, we can go with the others and you can maybe if you get a good Wi-Fi somewhere.
Yes, sir.
We can go to next presentation.
Dr. Somtirtha Roy, am I audible to you? Can you please start?
Yeah, yeah.
Yes, sir.
Yeah, Rohit, you're audible.
Can you
Yes,
please
sir.
share the presentation? Can you please share your
Sure,
screen?
sir. Sir, it is audible?
Yes, you're audible. Can you please start the slideshow mode?
Sir, is it audible?
Yes, you're audible and your slides are
The
well.
side flow is
So
yes.
we have
Thank you,
Dr.
sir.
Somtirtha Roy from All India Institute of Medical Science, Rai Bareli. He is a general surgery PG and he's going to present on outcomes of harmonic scalpel assisted clipless laparoscopic cholecystectomy, a prospective observational study. So we are starting with the time, Dr. Somtirtha.
Thank you, sir. Good afternoon, sir, everyone. Today, my topic for paper presentation is outcomes of harmonic scalpel assisted clipless laparoscopic cholecystectomy, a prospective observational study. Securing the critical view of safety is the cornerstone in the laparoscopic cholecystectomy. Clips which are used in common practice can have dislodgement or slippage. There can be inadequate closure due to mismatch. There can also be late cholecystectomy clip migration. If we use suture during ligation of the cystic pedicle, that can have long learning curve or increased operating time. Electrocautery used in general practice can have lateral thermal injury or burns. Sparks can ignite the volatile fluids or gas inside the operation theatre. Alternatively, harmonic scalpel, which is used, can act as multiple instruments. There is less production of smoke and there is less lateral thermal spread. So there is less risk of viscera-related injury. A prospective observational study was done at a single center, IAPS Abhimanyu, in the Department of General Surgery and Pediatric Surgery from July 2023 to December 2024. 63 patients were included in our sample whose age were more than 12 years. The primary objective was to know the incidence of post-operative bile leak following the sealing of cystic duct by harmonic scalpel. The secondary objectives were to know about the other complications. Intraoperatively, we included all the patients whose diameter of cystic duct was less than 4 mm. So, if the cystic duct could be easily accommodated in between the two blades of harmonic scalpel, its diameter is thought to be less than 4 mm and it is cauterized by harmonic scalpel. Also, we have confirmed with inserting a 12 French Giles tube from one of the ports and the diameter of the 12 French Giles tube is 4 mm. So, if the cystic duct diameter is less than this 12 French Giles tube, then it is cauterized with harmonic scalpel. Here you can see the additional lysis is being done by harmonic scalpel and the cystic artery is being cauterized with harmonic scalpel. Here, the gallbladder is being separated from gallbladder fossa of liver. Out of the 63 patients, 9 of them were of pediatric age group, and out of them, 25% have distended gallbladder. 2 of them had short cystic duct, and 2 of them had accessory right hepatic artery. And critical view of safety was achieved in all the patients. The gallbladder perforation rate in our study was less than the previous clipped cholecystectomy series. There was also no lateral injury to the viscera, no conversion to open surgery, and there were no any other bile duct or any other artery injury. We did ultrasound whole abdomen of all the patients before discharge, which showed no evidence of any bile leak. There was also no need for secondary intervention. Mean hospital stay, mean VUS score, and mean duration of the operation were less or comparable to other clipped cholecystectomy series done by Sharma et al. And Liao et al. In the follow-up 6 months, there was no evidence of any bile leak or any other complications. So, conclusion is the harmonic scalpel is safe, efficient alternative to clips or suture for ligation of cystic duct less than 4 mm of diameter. It offers shorter operating times, faster recovery, and favorable outcomes. However, its superiority needs to be further evaluated by RCTs. Thank you, sir.
Thank you, Dr. Somtirtha. I would now like to move judges for any discussion.
Thank you, Somtirtha. That's a nice study. In fact, we have been doing this for almost 5 to 6 years now in our institute, and we have presented it in IAPS Con before. So I agree that hormone scalpel works good, especially in the pediatric cases. I want to ask you one question and make one small comment. My first question to you is, how did you calculate the sample size?
Actually, the sample size is calculated with the actually the AIMS library is a new institute, relatively new institute. So we took the sample size by the whatever the patients have come to our hospital, we would include all the patients. We took convenient sampling, and total around 200 patients were operated in our institute during those 1.5 years. And out of them, 63 of them were included because 63 of them had cystic duct diameter less than 4 millimeter. Rest of them were excluded because they were more than 4 millimeter of diameter, or they were excluded due to some other reasons like acute cholecystitis or concomitant choledocholithiasis or frozen calors, etc. Sir.
Okay, so otherwise, if you it would otherwise, how do you calculate a sample size? So are you aware what are the considerations for calculating a sample size?
So sample size is calculated with due to the prevalence and also the alpha error. So if the prevalence is suppose p, then p into 1 minus p by d square, and there is also a constant 1.96 z square is there, it's constant. So if we take that the absolute error or the p value can be 5%. Normally it is taken as 5.
So which means that you could have calculated sample size here also, but anyway, that's fine.
Yes, sir. Yes, sir. Actually, according to that level, if we find that gallbladder perforation, the incidence of gallbladder perforation in the previous studies is around 20%. So if we take that into consideration, the sample size was around 157.
No, but why would you take into consideration gallbladder perforation? You
Sir,
should take
because
into consideration the factors that you brought about, like slipping of the clip and other things. No, see, your
yes,
using harmonic scalpel is not meant to increase or decrease the incidence of gallbladder perforation. But anyways, I'll let it be here, and I'll ask Tanmay to go ahead with the questions.
thank you, sir.
Great presentation, Somnita. What was your lowest age in which you did the particular procedure, and did you find any challenges while using the harmonic?
So the lowest age of my parents, it was 15 years, around 14 years, 7 months. It was around 15 years, and is in fact the challenges were to make the patient and the make the mothers or the parents understand the what is the thing we are doing, and the main as such there is no extra other challenges in the pediatric surgery age group. However, larger studies can be done and should be done to validate this harmonic scalpel instead of these clips.
Thank you.
So, Soumitra, your minimum age was 14 years.
Yes, sir.
So you didn't do any lap cholecystectomy in less than 12-year child.
No, sir. Our actually, sir, this is a comparatively newer procedure. So we wanted to confirm with the this 12 to 18 years first. Then after that, we will also in the future we will do this study below 12 years also, sir.
Okay, so any ethical clearance was taken before doing this, starting this study?
Yes, sir, definitely. The ethical clearance was taken from our institute ethical committee, and it was received prior to doing this procedure.
Okay, so what is the indication or what is the size of the gallstone that you take into consideration before going for these cholecystectomies?
Actually, sir, in our this Raebareli is a prone to this carcinoma gallbladder section. So all the patients who presented with symptomatic cholelithiasis or who presented with gallstone, we have taken all them, and we have planned for laparoscopic cholecystectomy for all those patients because of higher incidence of carcinoma gallbladder. And in the pediatric age group, we took all the patients who came us with the symptomatic cholelithiasis.
Because we are seeing a lot of patients that have got a very small size of the gallstone, like 4 mm, 3 mm. So would
Yes,
you
sir.
go for such a cholecystectomy in these patients, or would you try to wait for some time and then keep them on a regular follow-up? Because in the because it is being said that a gallstone may convert into a carcinoma gallbladder after 20 years. So
Yes, sir.
these kids are very small, and doing surgery in them because there is no clear-cut guidelines for that. So
Yes, sir, definitely.
what is the take of these on in
So
your institution?
we definitely can wait for some time for pediatrics age group, especially if they are less than 12 years or less than 10 years of age. We can, of course, if they are asymptomatic, then we can wait for some years. If they let them to grow up, and then after that we can to such procedures.
Okay, thank you, Soumitra. I think we are running
Thank you, sir.
out of time.
Thank you, sir.
Thank you, sir. Thank you, Soumitra. Can you please stop sharing your
Thank you,
screen?
sir.
Can you please stop sharing your screen from YouTube?
Yes.
Next, we have Dr. Arohi Gupta. Dr. Arohi,
Yes, sir. Good
can you
afternoon,
please-
sir.
good afternoon. Can you please share your screen now?
Yes, sir.
Can you put it in the slideshow mode?
Yes, sir. Sir, is the slides visible?
Yes, the slides are visible.
Okay.
Please turn on your video.
Yes, sir.
So now we have Dr. Arohi Gupta from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. She is a pediatric medicine and neonatology PG. Her paper title is A Term Boy with Cyanotic Episodes, Respiratory Failure, and Bilateral Emphysema. Can we start the timing, sir? Please start, Doctor.
Good afternoon, everyone. I'll discuss a rare case of a term boy with cyanotic episodes, respiratory failure, and bilateral emphysema. So slide is not moving. 1 second.
You can use the arrow keys if you want.
Yes, so slide is not moving.
You can just click.
आपका PowerPoint hang हुआ होगा.
एक बार शेयर अनशेयर करके फिर से शेयर करना.
Yes, yes.
See, probably it's about internet. It's taking time.
Yes, sir. Now it's moving.
Okay.
Yes.
Please start again.
Yes, sir. So this baby was born to a prima gravida mother by non-consanguineous marriage, and her antenatal period was uneventful. There were no maternal risk factors, and TIFA scan was normal, showing no gross congenital malformations. Also, baby immediately cried after birth, was shifted to mother's side, breastfeeds were initiated, and was discharged on day 2 of life. So after discharge, in the second week of life, baby had 2 episodes of fluid discoloration of entire body, which was triggered by crying each time and resolved after 30 to 60 seconds duration. But post-event, baby was stable and was alert and was accepting fees. There was no history of any abnormal movements during the event. The parents had consulted an outside practitioner where sepsis screen was done and it was negative. But in view of recurrent episodes, they were referred to our side on day 25 of life. So at our center also initially baby was stable vitally and general examination, systemic examination was totally normal. But at 4 hours of admission, again baby had a desaturation episode which was observed during crying and was accompanied by increased work of breathing. So at that time, baby had tachypnea, increased work of breathing, cyanosis was present, but there was no overt anomalies. So retractions with no murmur or auscultation, no hepatomegaly. So this is the video of outside when the baby was with the mother at home, showing the cyanotic spell. These spells were intermittent. It was not a persistent cyanosis. And this video is showing when baby was at our center, again during the cyanotic episode, where we are trying to do knee chest position, suspecting congenital heart disease, tetralogy of Fallot, which is the most common cause in TED spells. So the working diagnosis was term AGA male baby with recurrent cyanotic spells under evaluation, query dynamic airway obstruction. Our differentials were congenital heart disease, laryngomalacia, severe GERD, vascular rings, TEF, CPAM, pulmonary sequestration, foregut duplication cyst, and mediastinal cyst. So the causes can be multiple like cardiac, pulmonary, neurological, or hematological, and also hemoglobin deficit dysfunctions. So initial investigations was received a normal negative sepsis screen and echo was done, which was normal. MRI brain was also normal. So there was no clue to the diagnosis yet. Hence, we did a CT thorax with angio, where it showed a fluid field density of 16 by 15.5 and 25 mm size, which was abutting the trachea and both main bronchi. These are the CT images. So on day 4, baby deteriorated and required ventilator support, high frequency ventilation, but baby was not improving. There was hypercapnia, which was progressively increasing, and the X-ray was showing emphysema. So now we needed an emergent surgery to be done. But before that, to stabilize the baby, we did a selective right mainstem bronchial intubation, which was life-saving in this baby. Hence, posterolateral tracheotomy was done. The cyst was completely removed, which was abutting the trachea, and there was remarkable improvement in the baby. Gradually, baby was discharged. The cyst was lined by pseudostratified columnar epithelium, which was suggestive of bronchogenic cyst. So these cysts are primarily found in the mediastinum, mainly on the right side, can be paratracheal, intraluminal, or intramural, and can present with wheezing, recurrent pneumonias, and respiratory distress. So postnatal CT is the primary modality of choice, and various case reports have been done, but very rare in newborn, where baby presents very early. Hence, selective right lung ventilation and surgical excision was life-saving in our case, and CT scan proved to be very helpful for the diagnosis. So presently, baby is stable and is in our follow-up completely fine. Thank you.
Okay. Can I go ahead with the questions?
Yes, sir.
Okay. Thank you, dear. Arohi, that's a nice case. I have one comment and couple of questions.
Yes, sir.
When you presented, you gave an impression that because you did not have a diagnosis, you went ahead with the CT with angiography. I think it would not have been like that. You would have gone ahead with a CT scan, and based upon the findings, you would have decided to go with an angiography.
Yes, sir.
Anyways, we are short of time, so we generally club things together. What is the message that you're trying to give it to the youngsters by this case?
Yes, sir. So in this case, I want to highlight that this baby had episodic cyanosis. It was not a persistent cyanotic disease. Hence, we were suspecting dynamic airway obstruction since the very beginning. But since cyanotic heart disease are the most common cause, we tried to do maneuvers to improve the oxygenation. But due to the strong suspicion, we initially looked for the X-ray where we did not get any clue. The other investigations were also done, including the echo, which was normal. And because of recurrent dynamic airway obstruction, which we were suspecting, hence we went for a CT scan, because we also wanted to rule out other airway malformations like CPAM, bronchopulmonary sequestration, any vascular rings. Now, these vascular rings can only be seen in angio. So sometimes double aortic arch that may compress the trachea and can lead to such episodes, can also lead to dysphagia. There are enteric duplication cysts. There are multiple anomalies in the lung parenchyma and in the airway. So that is why CT is helpful. MRI can also be done, but then it is a long time-taking process, and baby was very unstable. So that way, we had counseled the parents. They were already in denial. So the need of emergent surgery was explained to them. And meanwhile, baby was also acutely deteriorating. We were unable to ventilate the baby because of tracheal obstruction. Hence, right lung ventilation.
Can I interrupt you? I'll ask my question again. In one line, can you tell me what is the message you're trying to give to the youngsters?
Yes, sir. Sir, my message is to keep a high index of suspicion in such cases for regarding the foregut malformations, that is bronchopulmonary malformations. They are very rare in neonatal phase, but this baby can present with wheezing, stridor, episodic cyanosis, where surgery is a standard treatment, but selective right lung ventilation proved to be life-saving in this baby, and which was a challenge to stabilize pre-op.
So one thing is that's the routine. It's not different from the standard. One suggestion, you might have compared your departmental experience with bronchogenic cysts and let us know that how this case was different as compared to what you routinely get. See, that's what a case report is all about. कि normally हमें सारे बच्चे आते हैं जिनके 2 पैर होते हैं, एक बच्चा है जिसके 3 पैर थे. But I do appreciate your effort. One last thing which I'm not able to comprehend, this was selectively compressing one bronchus, right?
Sir, it was compressing mainly the right bronchus and the trachea.
It was somewhere trachea also, and that was the reason for cyanosis.
Yes, sir.
So why did you admit in the first place and not the cardiology people?
No, sir. Cardiology people don't admit newborns, sir. And they don't have the facilities to ventilate also newborn babies. So we only admit sick
If it was
patients.
a patient of tetralogy of fellow, even then you would have admitted.
Yes, sir. Yes, sir.
Okay, thank you. Gurmeet, you can go ahead with the question, please.
Very nice presentation, Dr. Arohi. One thing, as Sir said, what is the message that you want to give in this case report is that we should have a high index of suspicion for these patients, and early high resolution HRCT is a simple procedure which can be done, I think, very easily, can be diagnostic in these patients. So one question is that what is the how long did you intubated this patient in the post-operative? Was the patient extubated just after the surgery, or you had an elective post-operative extubation?
Sir, we had extubated the baby after 24 hours of surgery on non-invasive positive pressure ventilation, and gradually the support was weaned off, sir, over 2 weeks.
Okay, so first of all, it was an intubation, then NIV, and then the oxygen.
Yes, sir.
Simple
Yes.
oxygen. Okay, thank you.
Just one quick comment from my side. Thank you so much, Arohi, for a really nice presentation. I think we have, patient's eyes or nothing was blurred in the entire presentation. We have the patient details. All the baby of Supriya was written. We can remove identifiers in such a forum,
Yes,
so that
sir.
it's good for the privacy. Thank you so
Yes,
much.
sir. Yes, sir. Thank you, sir.
Thank you, sir. Thank you, Dr. Arohi. Can you please stop sharing your screen now?
Yes, sir.
Next, we have Dr. Arvind Krishna. Dr. Arvind, can you please share your screen?
Yes, sir. Is my screen
No.
visible,
Yes.
sir?
Now it's visible. Can you put it in the slideshow mode and turn on your video, please?
So now I put in slideshow. Is it visible?
Yes, it's visible. Yes.
Slide, sir.
So, now we have Dr. Arvind Krishna from Mehta Multi-Speciality Hospital from the Department of Pediatric Medicine and Neonatology. He will be presenting on recurrent tracheoesophageal fistula in early childhood, a multidisciplinary approach. You can start.
Yes, sir. Good afternoon. I'm Dr. Arun Krishna, here to present a case of recurrent tracheoesophageal fistula in early childhood under the guidance of Dr. Rahul, pediatric surgeon. Coming to the index case, Master X, 2-year, 2-month-old male child, a known case of type C tracheoesophageal fistula, operated in UK at day of life 2. Following the repair, he had multiple episodes of life-threatening pneumonia, and a diagnosis of recurrent tracheoesophageal fistula was made. And he underwent multiple bronchoscopic glue applications and ablation procedures in the past for recurrent symptoms, which were unsuccessful. Following life-threatening pneumonia, we was started on NG feeds, and the child was shifted to India for further management. And with this child, the strategy we planned was fistula closure and esophageal anastomosis, which was technically challenging as the child had extensive salivary leak and multiple episodes of pneumonia for the past 1 year. So we went on to do a right thoracotomy, and there were dense additions from the previous surgeries, which were released meticulously with a combination of blunt and sharp dissection. And the fistula was identified at a level of carina, which was 2 centimeters wide fistula. And as the fistula was divided, the endotracheal tube jetted through the thoracic cavity. So we have to push the endotracheal tube into the left bronchus, ventilating the left lung. Meanwhile, the pediatric surgeon swiftly suture the trachea, and we have to bring that endotracheal tube up and so that we can ventilate both the lungs equally and make sure the baby doesn't go for desaturation and bradycardia. So we needed a pericardial flap at the tracheal end. So we made a triangular flap, and this is a flap that is applied at the tracheal end, vascularized flap. And the esophageal ends were trimmed and closed with Vicryl. And the anastomotic site was strengthened with intercostal flap, and the intervening PTFE graft were placed, and the wound were closed in layers, and the ICD was kept, and the wound was closed. Coming to the post-operative challenges we faced in PICU, coming to the ventilation, when we give a high-pressure ventilation, there will be a tracheal blowout, which will be a catastrophe. Whereas if you go for a low-pressure ventilation, it will be an inadequately ventilated lung, leading to hypoxia and pneumonia. And adequate sedation to prevent the child from coughing, straining, and excessive salivation. Appropriate antibiotic coverage and management of hemodynamic instability. And while the child was in mechanical ventilator, we needed to put in gentle suction on endotracheal tube and maintaining the NG tube in situ. And POD day 3, you was started on NG feeds. And POD day 4, child was extubated in view of clinical improvement. And on day 5, a bedside barium swallow was done, which revealed no contrast leak, and there was a free flow of contrast from oropharynx, hypopharynx to stomach. So started on oral feeds on day 6 and discharged on day 7. So he was followed up 6 months post surgery. Now he is gaining adequate weight, tolerating oral feeds, and there were no episodes of pneumonia. So this is a child who is taking oral feeds after a very long time, comfortably, without any aspiration. And the same child who happily celebrated his birthday after so much struggle in the hospital. So the learning points from my presentation is that recurrent TEF is a multidisciplinary team approach, ensuring comprehensive and coordinated patient care. And managing this is technically challenging surgical procedure, which needs to be anticipated. Experienced pediatric anesthetists providing safe and specialized anesthesia management is needed, and post-operative optimization in the PACU with close monitoring and expert intervention with adequate knowledge about the pediatric surgical techniques is a vital role. Thank you.
Thank you, Arvind. I would like to move to the judges now for the discussion session.
Thank you, Arvind. It's a nice paper. Tanmay, would you want to start the question answer session?
Yeah, Arvind, a really nice presentation. Just one question from the academic side. What are the signs that you would like to see when you are suspecting a recurrent TIF?
So there will be recurrent episodes of pneumonia which are unexplained, and there will be recurrent aspirations will be there, sir.
And
If
how
it is in the later part, we'll suspect TIF, sir. Immediately in the newborn period, there will be saliva, excessive drooling of saliva will be there. So if it is the later part, there will be recurrent episodes of pneumonia and aspirations.
And how would you like to work up? How would you?
So we'll go for an in the newborn period, we can put an NG tube and take an X-ray. If there's a coiling of the NG tube, then it's recursive fistula. And if
we're talking about recurrence, right?
Recurrence, we can go for barium swallow, sir. So you can look for a leak.
Okay.
And then you can go for bronchoscopy and look for any open fistula presence.
Okay. Thank you.
Thank you, sir.
Gurmeet sir? Nice presentation, Dr. Arvind.
Thank you, sir.
One comment, the coiling of infant feeding tube will be seen in esophageal atresia.
Yes, sir.
So esophageal atresia is a different entity and tracheoesophageal fistula is a different entity.
Yes, sir.
It can be associated with esophageal atresia, or esophageal atresia can be without a pure esophageal atresia, as you might be knowing. One thing is that how will you, suppose you want to do a CT scan in this patient?
Yes, sir.
How will you ask the CT scan person when should he shoot the CT scan? In the expiratory phase, when the child is crying, or in the inspiratory phase to see the fistula?
Sir, in the inspiratory phase.
Over to Prabhuth, sir.
ठीक है, Gurmeet. I'm fine with the questions. We can close this paper. Go to the next one.
Thank you, sir. Thank you, Arvind. Now, Arvind, can you please stop sharing your screen? Dr. Mane, Hema.
Yes, sir.
Can you please share your screen and turn on your video? Please put it in the slideshow mode.
Yes, sir, it is in the slideshow mode.
Yes, now we can see that. Next, we have Dr. Mane Hema Varun from Kalinga Institute of Medical Sciences, Bhubaneswar, Odisha. He is a general surgery PG, would be presenting on acute empyema in children and role of VATS, a retrospective analysis of cases in a single tertiary healthcare center. We'll be starting the presentation now.
So, one second, sir. I'm unable to.
Okay. Just unshare and share it once.
Yes, sir. Is it?
Just a second. Please run 2 or 3 slides. Yes. Okay. You can start from the beginning now.
Good afternoon, everyone. My name is Hema Varun, third year resident, surgery resident, Kalinga Institute of Medical Sciences, Bhubaneswar. And today's my topic of presentation is acute empyema in children and role of VATS, a retrospective analysis of cases in a single tertiary healthcare center. So, following bacterial infection, pleural effusion is commonly develops as a complication and is referred to as parapneumonic effusion. If it is left untreated or non-resolving with medication, it will progress to a purulent collection known as acute empyema. Empyema occurs in 3 stages: exudative stage, fibropurulent stage, and an organizing or chronic phase. So the early stages are generally managed with an ICD or intrapleural fibrinolytic therapy. However, if there is no improvement in the signs and imaging results, we can proceed for a surgical intervention. And recently, video-assisted thoracoscopic surgery has become the preferred method over open thoracotomy due to its minimal invasive nature and better recovery outcomes. So our aim of study is to assess the role of VATS as a treatment modality. And we have focused on identifying the preoperative, intraoperative, and postoperative factors. Also, additionally, the long-term postoperative outcomes, which include the leftover disease and recurrence. So our study design is a recurrent cohort study, and the population are all children who are admitted in pediatric surgery and diagnosed with acute empyema and have undergone VATS between January 2022 to March 2025. So our inclusion criteria is stage 2 and stage 3 diagnosed cases and non-resolution of empyema on chest X-ray after 48 hours of ICD insertion, and exclusion criteria are incomplete documentation and patient presenting with who have undergone VATS for other conditions and cases which are lost to follow-up, and patients who have undergone VATS and came with residual empyema in outside hospital. So our sample size came out to be 22 children, and results are out of the 22, there are 15 patients were male and 7 were female, and 15 had right-sided and 7 patients had left-sided empyema. Our mean age was 7.4 years, and concurrent systemic infections were seen in 3 patients like TB, scrub typhus, and typhoid. 2 patients had congenital anomalies like hernia and seizure disorders, and preoperative ICD insertion was done in 13 patients. Symptoms, fever was the most common symptom, and patients and associated with
Dr. Himmavarun, we are not able to hear you clearly.
Mane, you can turn off your camera. Yeah, so that
patient operatively. 8 patients had frank pus, and due to dense adhesions, out of 22 patients, 3 were converted to overcord. And positive for around 2 patients, and immediate extubation was done for 11 patients, and mean ICD removal time for first ICD was 3.1 days, and mean ICD removal time for the second one was 9.8 days. So 1 patient was discharged with ICD in place due to air leak. Satisfactory lung re-expansion on chest X-ray post ICD removal was seen in 21 patients, and after 1 month follow-up, normal respiratory examination was seen in 20 patients, and complete radiological resolution was seen in 15 patients. After the 3-month follow-up, complete radiological resolution was seen in all the patients, and no residual or recurrent empyema was noted. These are some examples. This is the preoperative picture with ICD insertion, and this is the intraoperative where we can see dense adhesions, and this is the postoperative picture, and this is after the removal of first ICD, and this after 1 month follow-up. This is another example of a patient with left-sided empyema and his intraoperative findings. This is the postoperative image, and this is after 1 month follow-up, and this is after the 3-month follow-up. So our discussion, our postoperative outcomes were largely positive, and lung expansion was satisfactory in almost all the patients, and complications like air leaks and postoperative fever was rare and manageable, and we did not observe any residual or recurrent cases. Our results supported earlier studies that surgical intervention early way leads to quicker resolution and excellent outcome. The conclusion is VATS is a safe and effective procedure in managing acute empyema, and that does not respond to medical or intercostal range. It is associated with faster recovery, shorter length of hospital stay, and almost nil rate of reintervention compared to other methods. My references, and thank you.
Thank you, Dr. Mane. I would like to move to the judges for any discussion.
Dr. Mane, it's a nice presentation. I'll just ask you one question before I hand over to the other judges. What is the message you want to give to our audience? Try to summarize in 1, maximum 2 lines.
Sir, if we can early intervene, we can early identify the symptoms and we can go for early intervention. post like VATS, like we can reduce the post-operative complications in patients and reduce the recurrence.
So how early would you recommend a surgery? Or what would be the transition when you would say, okay, let's stop the conservative management and now it's a surgical case?
Sir, the symptoms, and they're almost in stage 2 and stage 3. So it would be better if we can intervene within 1 week if there are no resolution of symptoms on conservative management.
Have you been following this regime in your department?
Yes, sir.
Okay, thank you.
But most of it's our hospital being a tertiary. Our hospital being a tertiary center, most of the patients who came here were already conservatively managed outside, and they have come with non-resolution. So they came in a pretty late phase. So they were already stage 3. So go for.
No, but otherwise, are you able to convince your pediatrician that they should refer you the case that early?
Sir, sorry, sir.
Have you been able to convince your pediatrician that they should refer you the case that early?
Yes, sir.
Okay, Gurmeet, please.
Nice presentation, Dr. Mane. One question is that the first ICD was removed within a mean of 1 to 2 days, and the second ICD was removed on 9th or 10th day. Dr. Mane, can you hear the question?
Yes, sir.
So
Yes, sir.
why was the
Yes, sir. Yes, sir.
why so much gap between the removal of the ICDs? And what was the mean hospital stay? I couldn't see because your net was not working properly.
So mean hospital stay was almost 14 to there were around till 30 days because one patient was having a prolonged air leak, so he stayed with us for a very long time.
And average day for removal of the second ICD was 9 days. So
9
your
days.
patient after the VATS was staying for around 10 to 30, I mean 2 weeks with you.
Yes, sir.
And what is the average day when you do an open thoracotomy and average stay for those patients?
Sir, if they are having non-resolution even after that, then we are only proceeding for thoracotomy, sir. But most of our patients, the symptoms were resolved, sir. So we have just waited for little longer time.
My question is that after doing a VATS, your
Yes.
patient is staying with you for 2 weeks.
Yes, sir.
Suppose you are doing an open thoracotomy. You have done open thoracotomies also in few patients. So
Yes.
what is the average duration they stay with you?
Sir,
It is
they
also
you
the
also
2 weeks or more than 2 weeks or less than 2 weeks. And what is your
sir, more than 2 weeks, sir.
more than 2 weeks? Because 2 weeks is a very long time. Next question, we may go to Dr. Tanmay. I think we are also running out of time. Yes.
Just one quick comment. I think what Dr. Prabhu sir and Dr. Gurmeet sir has said is probably around the idea that you have to monitor the number of days in the post-op period, or if you're going off a primary ICD versus a direct VATS and to a open thoracotomy approach, so that you can convince your pediatrician so that they can send the patient early, and probably you can intervene early and reduce the post-op time period for the patient. Thank you so much for your presentation.
Thank you.
Thank you, Dr. Mane. Can you please stop sharing your screen now? And Dr. Trishla Jain. Dr. Trishla Jain, can you please share your screen? Dr. Trishla?
Yes, sir. Share, sir. Is it visible, sir?
Yes, please put it on the slideshow mode and try running 1 or 2 slides.
It's not getting in a slideshow. Yes, sir.
Yes, try running 1 or 2 slides, please.
Yes, sir. Is it okay?
Yes, you can start from the beginning.
Okay. Good afternoon, everyone. Today I'll be presenting a case of breathless beginning and unusual thoracic tumor in a 4-month-old patient. So coming to our thoracic wall tumor, I would like to give a little introduction. Pediatric thoracic tumors are rare entity. Both are equally challenged to diagnose and to manage. So they comprise a heterogeneous group of neoplasm, which are finally classified on the basis of variety, location, presentation, biological behavior, treatment responses, and prognosis. Many tumors of thoracic walls are sporadic, accounting for 1 to 2% of all pediatric neoplasm, among which two-thirds of them are malignant. So before approaching to this case, we had two objectives in our mind. First was the complete tumor resection with a negative margin for bone and soft tissues, and second was the reconstruction to restore the proper ventilatory function, prevent deformities, and allow adequate mobility. With this, I would like to present you a case. So this was a case of a 4-month-old infant with history of persistent cough and episodes of respiratory distress since 1 month. Previously, patient was managed conservatively on a basis of a chest X-ray in an outside hospital, chest X-ray which was suggestive of pneumonia. When patient reported to us, we wanted to go ahead with a CT scan. CT was suggestive of solid heterogeneous thoracic mass measuring 6.2 into 5.2 into 6.6 centimeters, almost acquiring more than 50% of the lung space. With that, we were still not sure what kind of pathology we might be dealing with. So we went ahead with a true cut biopsy, which was suggestive of non-specific small round cell tumor. With this, we planned on managing operatively, and we had three differentials in our mind. One was Ewing sarcoma, second was hematoma, and third could be the aneurysmal bone cyst tumors. So on coming to the intraoperative finding, patient underwent the posterolateral thoracotomy and resection of tumor was done. Intraoperatively, we found that the mass was arising from the sixth rib and acquired more than 50% of the chest wall. And also there was a torrential bleeding. Intraoperatively, blood was transfused and mass was resected completely as shown in the picture. Along with that, we noticed that the mass was arising from the sixth rib. So with that, we removed the mass as well as the sixth rib. ICD was placed in the patient and PCB transfusion was done post-operatively in PICU. Patient stay in PICU was for 2 days and patient was discharged home on post-operatively day 7. Patient was put on supportive oxygen therapy for only 2 days and was maintaining without any supportive therapy as well. Patient was doing well in a follow-up for 1 year with a good weight gain and no recurrence in the next imaging. So patient I would like to go ahead with a post-op X-ray that we took. You can see that there has been done a resection of the sixth rib and one rib is the missing. Along the lung seems to be doing well. On histopathological, samples were sent. 2 samples were sent. Grossly, one was globular, well encapsulated, firm to hard mass, measuring 7.5 into 5.5 into 5 centimeter, and the cut surface of suggestive of large multiple cystic spaces with clotted blood. As I said, torrential bleeding was there, and a colloid-like homogeneous material with hemorrhage and area. No necrosis was seen on the gross specimen. Second specimen was an irregular fragment of bone, largest measuring 1.5 into 1 into 1 centimeter. Coming to the microscopic finding, as we need to differentiate between our differentials, benign neoplasm with numerous large to small cystic spaces were rimmed by osteocytes and osteoclast. The space containing hemorrhagic material, foamy macrophages, and multinucleated giant cells. The septate, which separate the spaces, and the stroma are composed of oval to spindle cells with a vesicular nuclei. No evidence of cartilaginous proliferation and chondroblastic foci was found. This point led us to differentiating our Ewing sarcoma. Coming to us. Evidence of presence of endothelial lining. With this, we differentiated Ewing sarcoma and hematoma both. Coming to the discussion, ABC tumors are mesenchymal fibroproliferative stroma. Usually, they are benign and affects the children and young adult. 1 in 1 lakh per year. Studies showed more than 80% lesions were long bones, flat bones, and spinal cord. As in our case, it was a rib. It is due to translocation between 16th and 17th chromosome leading to oncogenic activation. Radiologically, these are eccentric expansile lesion. As I said, since birth, only 4 months, the tumor became enclosing the entire thoracic cavity. Coming to conclusion, this case highlights the importance of early and accurate diagnosis of thoracic masses, especially when symptoms mimic common respiratory infections. Timely imaging, histopathological confirmation, and surgical intervention are crucial for it. And we believe if this had been caught a little earlier by other surgeon, then we would have had more time to manage this conservatively as well. In certain tumor cases, only option of is surgery. The risk needs to be taken, and intraoperative surgical innovative approach is required. This is a post-op image with the family and a follow-on of 1 year. Thank you.
I would now like to move to the judges for any discussion.
Trishla, thank you for this nice case. In fact, this is actually one of the cases that we see less frequently. So I'm sure you must have read about it and gone to the details. I was expecting you will tell us about the presence of the oncogenes. Are you aware that this genus, this tumor has some, tumor may not be the right word, this condition ABC has some very specific oncogenes associated. Have you looked into those genes?
No, sir. I haven't looked into that.
There's a USP something TRE17, the combination, the junction of that is taken as a. Are you muted, Trishla?
Audible?
Yes.
Yes, sir. TRE17 was taken into consideration, sir, but due to financial condition of the patient, we couldn't go ahead with that clinical testing. So that's why we did a true cut biopsy first. And on biopsy suspicions, we went ahead with a management plan for the surgery, sir.
So how much would be the cost of getting a TRE17 done on this child?
17,000, sir.
How much?
17,000, sir.
No, I think the cost, if you do a whole exome sequencing, it would be around 10,000. But if you do only a targeted sequencing for this particular gene, 2,500. It's not 17,000.
Right, sir. From our place, we have to send the sample to Bangalore and back and forth. So that entire thing cost around 17,000 to the patient. We did counsel the patient for it, sir, but they were not willing to go ahead with the investigations.
So suppose your patient was ready for this test. What exactly would be the test that you would want to do?
So then we would have been known about the ABC tumors beforehand, and we would have approached it in the same way, sir. We only wanted to know, since it was a huge mass, we thought.
नहीं, मैं ट्रिस्टा वही पूछ रहा हूँ, सपोज आपको पता होता डायग्नोसिस और पेशेंट अफोर्डिंग होता, तो आप कौन सा जेनेटिक टेस्ट कराते हैं इसमें? ठीक है, कोई बात नहीं, थैंक यू। तन्मय, गुरमीत, आप लोग पूछिए।
Thank you for the presentation, Trishla. I don't have any questions for you. Thank you.
Nice presentation, Dr. Trishla. I think we should move to next because time is over for the questions.
Thank you, sir. Now we are moving back to Dr. Preeti Ria Pinto. We could not have our presentation due to some technical glitch. Dr. Preeti, can we have your screen, please?
Yes, sir.
Can you please share your slides? The slides are not visible still.
Can we have a check on the audio as well? Otherwise, I think Rohit can present and she can.
This slide
audio is clear, sir?
Yes, it's clear now. Even the slides are clear. Can you try moving 1 or 2 slides back and forth? So that. Can you try? Yes.
Is it okay, sir?
Yes, it's okay. Just a second. Yes, we can start now.
Good afternoon, everyone. I'm Dr. Preeti. Today, let's look beyond these scars, scores, surgeries, and into the life of the children who are silently battling chronic pancreatitis. When we think of chronic pancreatitis, enzymes, the ducts, the pain scores, but in children, this does not just affect the pancreas, but it reshapes the entire world. Pain is not for days or weeks, but it is for years. Pain that keeps them away from school, steals their childhood. Some are even afraid to eat, thinking it would trigger an attack. Some are unable to play or attend class.
Dr. Preeti, we are still unable to hear.
So I'm audible.
Yes, you're audible now.
Preeti, you're not audible. Shall
Hello?
we try
Sir?
to?
Am I audible now, ma'am?
Yes, Preeti, but it keeps getting cut. Do you want us to present the slides so that you're only on audio so that the net would be better?
Logged on through another.
Now, if it's
Yeah, she's logged on through
Yes.
another.
Yes. Shall we start again?
Okay, ma'am. We can
Yeah.
start. We'll move to the first slide, Preeti.
I think we can later continue because you never know, the signal might be interrupted again.
Okay, sir.
Sure, sir.
Preeti, continue from here only. Aims and methods.
So a retrospective study was conducted at Annapurna College. Children less than 18 years of age, data was collected on the presenting symptoms, the frequency of pain episode, the type of intervention received, the recurrence, the nutritional status, and the school attendance, and the radiological findings. Follow-up for at least 12 months was done, and the descriptive analysis was done. The results that we found, 51% were male and 48% were female. Most of the patients presented with pain with the radiation in 44% of patients. And 44 patients had a nausea, vomiting with few high fever, steatorrhea, and GI bleed. And there was documented loss of school days, 16. Investigations was normal in 17%. Deranged LFT was seen in 28%, NA in 15%, and elevated amylase lipid 40% of the patients. Routine ultrasound abdomen was done, and CECT with MRCP and CT angiogram was advised in few patients for further evaluation. The common findings that we found in radiological investigations were atrophic or bulky pancreas with the calculus, pseudocyst, and calcifications. All the patients underwent conservative management, among which 19 patients had recurrence. In that, 7 underwent celiac plexus block, and the rest 12 underwent management. Among the surgical category, 3 had recurrence, who in turn underwent celiac plexus block. Whereas in the celiac category, 3 had recurrence, 2 underwent repeat celiac block, and 1 underwent surgical management. So the inpatient surgery, where the obstructions in the duct or intractable. The procedures that I found in the study were the phrase procedure, cystogastroscopy, Puster's pancreaticogenoscopy. Aneurysm cases, they had to undergo gastroduodenal artery stent and splenic artery aneurysm like it. The other category was the celiac plexus block, indication being non-obstructive causes, surgical, non-surgical candidates, and in case of refractory pain. This was the guidance. This is minimally invasive, but it is not curative. But the quality of life is still stay and the expenses are reduced. There was a study which was conducted in an institution based on that was iotic approach. Based on that, 11 children, among the 11 children, 10 had symptomatic pain relief, whereas 1 had relapse of pain. So this is the image where we can see the celiac plexus block being given between the T12 and the L1 vertebra. So based on my study, I found that the celiac plexus block had a shorter duration of hospital stay with the minimally invasive and cost effective, but repeated interventions and surgery was required in case the celiac plexus block had failed. Whereas in surgical intervention, the long-term favorable outcome was good. Am I audible?
Yes, Preeti.
Yeah. There was a longer duration of hospital stay with increased financial burden in the surgical intervention. So though celiac plexus block gives a good pain relief and quality of life, still surgery is the gold standard wherever it is indicated. So what on this study? The chronic pancreatitis is an irreversible change which affects not only the growth but also the quality of life. Hence, the burden is not on the patient, whereas the education, the family, and the finance is also affected. The focus should not be just treating the symptoms, but we should focus on restoring the childhood with a healthy living and joyful learning. Hence, early diagnosis and timely surgical intervention can reduce the pain, improve the nutrition, and hospital and what is the role of the pediatric surgeon is their deep expertise in the pediatric anatomy and the disease biology, which helps them to provide the surgical solutions that which focuses on the pain relief and also the healthy development. So take home message is in pediatric surgery, every incident and decision matters, shaping not just the organs, but a child's whole future is important. Thank you.
Thank you. I would like to move to the judges for the discussion part.
Thank you, dear. So, Preeti, I congratulate you for this presentation.
Thank you, sir.
One basic question I'm asking everyone. So, although you tried to summarize in the last slide, but still, as far as the management of chronic pancreatitis is concerned, what is that single message which you want to convey to the audience, which is different from what has been proposed or being followed in literature?
Sir, what I found in my studies, most of the patients had undergone conservative management. Many had recovered from the pain, had got back to school. They had a significant improvement, but few patients did not have improvement. Then based on the cost effectiveness or the duration of hospital stay, based on the tertiary center availability, we can either go for the celiac plexus block where the duration is less, cost is less, and also the recovery is earlier. Whereas in surgery, the duration of hospital stay and the recovery is more. But in my study, I found that few celiac plexus block had to undergo surgical management since they had recurrence, but under few surgical categories also had to undergo celiac plexus block. So it is upon the surgeon and the individual patient findings that we can proceed either to go with the surgical category or the celiac plexus block. So I think we should consider even the celiac plexus block as a management, not just focusing on the surgery, because ultimately it is the child's growth and the schooling and everything that is hindering the growth. So we should focus on that also.
So, what are the various therapeutic agents which can use for the celiac plexus block?
Celiac plexus block, initially a local anesthetic is given
No, what are
to
the other
reduce the
ones? What are
pain.
those
You can use the
other agents than those what
absolute
available?
alcohol, sir, which helps in neurolysis. Ideally, 50 to 100% percentage of the alcohol can be used.
One more agent, please.
Phenol, sir.
Sorry, I can't see you, Preeti. But anyway, one more agent.
Sir, am I audible?
Yes. Any other agent that you want to mention here?
So some of them use phenol also as the agent, sir. 6 to 10% of the phenol.
Phenol की safety बच्चों में, what are the recommendations for the use of phenol in children?
I'm not aware of it, sir.
No problem. Well presented. Tanmay, you're there?
Yeah, I think we are out of time, sir. But kudos to Preeti that in spite of so many hiccups, she still went on with the presentation and finished it. Good to see the enthusiasm. Thank you for presenting a really nice paper.
Great presentation, Dr. Preeti. One question from my side. What was the minimum age of the child that you had given the celiac access block? And what was the agent that you, in your department, you use for this block?
So in our department, we used absolute alcohol, sir.
Okay. And
The
what was the
minimum
minimum age?
2 years, sir. In my study, I found 2-year-old was the least age, sir.
Okay. Thank you.
Thank you, sir.
Thank you, sir. We have come to the end of this session 4 now. I would like to thank all the participants for such informative presentations. Now, I would like to invite the judges for the closing remark on the session.
I will let Gurmeet and Tanmay take the closing remarks.
Thank you, sir. I think it was a great presentation by all the presenters who have presented today. I was with the session right away from the beginning, and it was a great opportunity to see such a young junior residents from these broad specialities and few of the senior residents from pediatric neonatology. They were presented here, and this shows how a conglomerate of all the specialities can do to our kids that we used to treat. And we would like to thank IAPS for organizing such an events. I have one message for the participants that while making the slides, you have to use the title slide for 32 font size of 32 and more. The body should be of 24 or more. Adequate space should be between the slides, and try to use the sans serif format when you are preparing your slides. And as Prabhuth sir was asking, you must also include a slide in the conclusion that should include a take home message for this presentation. And there were hitches and glitches while the presentations. I think the reason for that was most of the time it is the internet availability. And one thing I would like to suggest all the participants that whenever you are presenting on the Zoom, try to refresh the app before your presentation, or you may remove the cache files that are in your computer that cause the hindrance or the slow down the speed of your internet and your presentations. Thank you, sir, and thank you, IAPS, for organizing such a great event. Thank you.
Tanmay, sir.
Yeah, thank you so much for this wonderful session. It was really great to hear all the young participants, showing some interest in lots of typical cases of pediatric surgery. I do understand there were some questions which may have needed a detailed reading, but then the amount of enthusiasm all the participants had shown to try and go through the literature and come up all prepared for the questions was really heartening to see. And it's a great initiative. The idea is, to overall become inclusive to all the allied specialties and the super specialties in a way that we can come up for a better care for the children, and to at the same time to develop some curiosity in the light branches. And I think the best way ahead is to collaborate. Thank you so much for all the presentation. Best wishes to all of you.
Thank you, sir. I would now like to hand over the floor to Dr. Evangeline ma'am for concluding the session.
Yeah. Thank you, Rohit. So it's been an amazing session today, full of energies and ideas and inspiration. I know I am inspired, so I hope all of you feel the same. A very big thanks to all our presenters, mentors, and attendees for keeping it special. And let's keep the spirit of IAPS alive as we move forward into the conference that we are awaiting in the next 3 weeks. It's been great to see an ever-increasing interest in the field of pediatric surgery, and I hope that many youngsters from today are inspired from today's sessions to take up pediatric surgery as their career choice, because it's really worth it. And I think today it's been a real testament to the fact. So for my vote of thanks, I would like to first thank the team at IAPS, especially Professor Biswas and Professor Vikesh for initiating and allowing this program to grow and blossom into such a big event. I also thank my co-moderators, Dr. Varsha, Dr. Supraja, and Dr. Rohit, who have helped to make this a smooth event today. And last but not least, thank you to all the presenters today who've shown their caliber and poise through their presentation and clarity of thought. Thank you. May all of you have a great Sunday ahead. Thank you.
Thank you, everyone.
Thank you, everybody.